Thank you. What an attentive group you are. Good morning, everyone, and happy first day of spring, I'm told. Let's see. Good morning. The meeting will now come to order. And a note that this meeting is being recorded, and we will start with a roll call.
Good morning. Joan Allen.
Present.
Thank you. And a reminder, speak into your microphone, please, and press the button so that the light is green. Barry Arbuckle.
Present.
Eliza Arjoyan. Stephanie Klein. Great. Carmen Comsty. Adam Daugherty.
Present.
Parker Duncan Diaz. Hector Flores. Sarah Gavin.
Present.
Stacy Rontas. David Joyner.
Present.
Ivana Krasinovic. Tam Ma. Carolyn Nava. Present. Mike O'Day.
Present.
Thank you. Janice O'Malley.
Present.
Sumana Reddy.
Present.
Yolanda Richardson. Karen Savage Sangwan.
Present.
Andrew C.
Present.
Sarah Sorokin.
Present.
Thank you. Ken Stewart.
Present.
Suzanne Usage.
Present.
Yvonne Wagner. Renee Williams. Anthony Wright.
Good morning.
Abby Yant.
Present.
Thank you.
Thank you very much. And with that, we have a record of who is in attendance, and we do have a few folks who are joining virtually. Also joining virtually is our attending board member. As you know, at every advisory committee meeting, we have at least one OCA board member present. So David Carlisle is attending virtually, and we appreciate Dr. Carlisle listening to the presentations and discussions. Good morning, Dr. Carlisle.
And we note that Sarah Sorokin is attending virtually, but is having difficulty with her camera, so she will be attending with her camera off today.
Thanks very much, Jane. What, Megan? She has her camera on. Terrific. Wonderful. So we see some of our board members, our advisory committee members, as well as David Carlisle. Good morning, all. Our co-facilitator, Jane Harrington, is here today to help facilitate our meeting and public comment, and we are thankful for that. So in terms of the agenda for today, we have the slide of the agenda up. So after a few executive updates from myself and from Vishal Pagani, we will spend the morning talking about the proposed spending growth targets and some related follow-up items that we've had requests to discuss. We've received a number of comments about Medi-Cal requirements. We had a lot of comments at our February board meeting about Medi-Cal and how OCA and Medi-Cal rate setting and Medi-Cal supplemental payments and other complexities interrelate. So we have spent some time with Department of Healthcare Services and wanted to present some initial thinking about Medi-Cal spending and additionally some about Medicare as well. We also have slides summarizing the very extensive feedback we got on the proposed spending growth target. So as you know, the office proposed our methodology and value in January, which kicked off a 45-day comment period, which ended on March 11th, last Monday. And we got over 220, I believe 224 or 25 comments from individuals, all of which are posted on our webpage. Very extensive, and the staff did an incredible job of summarizing those. So we will go through summarizing the feedback that we got, as well as hearing from you all, which is important to hear from the advisory committee. Then this afternoon, we'll have presentations on the workforce stability standards that the office has to develop, as well as our primary care investment, and we look forward to your feedback on those areas. Then we'll discuss an approach to collecting data on spending consumers do outside of their plans. So it's something that has come up a lot among our board, and you all raised at our first advisory committee meeting. Part of total healthcare expenditure costs is to capture consumer copays, deductibles, other cost sharing. But as you rightly noted, there are plenty of things that consumers pay out of pocket, and how are we capturing that? So look forward to hearing from the staff about the sources we've identified there on out-of-pocket spending. And then we look forward to hearing from Barry Arbuckle about a cost reducing strategy, and appreciate his willingness to do that presentation. So we have a full day together ahead of us. So turning to the executive updates, and I'm going to keep my executive updates relatively brief. But last month was Black History Month, and we have posted on our slides HCI's Black Liberation Statement. So HCI has a racial equity team. We have a general equity statement. We have a land acknowledgement that I noted in our fall meeting, and with it being Black History Month last month, we wanted to highlight our Black Liberation Statement. We think it's important to focus on equity broadly, but also to have particularized looks at sort of the two original sins of our country's forming, both around the land acknowledgement and noting what has happened in our history as it relates to Native Americans, as well as our African American members of our community. So I encourage you to read it. I'm not going to read the statement out loud this morning, but equity is at the core of HCI's mission, and we believe it is a foundational step in furthering equity to acknowledge our long history of intentional inequities, to name the violence and the racism that has been perpetuated on Blacks and African Americans that underlies the health disparities that persist to this day. We also think it is important to celebrate Black culture and the incredible resilience of Black communities. An especially troubling area in terms of health inequities is Black maternal health. Black birthing people in California experience pregnancy-related mortality at 3 to 4 times the rate of other racial and ethnic groups, which really is a staggering number. And there's also a rate of severe maternal morbidity among Black women, which increased dramatically in recent years. So unfortunately, this is not an area that's necessarily getting better. The California Department of Public Health's report, Centering Black Mothers in California, states that the preterm birth rate among Black infants did not improve between 2011 and 2019, while the Black mortality rate among Black infants in California declined over the past decade. In 2018, Black infants were still twice as likely as other infants to die before their first birthday. These deeply troubling statistics highlight the deep equity divide entrenched in California's healthcare system, as well as structural racism that impacts Black maternal and infant health. So we think it's important to note those, as well as to note some of the strategies that we at HCI, and I'm sure many others that you all are working on to address these issues. So one strategy that HCI is using to address these health disparities is to diversify the healthcare workforce. We know that a healthcare workforce that's more reflective of California's diversity results in better health outcomes. So we have programs supporting doctors and nurses, community health workers, midwives. It's really wonderful to see the recognition of the impact that doulas can play, and we were gratified to hear about some of the doula efforts in California. In addition to worse health outcomes, we know that Black Californians suffer disproportionately from medical debt and are more likely to skip needed care due to cost. So we know that affordability is a fundamental access issue and an equity issue. So just wanted to ground our work this morning with that note. So in terms of additional HCI program updates, I think you all are particularly interested in hearing about our healthcare payments data program, our HPD. So on March 1st, as we were required to do, HCI submitted a report to the California legislature on our HPD program, focusing on several areas, including the completeness and quality of data included in the database. So the report is available on our website. And it includes some findings that I wanted to highlight as well as some next steps. The HPD system does reflect approximately 82% of Californians and their healthcare services. So as you know, we don't have access to all of the data about self-insured plans, but we do have very significant data, and we have some findings about the percentage of self-insured employers about which we are collecting data. Efforts are also underway to expand the HPD to include data from dental plans. Currently, it's only collecting data from health plans. We're also working to capture capitation payments and other non-claims payment data. And as you know, OCA and our HPD program are working hand in hand to develop that non-claims payment data approach. The HPD program's public reporting and data release functions have been successful and continue to evolve, so we are proud of that. And then my last update is on our next slide. Last but not least, in February, Governor Newsom's 4 appointees to our Healthcare Affordability Board, Elizabeth Mitchell, Sandra Hernandez, David Carlisle, and Rick Kroenig, appeared before the Senate Rules Committee, where we had a robust discussion about OCA and the work of the board, and they have been confirmed by the Senate. So we congratulate them on that and thank them for their service. So with that, I will turn it over to Deputy Director Pagani.
Thank you, Director Landsberg. So I'll be providing an update on the total healthcare expenditures regulations. I'm pleased to announce that OCA's THCE data collection emergency regulations were approved by the Office of Administrative Law on March 4th and became effective immediately for a period of 5 years. I'd like to thank OCA staff and all of you who provided written comments, participated in the THCE regulations workshop, and provided comment at our various meetings to help us get this package over the finish line. Data collection is a first step in our efforts to bend the healthcare cost curve and make healthcare more affordable. And then for the advisory committee member selection process, I'd like to remind everyone that OCA is accepting submissions of interest to serve as a member of the committee. We have a link on our website, and then we've also emailed our listserv. So for those of you that are interested, we recommend completing an interest form. The term for these appointments will begin on July 1st of 2024 and last through June 30th, 2026, so effectively a 2-year term. Please email our inbox at oca@hci.ca.gov if you have any questions. And then next, as we do at every meeting, I'd like to remind the committee about our slide formatting key. We use a blue arrow in the presentation for areas that the advisory committee provides input or recommendations on based on statute, and other areas as requested by the board or OCA. And now I'll provide some updates related to the California Healthcare Foundation NORC California Health Policy Survey. This is a new question in the 2024 survey. And the responses show that due to high costs, Californians are accumulating more and more medical debt. This trend is significantly worse for Black and Latinx consumers, as shown in the orange and gray bars. Next slide. In addition to impacting the healthcare of Californians, the high cost of healthcare is contributing to personal bankruptcy in California and across the nation. There was an increase in Californians reporting medical debt from 36% in 2022 to 38% in 2023. More Californians now report having trouble paying medical bills, from 1 out of 10 in the 22 survey to now 2 out of 10 in the 23 survey. Next slide. As the slide shows, medical debt is more prevalent in communities of color compared to white communities. There was an increase in Black consumers reporting medical debt from 48% in 2022 to 53% in 2023. Next slide. I'll now turn it back over to Jane for advisory committee discussion.
Any discussion from the committee?
David Joyner, please go ahead.
Just wanted to make a point that, obviously the medical debt is a horrible situation and it's a growing problem. I think that a lot of focus on this issue is the cost of healthcare, which is a major driver of that. But the other thing not talked about very much is the rise in high deductible plan designs that put more burden on patients, members. And so I think both need to be considered as we think about this problem. The relatively rich HMO benefits that were the majority of benefits, say 20 years ago, have slowly declined, and PPOs with high deductibles have become much more common. I think that's the other factor that has driven this, not just the rising cost of healthcare. So just wanted to mention that.
Adam?
I was going to make that point as well. I think, particularly when we're thinking about our performance targets and external factors, none of this is in a vacuum. And with the erosion of employer-sponsored healthcare, high deductible plans, egregious payer techniques of pushing provider contracts out of market, thereby shifting costs to the consumers, increases the costs. And, techniques even from the provider side, whether it's burdens of prior authorization or prepayment review processes that inhibit that flow of care, have real costs and real health impacts for our patients on the back end. And I think it's important to understand that, those bodies are not being held accountable by, be it DMHC or DOI or others. And, when we think about particularly expanding Medi-Cal and Medi-Cal managed care, holding those players accountable in a way that we haven't before, looking at those narrow networks, those narrow specialty referral processes, and understanding that that has maybe an even bigger impact on affordability than what we are going to be discussing today as far as performance targets, let alone, I know it's a little bit of a broken record around all the, duplicative services and administrative glut, whether it's for compliance or, regulatory, processes within systems that do not actually impact patient care or improve access or quality. We need to continue to harp on those things.
Thank you. We'll go to Joan Allen and then Sarah Sorokin attending virtually after that.
I'd like to second Adam's concern about the Medi-Cal managed care plans and ensuring that we are, through this process, holding them accountable to the same standards that we are for commercial health plans, and making sure that those networks, particularly for specialty care, aren't damaging access and driving care to higher cost settings. Completely agree there. Completely agree that high deductible plans are one of the places where consumers really see the pain of high healthcare costs. but also see it as a yes and in terms of how we think about the solutions. Even if we just addressed plan design, that does not get us to the sort of affordability and bending the cost curve that we're here to do. So agree with both Adam and David that that is an aspect we need to address. But if we aren't also addressing the underlying cost, then we'll only get part of the way there. But when we get to the section on managed care plans, would like some better understanding on the Medi-Cal managed care plans, and would like a fair amount of robust discussion around that when we get there.
Thank you. Moving virtually to Sarah Sorokin, committee member. Go ahead.
Speaking of patients having to access higher levels of care because they can't access appropriate lower levels of care, and that ends up increasing their cost burden. For example, one common scenario while working at Kaiser was having to refer patients to the emergency department for an urgent concern instead of having urgent appointments available. And the other thought that I had is I'm wondering how much out-of-pocket spend factors into medical debt. Are people who have medical debt, are they also constrained by their finances, constrained by having to spend out of pocket on needed care, like in mental health? And I wonder how that contributes to then their ability to pay the medical bills that they do get from their insurance company.
Thank you. Going to Carmen and then Anthony Wright.
Hi. I think, one of the things that both Adam and Joan kind of pointed out, which I was thinking about, as well as Sarah, which is why this is important to us is because of the particularly what is being paid for. We know that medical debt is rising for patients across California, but what's really important here is trying to figure out what's actually happening and what are they paying for, particularly when you're looking at Medi-Cal managed care plans. Is it actually going to care? And I think that's one of the things when we're looking at the cost of healthcare and affordability for patients is there some way that we can look at, is medical debt rising, but then the actual care that is being provided to patients, is that subsequently, I think we all intuitively know this, that it's not getting better for patients, but having some way of actually capturing that and figuring out where this increase in medical debt is being actually placed into, because we're paying more and getting less, and trying to quantify that is, I think, really important, and trying to figure out where this is happening, particularly when we're talking about Medi-Cal managed care plans, where there is more costs being associated with these plans, and profiting off of patients, but then care not being received. So I think this is a really important conversation. And then also the thing that we haven't kind of really addressed here, which is that this is happening disproportionately to communities of color, and how we can figure out what is happening there and why that is happening is really important.
Anthony Wright.
Yeah, Anthony Wright from Health Access. Appreciate this conversation. This underlines for us why the conversation later on tracking out-of-pocket spending and consumer affordability is so important, because the Massachusetts example, which we look to in this at this body, was very positive in some regards, but the experience there was that even while the overall spend was going down. There was increases in deductibles and everything in Massachusetts, and so like now the advocates there trying to figure out, okay, how do we relook at some of these questions of what is driving the specific costs that people are experiencing, and so I think that needs to be part of the factor. I also just, we're very concerned about the rise of high deductible plans. I think and I don't think this is in a vacuum. I think the Office of Healthcare Affordability's efforts are alongside other initiatives that we're doing in this state, like, in Covered California to zero out deductibles and other work that we're really proud of. And hopefully that will have an impact as well. But we also recognize that while subsidies are needed for a very large part of our population, because healthcare is darn expensive, we can't subsidize our way out of the problem. And so while in some instances we want to actually even subsidize the health system, the industry, to make sure that people are protected from medical debt, from high deductibles, we can't do that without the sort of then to look at the base costs as well. So that yes and thing is as I think reflected. But I absolutely agree with the concept that OCA is not the only effort in this. It's alongside the efforts at expanding coverage and providing people assistance. But then it actually makes it more important because we can't just use that strategy only. And so the holistic approach that hopefully we take is going to be really important. But I appreciate the staff raising these things, especially in the context of the conversations we'll have later, especially on consumer affordability.
Janice O'Malley.
Yeah, I'd like to echo the comments made by Joan, Carmen, and Anthony, and just really appreciate these beginning slides with these statistics on healthcare affordability. But I think it really helps center this conversation because it's so important to understand that these aren't just statistics, these are people's lives, right? And when people can't afford the cost of healthcare, they can't afford to pay their deductibles, it has a domino effect. And I really hope the conversation today, as we start talking about the workforce, the people that help deliver these services that we all rely on, that we center back to this information about how we are failing people of color, we are failing people in this state, and being able to provide their basic needs of good health. And so I just, again, really appreciate it and hope we can have a really productive conversation about affordability.
Thank you. Looking back virtually, Hector Flores, go ahead.
Thank you. I apologize. I had technical difficulties getting on early in the call, but I wanted to echo David Joyner's comments about the high deductible plans, and all of that reflects the cost shifting that providers are doing, basically saying Medicare and Medi-Cal don't pay us what we need to be profitable or to operate successfully. So we're going to maximize commercial insurance, and that's a cost shift. And employers have gotten smart, and sadly, they're pushing that cost shift to their workers and their families. So we're starting to see health plans working with the employers and saying, we'll give you a lower premium structure if the delta is paid for by the employee through out-of-pocket contribution to premium, as well as those high deductibles and copays. So it really has an adverse effect on the individuals, and it also may end up confounding our ability to gather data, because what we're seeing when patients have a high deductible plan, they're often going, for example, here in Los Angeles, they're going to Mexico to get services, which they pay cash, and that will never get registered through this cost analysis that we're doing. So it is a really important point. It's part of the cost shift that we need to account for. And sadly, the shift is happening to the employees and their families. Thank you.
Let's move to Ken Stewart and then Carolyn Nava.
Okay, this is a great discussion, but in addition to the cost concept, I think we should not lose sight of the fact that what drives the costs, and that's utilization and the the services that are being rendered, and hopefully through the HPD, we'll be able to ultimately better identify the higher quality, more appropriate providers, and eliminating the fraud, waste, and abuse in the system, I think will go further to reducing costs than spending controls.
Carolyn Nava?
Thank you. I just want to echo really both of those comments. One about the high deductibles that's passed on now to the commercial level, because yes, we already know that if you qualify to receive, the Medi-Cal plans, that's because you're lower income and there's support for that. But you have this huge cross section of middle income America, me being one of them, and I'll just use myself as an example at this table to emphasize how grave it is. I do have private insurance through my employer, but because of the high deductible, oftentimes a lot of the care that I require comes out of pocket. Right now, my medical costs out of pocket for my family run on average about $2,300 a month. That's in addition to insurance and copays. Now, maybe I'm not your typical example, but I also don't think I'm the only one out there with that kind of expenditure. And I'm grateful to be at this table and to be able to tell a real story and to help emphasize why we need to do exactly like Mr. Stewart is emphasizing. There's layers of this, onion layers, that we really want to pull apart and understand not just the disparities, because there's all the the labels going around, inclusion, disparity, equity. We can't even get to those discussions, really, unless we look at this from the onion layer of why are things truly costing so much, where might there be fraud or elements that we can immediately address to eliminate some of those high costs, and how do we bring this up the channels to that 60,000 foot level, because this isn't all going to happen in California. This is going to go up the chain and go up into federal legislation, go up into nationwide changes. And I think we'd be remiss not to start looking at things a lot more deeply on these layers.
Thank you. Thank you for the discussion from the committee. I think we're going to move into some of our agendized items to continue this important discussion. At this time, we'd like to take public comment on the executive updates. So we'll now recognize members of the public for comment on the executive update agenda item. Please reserve comments on other items for the general public comment period. To ensure equitable access to public comment, we will alternate between members of public present in this room and those attending virtually. Those in the room may line up at the podium. Those attending virtually can raise your hand. If you're dialing into this meeting on the conference line and you would like to provide public comment, we ask that you submit your comments via email, or please join this meeting online if you would like to make verbal public comment. If possible, please keep your comments to 2 minutes or less so that we can hear from as many people as possible. Please note that while the committee is committed to communication and transparency, committee members and staff will not be responding to public comment. Additionally, the committee may not discuss or act on any matter raised during public comment that is not included in the agenda. Looking to the room for individuals lined up at the podium, seeing none. Looking online for any individuals with their hands raised, seeing none. That concludes public comment on this agenda item.
So I'll be covering this agenda item along with Assistant Deputy Director CJ Howard. And we also have Michael Dalet attending remotely in case any questions come up. Next slide. And then one more. Okay. So, we've shown this slide a few times as a reminder. As many of you know, our 45-day comment period closed on March 11th. The board will not be acting on the target this month, but it could be April or, and the last opportunity would be the May meeting. And the final target could align with OCA's recommendation or be another value as determined by the board. And then for reference, on the next slide, we've included our proposal for a 3% statewide spending target for a 5-year period of 2025 to 2029. And then moving on to the next slide, just want to discuss assessing performance against the statewide target. This slide lays out the 3 phases of spending target implementation. The first in that light green box is to set its target value. To date, the target setting methodology discussions have been rooted in consumer affordability. Along the lines of what I spoke to earlier, a statewide target cannot uniformly account for circumstances impacting each entity's performance against the target. The next, the dark green box is the second step, which is assessing performance. OCA will assess each entity's performance against the target. During this phase, OCA can consider circumstances that may have impacted an entity's performance. And the third step, that light green box, is progressive enforcement. The details on how progressive enforcement works will be an area of future board discussion and public engagement. As a reminder, the components include technical assistance, public testimony at a public meeting of the board, performance improvement plans, and as a last resort, financial penalties. For today, we want to focus on that middle green box of assessing entity performance against a statewide target. We'll begin by covering what's in the enabling legislation, and we'll also want to get the board's input on additional reasonable factors that may impact entity performance against the target. A key reason for why we want to have this discussion today, if you could just go back one more. Many of you have raised factors or drivers of spending growth, such as the high cost of specialty drugs, as an example. And those are, factors that should be given attention. But we think there's an appropriate place for them, which is in this middle box of assessing performance, rather than the first box, which is the target setting. Today we're going to be discussing some of those factors that OCA can consider that could mitigate, steps in the progressive enforcement process. So in the next slide, we'll cover portions of section 127.502.5, which is the relevant health and safety code pertaining to healthcare spending targets and enforcement. I'm drawing your attention to the language we bolded, which states the director shall consider each entity's contribution to cost growth in excess of the applicable target and any actions by the entity that have eroded or are likely to erode access, quality, equity, or workforce stability, factors that contribute to spending in excess of the applicable target, and the extent to which each entity has control over the applicable components of its cost target. In the next slide, the rest of the language from this section summarizes the progressive nature of OCA's enforcement approach. And then in the next slide, we've heard from the board and the public about potential factors that should be considered when assessing an entity's performance against a target. These factors may contextualize an entity's spending growth, as well as mitigate steps in the progressive enforcement process. Some of the potential factors that have been surfaced to OCA by the board, the advisory committee, and stakeholders, as well as some factors that are described in the statute, include changes in state law that impact healthcare costs, changes in Medicare and Medi-Cal reimbursement, investments to improve care and reduce future costs, and then catastrophic events is another example. And then we have also received a lot of feedback on high cost, high value pharmaceuticals, such as physician administered drugs, and then the cost of labor, and then a few others that have been at our last board meeting that we've reflected here are annual changes in age and sex of the entity's population, which could happen if a provider group enters into a new contract with an employer group that fundamentally shifts kind of the population they take care of. So we've included these factors here. And today we want to have a discussion with you all if there's additional reasonable factors that may impact entity performance against the target.
If there's anyone who can't get into the meeting, please send an email to OHCA, OHCA at hcai.ca.gov. Thank you, and we apologize for the difficulty.
And I'll turn it back over to you, to the facilitator.
All right, so looking for committee discussion on the current slide. Going first to Sarah Schroken, who has her hand raised virtually. Sarah, go ahead.
Maybe this is a different subject, but does this include, so there's things that impact a healthcare entity and their costs, but how about things, other things that can reduce their costs? Like, I'm assuming both of those are being looked at, like, let's say a more efficient staffing model where management is, the managerial level is most efficient to prioritize direct care provider staff. And so, yeah, so I'm just wondering if both factors are being included, those that increase costs and those that decrease costs, because those can kind of balance each other out, I'm thinking.
Thank you. Going back into the room to Ivana.
You set me up perfectly. I have an example. So we do our own claims, so we have our own data. And we were recently looking at some of our drug spend in our medical benefit. And we came across this drug, aloxitine, which is a chemotherapy drug used to treat advanced cancer, colorectal cancer, colorectal cancer, right? And it lost, in 2012, Sanofi lost its patent. This drug had been steadily increasing in price until 2012, and then it plummeted. There was like a 99% decrease everywhere except for, where do you suppose I'm going to talk about? So at Salinas Valley, and this was in 2012. So last year we had a patient who had 12 infusions of this drug. The Medicare would have paid $185 total for this drug. That's how cheap it's become. For the 12 infusions, $185. We paid, and Blue Cross Blue Shield approved, a payment of $89,371. Like, you can't even really calculate what percentage of Medicare this is anymore. It's like 84,000 percentage of Medicare. So when I sit in these meetings and I hear people talk about the increasing price of drugs, there are drugs prices that are going the other way as well. And okay, it might take a while to reprogram, but it's been more than 10 years since this drug lost the patent. And that, so I just am concerned that, people are going to come with these latest, blockbuster drugs. We also have to be paying attention to the drugs that are losing patents and are coming down in cost.
Thank you. Andrew C. and then David Joyner.
Yeah, so I think one potential factor, and we've talked about it earlier, is really around the changes in plan design, right? Deductibles and such. That actually does impact utilization patterns. So, I guess as we look at how, the actual values of the designs change, that's probably a factor. It goes the other way too, right? Sometimes there are mandates to, give free coverage to certain things, and that creates induced utilization. So I don't know if you can cover it under the statutory changes impacting healthcare costs, but it is a factor I think we should look at.
My comment is that personally, I don't like this approach because it feels like you're saying we're going to set a goal that we know doesn't include a bunch of known factors that will increase costs, and after the fact we're going to deal with them. And in my opinion, it's really important we set a goal that is achievable and grounded in good analysis and understanding of the market. And I think we all know that there are components that are in the healthcare costs that are going up faster than the rate of general inflation or household income. And I think the right approach, in my opinion, is to set a goal that includes adjustments for those known factors. I was just looking up actually another different example for a chemotherapy drug called Revlimid. And if you're an oncology practice in California, you don't get to negotiate a special price with Celgene, who's the manufacturer. But Celgene launched Revlimid in 2005, a price of $215 per pill. It now costs $763 per pill. No change in the drug whatsoever in its formulation in that time frame. So if you're an oncology practice, that's a cost that you can't negotiate because oncology practice can't negotiate a different price with Celgene. So I think we've got many examples like this where I think we know that healthcare providers and healthcare plans are going to be exposed to costs that are rising faster than 3%. And in my opinion, it's better to try to have a goal that tries to take account of those factors rather than have a goal that ignores many factors you've got on this list. And then you're going to deal with them provider by provider after the fact. I think that's an inefficient way, and I think it will undermine the credibility of the target. I think it's far better to have a target that's seen as very credible and achievable, and it adjusts for known factors. So I think behind that comes more credibility. So I'm not a fan of this approach, but it seems like you're moving in a different direction. But I just want to say my piece on this.
Thank you. Joan Allen, go ahead.
So I appreciate this list and feel like it's heading in a really useful direction. Do want to get a better understanding of how this list interacts with two slides earlier, where there's the list of from the statute of action. So cost, the director shall consider each entity's contribution to cost growth in excess of the applicable target and the erosion of access, quality, equity, and workforce stability. And whether those two slides are meant to interact or whether those lists are intended to be entirely separate. And if they're separate for the most part, when do we anticipate digging in on what those, what it means to erode access, what it means to erode quality?
Yeah, we could go. Yeah, we're at this slide. So it's actually go back. So it's really that factors that contribute to spending in excess is kind of why we listed those factors in the next two slides. But it is kind of part of this overall sentence, or considering each entity's contribution, and then as well as any actions they could have taken. I don't have like a clear answer to your question about how they interact, but it if an entity misses the target and they exceed it, and there's valid reasons, warranted factors, then we would take that into consideration. But if they complied with the target and they did it in a way that eroded access, then that's kind of a different scenario we'll look at. Yeah, yeah, I don't have a clear answer to your question, but just kind of the way we're thinking about it was focusing on the factors.
I appreciate that. It may be a topic for a future meeting, but digging in the same way that we are digging in on what are some of the factors at the entity level that may have led to exceeding the target. That feels like half of the puzzle, and this slide is the other half of the puzzle of let's look at access, quality, and all of those other metrics, and that this group could have a really good set of thoughts on what it would look like for an entity that's missing their target and is also doing so in a way that is impacting these factors. And so it just feels like the discussion is about just the list of on the slide 2 later, and it feels like we at some point should dig more into this.
All right, we need to pause for a technical note. We understand that Microsoft Teams platform is having difficulty with folks dialing in. So the dial in by telephone to the conference line option is not working. We've been asked to ask people to use the link to join the meeting virtually. All right, we'll continue with comments or discussion. Adam?
I mean, in the same vein as the previous two comments, I think a lot of this, what we're trying to get our heads around to make it applicable to this list is, the real incentives and motivations in the system, whether it's, the profit motive, the utilization motive, whether the entity is beholden to shareholder dividends as goal number one. That all has major downstream effects. I don't have to tell this group that. But thinking about how to circumvent those or pierce through those, whether it's, identifying those profit motives, whether it's, thinking about how the shell game is going to operate once these things go into place. Okay, we met their target, but, we were able to still satisfy our shareholders or our, executive bonus payment or, these kinds of things that are what are causing the increased costs in our system, things that are not directly impacting patient care. So, thinking more about risk adjustment, comparative effectiveness, the things that we do know can move the needle while simultaneously containing costs. I think we are missing the mark there.
Anthony?
So a couple of things. One is I appreciate the comment about looking at factors that could both go down and up. There are innovations and other things. AI is the flavor of the moment, but other things that will potentially lower costs. And one of the things I'm curious about is our system able that if there is savings generated from AI, for that to actually those savings to actually redound to the benefit of patients and payers. And so I would say that. I would say on the issue of, I appreciate the comment about, are there known, if some of these things are known, then how do you fact them before? I would say that there's some known and some unknown. I mean, there's certainly, we don't know if there will be a pandemic or a natural disaster kind of issue. But let's not even use that example. I would just say I was talking with one of our board members, Dr. Pan, about the notion that a hospital chain reports that their profits and costs were down in a given year, and that was bad because it was actually a light flu season, right? And so sort of the weird incentives that we currently have in our system, where like something that's demonstrably good is actually isn't reflected in the incentives in our healthcare system. And then, so if there is something where like we have a tough flu season, then that will be reflected across the industry. But then it would also be an opportunity to identify as a system, hey, what should we be doing about this like if everybody's indicating that, then how do we like address this and make this part of our strategy for reducing costs that helps everybody get to that? At the same time, if there is I will also say that even for some known things, like if there is a rash of asthma in the Central Valley, uptick in asthma in the Central Valley or something like that, I think that there is a hope for innovation in how providers respond to that, right? Like that there's one way to deal with asthma, which is just to have people cycle through the emergency room in the least efficient way possible, and then there's a variety of upstream strategies that could be used. And my hope is that this spurs the innovation about, okay, here are some conditions that we are living with, and different providers will compete to actually be to figure out what is the best value response to that could mean upstream in terms of even managing the asthma, or even further up in terms of the environmental conditions. So I hope that so that's why I do think that there is some benefit in having the look back, as that we can't predict everything, and even for the stuff we can predict, we can respond to it in different ways, and that's, I think, the value of this approach. But I and I think that's so I'll just say that, and in terms of this approach. But I would continue to look at. So I think that so I think that one way to look at this list is also like what are factors that are appropriate, are things that affect the whole system or at least the whole region, versus ones where there might be differences, and we could actually learn from our perch and from the board's perch of, okay, looking at the holistic way, can we then incentivize benefit? Because the point of this is not to get to the fines. The point of this is to get to an improved healthcare system, and I think that's the spirit which this should be taken. And I hope that is. And I think that the progressive enforcement sort of suggests that that's what we're trying to get to, rather than to a conversation about penalties. This is about identifying what's the problem and then getting to it.
Thank you. So going next virtually to Sarah, and then Hector, and then back into the room to Andrew and David. Sarah, go ahead.
So kind of building on what many others have been saying. So like even if an entity meets the target or has a valid reason not to meet it, will there still be focus on looking at these actual known systemic issues that are keeping costs high, like, for example, in the mental health sector, lack of access to lower levels of care, which ends up meaning more people are needing to access higher levels of care. And this is just a reality. And, you know, in terms of solutions, that's probably another conversation. But like, for example, the population of therapists and mental health providers in private practice taking private pay, what would it take for them to feel like working within a system providing care, public or private industry, would be worthwhile, would be good working conditions for them. And even I'm thinking, there's been, I forgot the name of the Senate bill, but there's a Senate bill that most counties chose to delay by a year or two, about including people with severe substance use disorders as those that can be placed on a 5150 if they are considered gravely disabled, or I believe a danger to self or others as well. And the idea that if we have systemic issues in our substance use and mental health delivery systems where lower levels of care are not invested in, then we really are setting ourselves up for, well, maintaining the suffering and the increased disability and increased comorbidities that the current system enables, but much higher costs once, for example, that most counties have to start complying with that Senate bill. Thank you.
Thank you, Hector. Go ahead.
Thank you. Just want to piggyback on Sarah's comment. Actually, one of the bullets, I think the third from the bottom, is talking about organized labor, and it's important to note that we're seeing more and more physicians now organizing. And I think all of us have seen the Cedars-Sinai anesthesia group electing to have the Union of American Physicians and Dentists represent them. So I think we're going to see more of that. We need to track that. But the other thing, the broader issue, is that our success as a state in covering people, this year we will achieve universal coverage of all low-income families, including undocumented individuals, reducing our uninsured to about 3% in the state. So it's a applaudable accomplishment, but it's also exposed the critical shortage of the workforce, not only physician, but also other advanced practice clinicians. And that is, I think, a crucial issue we need to track. It's not just primary care, but it's also specialty. For example, my hospital system, Adventist Health, acquired a small hospital, and this is the good side of M&A, is it saved a hospital called previously Beverly Hospital, now called Montebello Adventist Health, in the community of Montebello. And that hospital plays a critical role in that community. But we're having trouble attracting specialists to rebuild the services that are needed for Beverly Hospital, now called Montebello, to come back to its previous efficiency. And this really speaks to this, that when that hospital fails to attract specialists to support the inpatient care that the community enjoyed for many years, we're going to need to resort to more expensive locales. And as Sarah was saying, sometimes we have no option except to use a very expensive tool because the lower cost alternative doesn't exist. So we also need to track that workforce shortage across the state. Thanks.
Thank you. Go to Andrew, then David, Carmen, and Stacy.
Yeah, so I guess I'm going to piggyback off of David's point earlier, right? So as I look down this list, and occupational hazard, I'm an actuary, right? So I'm looking at this, I'm like, what would the filing look like, and how do you normalize for all these things? It is rather complicated. I think we are going to need a platoon of actuaries to actually dissect this. And I guess I'm in the let's start with a target that is realistically aggressive, right? So that that the office is not inundated, because if it's it's a target that is just not achievable to begin with, then everybody's just going to train actuaries now, because you're going to have a ton of filings to try to assess why people didn't meet the target. So I guess part of it is just stressing the need for let's start with something realistically aggressive, and maybe glide path to something that we're looking for. But right now it's just the starting point. Considering the number of entities that are probably not going to hit that 3%. And all these factors, I just don't know how this is going to work. The other thing is, and maybe somebody needs to correct me, that costs associated with increased organized labor costs, I guess my understanding is that's a not after the fact adjustment, that's actually a before the fact adjustment. So I just probably want to check on that.
I just wanted to say a bit more about this issue, and I appreciate what Anthony said, because I want to clarify my intention. So first of all, I believe that when a government entity tries to influence a whole market by setting targets, it's really important that those targets are credible. And already the 3% has nothing to do with medical cost inflation. It's a number that's derived from a historical artifact around household income over 20 years. So I think already you start from a point of view saying that really has nothing to do with medical costs. And then I think you add to that, you've got in this list a collection of known trends as well as unknowns. And I think when we have known trends, examples would be specialty drugs. Another example would be the minimum wage adjustment for healthcare workers in the legislation that was passed last year. I think we should set a target that tries to adjust for the known factors. I think we all understand that the unknowns we'll have to deal with as they come up. I think the danger you have here is you're going to have a target that will be not seen as credible, which will be an enormous impact on this agency trying to respond to all of the providers who are not able to meet it. And by not adjusting for these known factors, you will have more swept into this than there should be. And so so I'm really focusing on not all unknowns. I think unknowns are understood to be not forecastable, but I'm focusing on the known factors that we know are going up by more than the 3%. The last thing I'll say is like, be aware of the law of unintended consequences. So whenever in industries you try to set price targets, you often impact access. And for me, we've really got to look very, very thoughtfully at both costs and access. And I'm nervous that we'll create situations where we're going to compromise access. So if you're a cancer patient and there's a brand new drug that's just been released that is dramatically more expensive than the old drug, do you want your oncologist saying, I'm going to prescribe for you the very best drug for your condition? Or are you worried that they're going to be thinking, well, this is going to break the 3% trend factor because it's 10 times as expensive, but it's double the effectiveness? I think those kinds of factors, I'm afraid, will come into play here if we set an unrealistic target that's not adjusted for these known factors.
Thank you. We've got Carmen, Stacy, Samana, and Janice.
Yeah, I think I don't know if this would be helpful for everybody else, but I mean, it's the process here of how it goes from assessing the contributions to the, to not meeting the 3% target to going into progressive enforcement is kind of confusing to me. Like, is this meant to be I know that you explained it as like the step before it gets to the progressive enforcement, but is the goal here to, I guess I'm just unclear about how, like, which of the regulated entities get into this bucket. And it seems to me like a little bit of this is, going to Andrew's question, is like, is there going to be data collection from OCA at this point? Are there going to be regulations on each of these performance assessments? And sometimes, like, in this conversation, it kind of seems like we're reopening the spending target adjustment question in a weird backdoor way, which is like, is that what we're doing here? I'm just like a little bit confused about what exactly is happening. And I think, from some of the discussion that everybody was having with the, which one of these factors might make spending go up or down, it really, just looking at what happens with progressive enforcement, maybe that's where we get the public testimony so that we're not just throwing a bunch of actuaries, sorry, Andrew, at it. I'm just a little bit confused about the process here, because I think what we're all concerned about is that people are, providers or other regulated entities are going to be making bizarre decisions, good or bad, trying to maybe or maybe not be placed into this number 2 bucket, and then it's not clear when everybody gets, like, when the performance improvement plan starts. And I think just some clarity on what we're actually doing. and I don't know if that would be helpful for everybody else, because I am not really sure what's happening. And I think, Anthony's point earlier is just like, we really should be focusing on making sure that people get the care that they need.
So we have Stacy. Oh, God. Thank you.
Yeah, thanks for that comment, Carmen. I could clarify. We did get a lot of feedback about kind of adjustments for various things. And it's OCA's perspective that we shouldn't adjust the target on the front end, because high-cost specialty drugs aren't experienced by all providers equally, nor is technology deployed at the same rate. We do think there's a place for these factors, and enforcement is not automatic, but there could very well be warranted reasons for why an entity exceeded the target. So rather than kind of automatically putting them on the path of enforcement, there is this space where we could assess performance, and that could potentially mitigate the steps in the progressive enforcement process. But if there is, if the office doesn't get information, or the office, it would be, the healthcare entity would need to provide some information about what these potential factors, and if they're not able to, then then that would put them back on the path to progressive enforcement. But we just wanted to kind of just demonstrate that enforcement's not automatic. We will take into account additional factors.
Thank you. So we had 3 additional comments, Stacy, Simona, and Janice, but we do need to move on. And then I did see 2 additional hands raised after that. So I will give Stacy and Simona and Janice an opportunity, but we would like to move on. We have a number of more items.
I'll make it very brief then. I just wanted to just comment, the dialogue we're having shows the complexity of what we're trying to do here. And the factors to adjust means to me that you've heard us in all of our comments. I do weigh into David and Andrew's comments about if there are known areas, minimum wage as an example we've used before, that probably should be considered up front, because we do want a measure that is reasonable that we could reach for. And I'll stop there.
Just again, I definitely hear David and Andrew's comments. I've wondered myself, as you have, how to create institutional common purpose in a sense where the gaming might happen. We're all concerned about this. I find it interesting that hospitals that have bundled payments, let's say in the emergency room, the particular example, an $1,800 charge for one single lab panel that normally would be under $50. In that particular instance, when the insurance was approached, they approved these charges and didn't question them. Again, you have to have the interinstitutional will, you have to have some kind of a system that allows this sort of thing to be picked out. Where are the high value cost improvement measures that the hospital itself may not see? Because I'm just used to, in my area, decades of conversation around this is necessary because the private payers are subsidizing the public, Medicare, Medi-Cal costs. It's a culture change, I guess, is what I'm saying, while trying to embed that in that specific example. And in answer to those questions, that has always been the thought process around American quality of care, is that innovation cannot be stifled, and yet we have to support, what we know about comparative effectiveness research. We have to say, is this imbalance worth it before we jump on the bandwagon? So that's some thoughts.
Thank you. And so we do want to wrap this up, but I do want to invite Janice, Abby, and Stephanie in that order if you'd like to add anything.
Yeah, I just want to rebut the conversation on whether we have known factors. The known factor is that over 30% of Americans are in medical debt. And currently there is no cost growth target, and consumers still can't access care that they need. And so I think the goal and the opportunity here in this room is, are we shifting this conversation about whether we want people to afford care or not? And so I think this is a very comprehensive list of potential factors that could affect healthcare affordability, and I think it's really valuable information that we can glean about how we can work collectively to make this happen and to allow consumers to afford the care that they need.
Go ahead.
Hi. So I'm not as sophisticated as a lot of people on this board when it comes to bean counting, money, target spending. But I can tell you, and to recap on something that Ms. Dr. Joyner said earlier, I actually see doctors spending more time justifying why an expensive drug is no better than an inexpensive drug. That's been my experience time and time again. The money spent on commercials advocating products that have clearly not shown strong clinical evidence over stuff that is much more effective is plaguing our system. These commercials are awful. People wanting brand name, it's off the hook. So there's so much waste. So before we go into this target spending, people complain about labor. I will tell you, I wear many hats. There needs to be more cross training. I'm not a psychiatrist. I'm not allowed to diagnose people, but I would say half of my job is spent dealing with psychiatric issues, and there's not enough preventative in those directions that could probably save us a lot of money in the ER room. I see the same patients boomeranging back with all their mental health issues causing their physical health issues. We have a society full of depressed, disenfranchised human beings. It's costing us copious amounts of money, and people are not getting healthier. And I could go on, and maybe someday I'll write a book, but targets and goals. I've heard labor being brought up. I'll tell you, I'm worth every penny. My 22 years of what I do, my only issue is I feel there needs to be more cross training because COVID brought out the worst and best in human beings. And we're still seeing the sequelae of all the health issues that are coming and a lot of stuff that's not being talked about. Because I can tell you, I have a lot of patients who may or may not have had COVID with a lot of lung damage going on, including my 31-year-old son who can no longer run 10Ks. So we're not even scratching the surface, but until we talk about these targets and performance, we need to see the grassroots level of where we are broken, and we are seriously broken. And if other countries can do it better than us, I don't know. I feel like there's a lot of spinning and coming back to issues, and it's still a little abstract to me, but I'm hanging in there to try to learn as we go. But until we address all these fundamental issues, we're not gonna fix our system. Thank you.
Thank you, Abby, and then we'll close this item.
Thank you. As a major purchaser of healthcare for the residents and the workers of San Francisco, I have to say that the affordability question is first and foremost in that our ability to even project reasonable rates over the next, starting last year, has gone out the window. And it just makes it very difficult to plan and project what is going to happen in the future and how that takeaway from wages of current workers or programs for residents is very real that we're grappling with in the moment as we await the bids from our health plans in next month. So this is a very real time for us. As in my experience in both private and public healthcare and the clinical setting, I totally appreciate the concerns and sort of the fears of the industry as it grapples with the pandemic, the emergency, the emerging technology, and the workforce shortages. And yet, I continue to just be stunned by the unbelievable high cost of this. I recently reviewed a hospital bill from one of our plans that was voluminous and that resulted in an $8 million bill. And I just can't quite fathom how we got here. But that's where we are today, and we certainly have issues with that we can't and wouldn't want to capitate care. But at the same time, when you're seeing bills like this that are so stunning, it's very difficult to imagine what the future would be like without some controls in place. And so we really do, as I said, as a major purchaser, and have many colleagues in the field as well that are just baffled and confused as to how to actually do sound purchasing with public dollars or private industry dollars to do the right thing to keep our workforce insured. But at the same time, I mean, just the whole idea of going backwards on high deductible just makes my head spin. That's the one study that's been done on plan design that says it doesn't work. So I think that's would face yet another failed experience.
So we do think the retrospective review for these issues will yield some very important policy issues that as a collective we need to address. But at the same time, we have to address the affordability issue now with a very aggressive target that gets us out of the gate. Thank you.
Thank you. Go back to Vishal.
All right, good morning. I'll be taking us through the next slide as we go through a few considerations that we just wanted to provide an update and some context for the AC related to. And so this first one that I'll be covering is some context related to the considerations around progressive enforcement. We want to provide some context related to the timing and the implementation of progressive enforcement actions, and also how it kind of intertwines with target setting. So as you all know, OCA is proposing to establish a target for 5 performance years. Those are 2025, 26, 27, 28, and 29. In each of those, we'd be comparing growth from the spending from the year prior. So 2025 is comparing spending from 24 to 25. 26 is comparing spending from 25 to 26, and so forth. We note that 25 is a reporting year and is not subject to the progressive enforcement, but will be the first time that we do report spending and performance relative to a target. We know that progressive enforcement involves engaging in technical assistance discussions, requiring entities to provide public testimony, establishing performance improvement plans, and ultimately levying financial penalties, generally after non-compliance with a performance improvement plan. So again, just to kind of put this more into context, and I think the next slide will hopefully visually also help reinforce this. Nope, if we could not go to the next slide yet. Just a preview for everybody, not to get ahead of myself. So the annual report for performance year 2026 won't be published until the spring of 2028. Right, that's just sort of the time lags that we have. We need to wait till 2026 spend is complete. There's the run out period of at least 6 months, and then we collect that data in 2027, and then the report comes in 2028. So if we were to establish a PIP in 2028 relative to the 2026 spend, that PIP would really be applying to prospective out years, right? Because 2027 spend has already occurred. And so we'd be looking at, so 2029 and beyond. And statute provides that an entity may be subject to a PIP for up to 3 years. And so while OCA has the authority to assess financial penalties on a standalone basis, currently OCA is more likely to assess penalties when an entity's been non-compliant with the terms of a PIP. Again, that sort of progressive enforcement in terms of how the statutes outline. And so that's not to say that performance years 27 and 28 aren't subject to progressive enforcement actions. In fact, they are. And so the 27, 28 would still be subject to enforcement actions, and non-compliance with the target could result in technical assistance, public testimony, PIPs, and potentially financial penalties. But again, we're kind of signaling that that's an unlikely scenario. So if we go to, now we can go to the next slide. So again, just to put more of this in context for everybody around the targets, how this all interacts with each other. So we're currently in 2024 talking about setting the 2025 and potentially beyond, right? We're recommending setting the target for 5 years to provide some stability and predictability around the directionality of the target and where we want to head, or where we think that we need to head as a state. That first annual report for 2025 would be released, as I said, in 2028. PIPs would likely flow, for performance thereafter. And so also, we want to highlight and note here is that, the board needs to approve at least 2025 by June, the target for 2025 by June of 2024, the target for 2026 by June of 25, the target for 2027 by June of 2026, and so forth, right? So even if the board does set, as we've recommended, a 5-year target, the board still would have the authority to revisit or reestablish the target. And so by the time we would be getting to a target year that's likely to be subject to financial penalties, as we said, 2029, the board will have had 4 annual reports that it would be on spending growth that it would be able to use to, again, further inform that target, and would be able to revisit based off of that. So by the time we would get to sort of solidifying targets, in June of 2028, we will have released the statutorily prescribed baseline report in June of 2025. As we've mentioned before, the office intends to release a report comparing spending from 2023 to 2024. And then also, as just defined in statute, we have to release the first annual report, which is the reporting year against the 2025 target, and then also the 2026 annual report, which will be released in 2028. So there's going to be multiple, just to kind of reiterate, there will be many times that the board is able to, and we will all get to see spending data and performance data as we get into this sort of reporting cycle. And just wanted to also just point out the sort of some of the delays that are just unavoidable in terms of how this reporting cycle will play up and out into the future. With that, I'll hand it back to Michelle.
So I'll be covering some considerations for Medi-Cal spending. So today we want to spend some time going over unique facets of Medi-Cal. First, I'd point out that consumer affordability is fundamentally different in Medi-Cal than in commercial coverage and Medicare. Only a small percentage of Medi-Cal members have a share of costs similar to a monthly deductible. Most Medi-Cal members have no cost sharing, which means consumer affordability is not a barrier to accessing care. Next, some aspects of program administration for the Medi-Cal program requires OCA to take a coordinated and tailored approach regarding data collection, measurement, and enforcement. As a reminder, OCA will report spending data that includes MCOs or managed care organizations and their contracted providers, since they are healthcare entities under the statute. Next slide. Here we provide some background information on base and supplemental payments and non-federal share financing. As many of you know, there is a base payment and separate supplemental payments for services rendered to beneficiaries. Supplemental payments leverage federally approved financing mechanisms to increase reimbursements to providers. For the most part, the non-federal share of base payments is financed using the state general fund. On the other hand, the non-federal share for supplemental payments is largely financed using locally generated funds. These supplemental payments enable the state to maximize FFP or federal financial participation and increase reimbursement in Medi-Cal without increasing the use of general fund. Next slide. This slide lays out what's in statute for OCA to consider relating to supplemental payments, non-federal share, and taxes or fees. We've included the citation as a footnote. So as part of kind of OCA's approach for measurement, we'll be taking into account these categories. Next slide. The next slide lays out when assessing financial penalties against a healthcare entity, OCA may consider the provision of non-federal share put up by providers. Next slide. So I'll now provide a status update on data reporting for Medi-Cal MCO spending. Under our now approved data collection regulations, submitters have a 1-year exemption for their Medi-Cal line of business. This applies to the first set of data that is due September 1st of 2024 for 2022 and 2023 data. In the meantime, OCA will leverage existing data from DHCS to report MCO spending on an aggregated basis. So this is a statewide total. OCA will report supplemental payments and this as well as the provision of non-federal share. I'd note that leveraging existing data from DHCS does not enable us to report attributed total medical expenses to physician organizations. OCA will need to determine if additional data is needed directly from MCOs. The thinking behind this is that we first want to work out the data submission process with commercial payers on attributed total medical expenses for physician organizations before we roll it out to Medi-Cal managed care organizations. Lastly, as you may recall, at the last advisory committee meeting and the January board meeting, we noted the need for OCA to develop additional strategies to measure hospital spending across all patients, not just those that are part of a health system that includes a physician organization where you could attribute lives. As we develop this approach, it will likely require inclusion of spending by lines of business, that is the commercial, Medicare, and Medicaid markets, as well as consideration of Medi-Cal program requirements. Next slide. So this slide lays out what's in statute pertaining to coordination in spending target enforcement. OCA is required to coordinate enforcement actions with DHCS, DMHC, and CDI as relevant. Under this provision, we would take into consideration Medi-Cal program changes that impacted spending. Next slide. One of the more recent changes in Medi-Cal that impacts spending is the Managed Care Organization Tax, or MCO tax. Additional revenues from the MCO tax will be used to support the Medi-Cal program, including new targeted rate increases for providers and other investments that advance access, quality, and equity. We've laid out here the phases in which DHCS is implementing program changes, with the first phase of targeted rate increases underway. And then on the next slide, we'll move on to the way OCA will assess performance and enforcement for entities participating in Medi-Cal. First, we'd like to provide some background information on Medi-Cal MCO rates. These are rates certified by actuaries as actuarially sound for each plan, rating region, and population, based on several factors such as historical costs and utilization or program changes. These rates also consider, the certification of these rates also consider reasonable, appropriate, and attainable spending for a typical Medi-Cal plan in the same geography. Rates are also subject to rigorous review by federal actuaries and are subject to extensive state and federal oversight and examination. For these reasons, OCA would note that Medi-Cal MCO spending is significantly different compared to commercial spending. With regard to providers, DHCS and its actuaries are also annually evaluate how the rates MCOs pay providers compare to Medicare and commercial coverage. This includes review by federal reviewers. Federal requirements also prevent DHCS from funding MCOs for payment levels that exceed average commercial rates. Except for inpatient care, current Medi-Cal payment levels for many services are below Medicare on average. Next slide. This slide lays out what's in statute pertaining to, sorry, I got my notes mixed up, but I'm on the correct slide. So because spending growth in Medi-Cal can change from year to year, OCA will coordinate with DHCS on factors such as rate increases, investments, and other program changes so that we provide the appropriate context. Given the extensive state and federal oversight for Medi-Cal spending and rates set for MCOs, OCA would not pursue progressive enforcement for MCOs. For providers that exceed the target for their Medi-Cal line of business, OCA will contextualize spending growth driven by program changes and requirements implemented by Medi-Cal. I'll now shift to considerations for Medicare spending. Since there are a similar set of issues, I'd ask that we hold comments for just a few minutes. So as most of you know, Medicare fee-for-service rates are set administratively. With respect to Medicare Advantage plans, the federal government pays a set rate per person per year. The rate often has various adjustments, such as for quality. We've included some information here with regard to how these federal payments to MA plans are tied to local per capita Medicare fee-for-service spending. This means the rates MA plans pay to providers are similar to or slightly above Medicare fee-for-service. Further, federal law requires providers to accept Medicare fee-for-service rates as payment in full for out-of-network services received by MA enrollees. This effectively limits the rates that can be charged. Because MA rates are governed by CMS, this would mitigate the need for OCA to pursue progressive enforcement for MA plans. For providers that exceed the target for their MA line of business, OCA will contextualize spending growth driven by program changes and requirements implemented by Medicare. And I'll now turn it back over to our facilitator for comments and questions.
Thanks. So at this time, we'll take some questions and comments. Sarah Gavin, do I see your hand?
Hi, thank you for that. I have a question specifically about FQHCs since they provide a bulk of the Medi-Cal services in California. And given that FQHCs are paid by PPS rate and that is negotiated and can be renegotiated by site, I'm curious how the spending target impacts that entire system.
So at the statewide level, we will report Medi-Cal spending, which will encompass FQHC services. Since we have a 1-year delay for MCO reporting, we will not be reporting at the provider level. But once we have some decisions to make kind of about the data collection with regard to collecting them directly from MCOs, and then we would be kind of ready to measure FQHCs at that level.
So it's a good question, Sarah, and I think we just haven't gotten there. So I mean, I think Vishal's laid it out. It's a good point that given that FQHC's PPS rate is sort of set. So I think appreciate you raising that. I think we will certainly look at that down the line.
Andrew C., and then I see David's hand.
Hi, so Vishal, just, English is my second language. I'm just trying to figure out what you just said on Medicaid and Medicare, right? So I heard for Medicaid MCOs, it's been vetted by, lots and lots of actuaries. So essentially, for enforcement purposes, you would exempt Medi-Cal MCOs. And similarly for MA plans, is that what I heard?
There wouldn't be a need for OCA to pursue enforcements given the extensive oversight by state and federal agencies.
So on the health plan side of this equation, I mean, the only thing left is commercial, right, for the most part, and that's kind of really it. And I would note we actually, there are commercial filings in the state, several of them actually.
Okay, with that, David Joyner and then Stacey Herrantes, and then we see online Hector Flores.
Can I just ask if you would explain what you mean by contextualize? I'm not sure I exactly know what you mean by that at the end of the slide.
Yeah, thanks very much, David. I think so. What we're saying is that for the Medi-Cal plans, as Andrew noted, because there's such rigorous oversight, that we wouldn't deem enforcement. So for physician organizations and hospitals, we will look to their Medi-Cal line of business, and if there are so the contextualized part is that if there are significant new Medi-Cal requirements, it's an you look like you want to say something.
Maybe I should have been clear. I'm talking about the current slide, which talks about Medicare Advantage.
So for both Medicare and Medi-Cal, for both physician organizations and hospitals, we would look to see if there are program changes and requirements that led to an increase in spending. That's the contextualization.
Okay, so make sure I'm understanding you. So if in MA, the rate of increase is less than 3%, no issue. If the rate of increase is more than 3%, you would say we're going to investigate and determine whether program changes caused that. That are
Correct.
outside the control of the provider or the health plan?
Correct.
Okay, thank you.
Stacey Hernandez, please go ahead.
Actually, mine was regarding Medicare Advantage. If providers take a percentage of premium contract for Medicare Advantage plans, wouldn't we be considered in that first bucket instead of the conceptualized or contextualized?
Yeah, it's a good question, Stacey. We've had really robust discussions with DHCS over the past couple of weeks to sort of get where we think we're going on Medi-Cal, and we have not done the same thing with our federal partners. So I think we'll need to learn more about how Medicare contracting works. And so if that's the case, that'll be important for us to look at.
Thank you. I think if we're on a percentage of premium, it just comes downstream. It would make sense, at least to me.
Thank you.
Hector Flores, please go ahead.
Thank you. So my comments relate to, in this topic, developing a more robust way to evaluate community benefit, because it's substantial. And the reason for that is, I recall in 1994 when the governor at that time, Pete Wilson, announced the Medi-Cal Managed Care Initiative, Kaiser Permanente was very vocal about not being all in on this initiative because the rates that the state was offering were not actuarially sound. So they were challenging the actuaries that gave Medi-Cal its number. And we know from the last couple of years that Kaiser publicly announced that by their estimation, they're subsidizing the Medi-Cal program to the tune of about $2,000 per member per year. They have close to 1 million members, so that's $1 billion in subsidy, which they write off to their community benefit. But it really speaks to the fact that the Medi-Cal program is underfunded and that cost shifting that goes on. But secondly is Kaiser defends its ability to ascribe that to community benefit because they believe they can track every single dollar up to support their tax exempt status. I think that's important for us to keep in mind two things. One is, are the actuarial analyses of Medi-Cal correct? And I would say Kaiser's numbers, they tend to have good data, so I would believe their numbers. But then we also need to look at how community benefit can be utilized to enhance access and affordability for care. And the second part related to that is looking at the future of Medi-Cal. One of the uncertainties is the expansion of Medi-Cal today to undocumented populations, for example, which we all champion. Depending on future budget crises, that may also get rescinded. And so we're going to need to also anticipate how community benefit can meet the needs of those individuals when they suddenly become uninsured. So it really speaks to that from my perspective. The community benefit, we need a robust methodology to track it. I think it has value. And then number two is see if the new data that we're collecting can help us get to a more actuarially sound valuation of the cost of Medi-Cal. Thank you.
Joan Allen, you're next.
I would encourage that it's a little bit premature to put that we're going to that we have mitigated the need for progressive enforcement in MA and to entirely rule out the possibility of progressive enforcement on the Medi-Cal managed care plan side. It feels like we don't have enough data yet to know that. On the MA side, we've seen nationally concerns with upcoding, and as incentives change, reactions by the MA plans that do not necessarily track the actual underlying population they're serving. And so something that you are not going to manage, you're not going to measure nearly as closely. And so on the MA side, it feels like it's still important to really be digging in and tracking that with our federal partners. On the Medi-Cal side, it's almost the flip. We know that we have an access crisis in Medi-Cal, particularly on the specialty side, that as Adam raised earlier. We know that it varies regionally, and we know that it varies by plan. but there is not enough data yet to really get at what that means for equity and for quality. And so I think it's premature to rule out that enforcement and to rule out because the progressive enforcement isn't just about the financial penalties or getting people back under the target. It is also about those other access, quality, equity, and workforce stability aspects of what we're trying to do here. And in service of those, I would encourage taking out the reference to, I would encourage taking out that reference to not doing enforcement.
Thank you. Karen Savage-Sangwan, you're next.
Great. Similar, actually, want to echo Joan. And just to start off, I have some concern about the initial framing about affordability not really being an issue for Medi-Cal members. I don't think that's true. And I think, you know, I believe it's 1 in 5 Medi-Cal members is carrying medical debt. Now, that may predate their time in Medi-Cal, but a lot of it may not, right? And so I think we need to be conscientious about the affordability issues. There too, people are paying out of pocket for behavioral health care. People are paying out of pocket once they go over the dollar limit for dental. We still have a dollar limit for dental in Medi-Cal. Like, there are those real issues. So I just want to make sure in the framing we're conscientious, not to mention when we're talking about taxes, you know, poor people pay a much higher share of their income in the taxes that support this program. So we really need to make sure those dollars are well spent. Now, I would definitely agree. There's a lot of investment needed in Medi-Cal. There's a lot of real, I think, dire need to improve access and to make strategic investments to do that. But I would also say when we think about the key areas to reduce costs, some of those do apply to Medi-Cal. There are administrative inefficiencies in Medi-Cal. There are high cost, low value services in Medi-Cal. I think someone earlier talked about inpatient psychiatric care, high value, high cost, low value care, right? So I don't want to lose the opportunity to really work on those things in Medi-Cal. So I would agree with Joan. I think it's premature. I would appreciate, I think, maybe seeing some other options from HCI about how we recognize the complexity, specific complexities of Medi-Cal, and some other options for how that could be addressed.
Thanks. Anthony Wright and then Adam Doherty.
Just seconding my colleagues, Joan and Kieran, on the question of Medi-Cal and maybe Medicare too, just that I appreciate what the staff is saying, right? That these other, we're focused on the commercial because Medi-Cal and Medicare have already been living on a budget through other structures. But Medi-Cal is just a third of our state. It's so crucial. And you know, frankly, and so there should be coordination with DHCS but even DHCS is going through its own changes with regard to how they oversee Medi-Cal. I mean, they just started a new, for the first time in decades, a reprocurement process with now a new contract, literally like 2 months ago. So, I don't know if I want to sort of cede a lever when, you know, DHCS is just literally reevaluating its own letters right now. And even though I appreciate that, like, again, the focus should be on the commercial side. I'll second issues around quality and efficiency, et cetera. Also, actuarially sound is an important metric, and Andrew might correct me, but doesn't mean efficient. It doesn't mean, like, there's a wide range in actuarial soundness. It's not one number, right?
I'm sorry, and it's actuarially sound for the health plan, right? Which is really what the providers are talking about here. Right.
I mean, I've done enough of the rate review side, even in the commercial side, where yes, DMHC quantifies something that's actuarially sound. That doesn't necessarily mean affordable. That doesn't necessarily mean efficient. That doesn't necessarily mean other factors as well. So, just 2 other points. One is I appreciate you going through the progressivity piece because and the timeline, because I know that there was some comments about, like, maybe we should just do a target for 1 year and then see what happens. But as I think the timeline shows, if we it doesn't make any sense because we're not even going to get data for a couple of years and then have a conversation or whatever. We could do it for 1 year, but then what do we do the second year? We still won't have any new information from this process, and so we do need to have a multi-year target just to give the industry something to work with. while it gets informed by other things going forward. It doesn't mean that we can't change it or adjust it, but I think to only do it for 1 year, I think just doesn't make sense with the timeline that you talked about. And then just finally, I want to just go back to say what this conversation has already seeded. You know, access is already compromised because of high healthcare costs. We talked about high deductible plans. That's basically a trade-off between how damn high premiums are. And anybody who goes to Covered California recognizes that it's basically a trade-off of, if you can't afford of course everybody would like a no deductible plan, but if you can't afford that gold or platinum, then you have to buy down to a silver with a $3,000 or a bronze with a $6,000 deductible. And so the costs do matter. They do have an impact on access already. And so that's what we're trying to mitigate already. And in terms of the evidence behind, like, I think that there could be a credible target that is a reduction in healthcare costs based on, you know, the literature that's out there around waste in the system, that literature that's out there around variation, both within and between regions, and just even targeting costs to something that you could have a credible case that we should have a target that is actually a negative number. I know that's not in the statute, but so I think we're seeding that, like, this is not a reduction, this is not a freeze. We're trying to target to something that to at least not make healthcare costs more affordable for Californians. And in addition to that, we also have this progressive enforcement that is going to take some time. And and so we're along for this ride because we want to get to a goal. But like, I think we've already seeded a lot here, and I just want to acknowledge that.
Thank you. Adam Doherty and then Tam Ma.
I think we've really opened a can of worms with the Medi-Cal question. I'm here for it. It's fantastic because I think, you know, it's, as we're hearing now, it's, you know, not in a vacuum. There are plenty of patients who churn between Medi-Cal and high deductible plans and back. And a lot of these Medi-Cal MCOs are just trying to run the clock out, whether getting the patient to Medicare or getting the patient off their rolls. And they are intentionally doing that, whether it is carving out services, whether it's narrowing networks, whether it's making my job harder by literally not paying providers because they are trying to poke holes wherever they can. Maybe they're going to get sued, maybe they won't. It doesn't really matter because DHCS is so backlogged. I would actually challenge the notion that they are extensively overseen by DHCS. God bless the good people over there for the work that they do, but the sheer volume of inquiries, of concerns, of lawsuits that they do not have the staff to cover is, you know, writing on the wall a little bit. People are going to get to the goal that they want to on the payer side with our taxpayer dollars, whether they are stopped. And I think I think the office has a crucial role in that regard to either shine light on it, because this is affordability. This is, at the end of the day, I don't really care if, you know, we make a full body MRI more affordable for the ultra wealthy who wants it every year because that's what they want. If that's not affordable for them, that should not be our concern. We know the people we're talking about. We know the people whose health outcomes are affected by the most from the slides at the beginning of the day. I think we cannot lose focus on what that actually means here, and this is a crucial part of that conversation.
Thank you, Tam Ma, and then Barry Arbuckle, and that may wrap up this segment. We'll see. Thank you.
Are thank you, that are self-financed, right, by our public hospitals and health systems through the IGTs, and that, you know, reliance has grown over the years. I think, Michelle, you made a comment about measuring hospital spending and potentially separating costs by lines of business. So we're very much interested in understanding how that might work out operationally, and hope that the hospital spending work group can dig into that, because I think there are a lot of costs associated with providing care. That's, you know, where like we hire staff, buy supplies, equipment, and things that just, you know, it's not done by lines of business. It's just, you know, services, labor, supplies, costs, and things that are just, you know, that we take on to provide care to patients. And I think our experts on spending, hospital spending and operations can dig into like, you know, what's possible or not in terms of attributing cost by line of business there. And then finally, I had a question about how OCA might account for cost shifting by providers to account for unreimbursed costs, and how does that play into this conversation?
Shall we move on to the next committee member, Barry Arbuckle?
Just two comments in the Medicare space. One really just kind of highlights, I think, the complexity of all of this. I read by the first bullet on this slide that Medicare, traditional Medicare fee-for-service isn't one we're going to really dive into a lot because they're set by through laws and regulations. We shouldn't presume that means it's fair or equitable. It is what it is. I mean, and given the number of people, and you all know the statistic that are aging into Medicare every single day in the United States, it's becoming a bigger reality. But just as a kind of a tangible point, in my market, just to use two hospitals as an example to highlight the point I'm making, many people would consider Cedars-Sinai and UCLA to be fairly comparable. They have very similar markets. They have similar services, similar acuity. They both have big teaching programs. They both do a lot of research. The Medicare reimbursement, then, you would expect the DRG payment to be relatively similar. They're not. UCLA is not 5% higher. It's not 10% higher. It's not 20. It's not 30. It's 36% higher. DRG to DRG. So, and I'm not saying that's, I mean, it is what it is. That's the rules. But that creates a wild inequity as patients age from commercial insurance, which we all know there's the cost shift, into Medicare. All of a sudden, that same hospital is getting reimbursed wildly less for caring for that same patient the same way the next day. And that's just one of the realities of the U.S. healthcare system that is kind of the ugly, you know, underbrush. The aspect down below, the second from the bottom bullet on MA plans, it just concerns me a bit that we're not going to investigate that a little bit more, because MA plans are making billions of dollars taken right out of the system. Somebody's paying for that, and it's the consumers. And so there's got to be some guardrail around that, because that is among the most profitable things that in healthcare right now from a reimbursement perspective is Medicare Advantage. Thank you.
Thank you.
So I just want to thank all, I don't know if there are other comments, Karen. Look, I just really want to thank you all. You know, we are working with DHCS closely on this. Like I said, we haven't had conversations with CMS. It's very helpful to hear all of your perspectives. So this is why we have you all to try out some of this information. So appreciate the robust discussion.
I think we're ready to move to public comment. So this would be public comment in regard to the most recent agenda item 3. We'll look for people to come to the podium in the room, and we'll also look for raised hands online. A reminder, please keep your comments at 2 minutes or less. And we'll start with someone here in the room at the podium. Thank you. If you could just make sure your mic is on, we'd appreciate it. Thank you.
Is this on? All right. Ben Johnson with the California Hospital Association. Thanks for the opportunity to talk. Just like to align ourselves with the earlier comments from committee members that factors that are known and predictable be built into the spending target rather than used for after the fact and potentially difficult to understand sort of steps in the enforcement process. We support a lot of those inclusion, though, of consideration of factors that can't be predicted, such as many of those listed. I think you captured a lot of those. A couple others that would want to note quickly. Statute doesn't exclusively refer to organized labor costs and the consideration thereof, and so would certainly ask the office to consider labor costs more generally when they're looking at upfront, certainly adjustments of the spending target, but also on the back end as well. And then one other issue we've heard in other states that has a factor that actually has sort of pushed maybe certain entities over the spending target are quality payments, value-based payments, and so forth. So an entity that performs well on quality measure A, B, and C gets a payment, and that's counted against the spending target. And so that should be a very important factor considered on the back end process. Appreciate the inclusion of a discussion of Medi-Cal issues, and really look forward to, I think, continuing that discussion. Do have some questions about the really distinct standards that you're proposing to apply to plans versus providers. And I think stand with committee members that not exactly clear what contextualizing will mean in practice. And so do believe that these known factors, such as policy changes that are going to add $6 billion in costs next year, be really considered upfront. Thank you very much.
Thank you. Looking to virtual attendees, I don't see any hands at this time, so we'll return back to the podium here.
Thank you. Ryan Witz, District Hospital Leadership Forum. Ben was reading the same comments that I had, so I'll just echo in support of CHA's comments. Thanks.
Thank you. All right, looking at our virtual attendees again, seeing no hands, not seeing anyone else step up to the podium here. That concludes public comment for this agenda item.
We're just doing a quick huddle on, we're going to let you go to lunch soon, and we're just doing a quick huddle on when we're going to come back. So when we come back, we will go through the slides summarizing the input we've gotten thus far on the spending growth targets, hear your additional feedback, and we are coming back at 12:50. All right, so you still get 46 minutes. See you all back at 12:50. Thanks so much. Well, welcome back to the afternoon portion of our Affordability Advisory Committee meeting. I think with that, Jane, or do we do another roll call, Jane? Okay, great. Whatever we do.
Joan Allen.
Present.
Barry Arbuckle.
Here.
Eliza Arjoyan. Stephanie Klein. Carmen Comsty.
Here.
Adam Daugherty. Parker Duncan Diaz. Hector Flores.
Here.
Sarah Gavin.
Here.
Stacy Rontis. David Joyner.
Present.
Ivana Krasinovich. Tam Ma. Carolyn Nava.
Present.
Mike O'Day.
Present.
Janice O'Malley.
Here.
Sumana Reddy.
Here.
Yolanda Richardson. Karen Savage Singwan.
Present.
Andrew C.
Present.
Sarah Sorokin.
Present.
Ken Stewart.
Present.
Suzanne Usage.
Present.
Yvonne Wagner. Renee Williams. Anthony Wright.
Good afternoon.
Abby Yan.
And Tamma, we just know Tamma's joined us. Welcome.
Thank you.
And we note that David Carlisle from the Affordability Board is also with us. Thank you very much, Dr. Carlisle.
Thank you.
So our next portion of the agenda will be public comments on the proposed statewide spending target. You know, as the director mentioned at the top of the meeting, there was robust public comment. The next slide shows that we received 224 public comments related to OCA spending target recommendation. The full public comment letters are posted on our website. Comment letters came from individuals, unions, consumer advocacy groups, equity-focused organizations, purchaser organizations, individual hospitals, physician and medical groups, and health plan, medical, nursing, orthopedic, and hospital associations, among others. We've organized the public comments into summary slides that are representative and organized by broad categories of spending target, methodology, and duration of the target. Within each category, we also broke out comments further into the following themes: access and quality of care, target value, adjustments, economic indicator, duration of the initial target. And then for those that didn't fit neatly in those categories, we have an other comments section. Because there's a lot of content to cover on each slide, the approach we'll take is to stop and get advisory committee feedback after each slide. CJ and I will alternate, with CJ covering the next slide.
All right, good afternoon. So again, the first slide is related to the target value with the theme of access and quality of care. And we'll be stopping shortly to solicit any additional feedback that you may have or reaction to the public comment that we've received. And again, this was our best attempt to summarize some 225 letters and several hundred pages worth of content into 7 slides. So there are some summary that was necessary to get to this point, but tried to make sure that we were airing all of the substantive comments that we received. So the first, and again, organize these by concerns and then sort of support for the target or the target value. So on the concerns, there was a comment that to meet and maintain the target, hospitals will have to reduce services or close certain service lines and exacerbate an already difficult healthcare workforce shortage. There's concerns over the ability to deliver high quality healthcare to those in need is detrimentally impacted by any decrease in reimbursement. Concern that an unrealistic target will result in longer patient wait times, reducing patient access to care, and penalize physicians who care for more complex patients with disabilities and chronic disease. The most vulnerable patients might not be able to find physician practice or medical groups able to take them and meet targets. Also concerned that this may force providers to cut back on care or face penalties, and that OCA has not performed sufficient analysis of trends in healthcare labor costs, the potential impacts of a 40% drop in healthcare spending growth on workforce stability, or the effects of negative real spending growth on access and quality. So supporting the target value along the theme of access and quality of care. So any increase in costs of care will exacerbate problems with access, equity, and public health, furthering lack in access, affordability, and equity. These effects are particularly hard on minorities and those with disabilities. Lack of affordability impairs quality because consumers skip or delay going to the doctor, filling prescriptions, and getting other necessary care. Californians, especially those with employer-based coverage, are paying more and getting less care, less access to care, lower quality in terms of managing chronic conditions, and less health equity. And that OCA's proposed 3% cost growth target is desperately needed today to help California families who are insured be able to use their health insurance. This target will help California strengthen healthcare quality and achieve more equitable care. I'll turn it back to the facilitator to facilitate any discussion or reaction to these comments.
Looking to the committee for any additional comments, discussion. Eva, please go ahead.
I hope I didn't miss it, or maybe it's in the other slides. Is there any sense of like the weighting, like how many letters or statements you got on one side or the other?
Yeah, we got a little, mostly equal, but a little more on the support side. So we got a lot of letters from individuals in support of the 3%, as well as from union and purchaser groups. So as I noted earlier, all of the comments are posted on our website, but CJ, correct if I'm wrong, I believe it was more on the support side.
Yeah, David Schwenner, go.
I'm not sure the right way to make right point to make this comment, so I'll make it now. I've already made my comments about the 3% and how I feel about it. I won't repeat those. But one other thing that I'm concerned about is I think the plan is to apply the 3% to all providers, irrespective of where their starting point is. And I think when you have two hospital systems or two medical groups in the same market and one is substantially higher cost than the other, in my view, you shouldn't apply the same percentage target to them. And I don't read anything in here about that issue, but I think that needs to be thought of carefully. I also think that it's hard to do, but I think we should think about the fact that we ought to provide a different target to high quality, great outcome providers than to those who provide the lower quality outcome. That's obviously very difficult to do, but conceptually, over time, I think we should think about that and really make sure that those that invest in great outcomes are held to a different target than those who don't, and should be penalized accordingly.
Andrew C., go ahead, and then Janice O'Malley.
Yes, I don't know where to make this comment. So I spent a better part of Sunday reading all of it, believe it or not. It's just like binge watching, but I'm binge reading. And what struck me is really the consumers who actually took the time to put the stuff in the middle of the form letter, which is put their story out there, right, for people to understand. And there's trade-offs there, right, very personal for those folks, and you feel the pain for the affordability. On the other side, you see kind of the potential consequences of such a target, given our starting point today, right, where the hospitals may be forced to close certain lines, ERs, labor and delivery, whatever, right? It will impact access because I know folks have been waiting for a while, but we are where we are, right? We are post-pandemic. The delivery systems, the providers have gone through a lot. It takes some time. We're in an inflationary period. Just the starting point is pretty far from the staff's recommendation. So I guess in my mind, if something like a glide path, I've team phase-in, right, from a few meetings ago. Everybody knows this, but some kind of glide path, right? A realistic target. Because otherwise, an unrealistic target, we end up in, okay, everybody's not going to meet it. And we're going to have platoons of actuaries trying to justify the overage. And I'm not sure that's where we want to be, right? We want to actually have something that providers can realistically strive for. It's not a buildup of cost. It's like you have to look at that, but, there has to be an adjustment for affordability, right? Because there has to be commitment to affordability. That's why we're all here. But anyway, just pitching the glide path again.
Thank you. Janice O'Malley.
So from, I guess, from OCA staff or HCI staff, for those states that have cost targets already in existence, did it reduce services or close certain service lines?
Yeah, I was going to turn to, is Michael Bailett on the line?
I am.
Okay.
Ooh, right.
Hi, everybody. I would say that I do not know of any structured evaluations to assess impact on service offerings or on access, but anecdotally, I have not heard any stories that would support that being a problem. I also want to be transparent, though, that the other states do not all have enforcement authority, and no doubt that is going to have some impact on response to a spending target.
Go ahead, Andrew.
And I guess question for Michael, right? So for these states that have, the providers never hit the target, right? More often than not, they went over, right? So it's one of those things we don't have a real world case of everybody tried to hit a pretty low target and what that actually looks like in real life.
Well, I think the story, Andrew, is mixed. That we do have years in which most providers hit the target, and we have other years where that's not the case. I mean, I'm looking at 2022 data now for some states, and there were a lot of providers that hit the target in some states in 2022.
Thank you. Janice,
No, I think I was actually going to make the point that Michael Baylor did about how I think at the start of the Massachusetts cost growth target setting that the industry did very well in reaching those cost growth targets because I would argue that because they weren't enforceable, that they overshot the targets because there was no need to adhere to those targets. So from AFSCME's perspective, from the healthcare workforce perspective, and as for the healthcare consumer perspective, anything above 3% would be, I think, problematic for access and quality of care.
thank you. Looking virtually, Sarah Srokin.
The question of that there may be many entities, and I'm not sure if I'm using the right terms here, but providers, entities that don't meet the target. I think even if that is the case, that would be helpful to then dig into why, especially given so many people can't access care, and then when they have to access it, it's higher cost care because their condition had worsened. And I'm wondering if maybe one of the outcomes, if that is the case that's going on, is that entities can meet the target by lowering costs, increasing access, and overall healthcare spending will go down because people will receive that preventative or lower level of care before needing the very expensive care and experiencing like that increased comorbidity and disability because of putting off accessing care.
Thank you. Seeing no additional hands at this time, we'll move to the next slide.
For the category of target value and the theme pertaining to a 3% target value, concerns raised by stakeholders include the following. One stakeholder recommended a target framework of 1 year at 6.3% in 2025, which accounts for inflation, aging, technology / labor, and major policy impacts. Examples are given in the parentheses, such as the healthcare minimum wage or Medi-Cal investment, seismic compliance. This stakeholder also noted that the framework also includes a 5.3% average for years 2025 to 2029. Another commenter noted that the average annual growth in per capita healthcare spending should be considered when setting a spending growth target. The commenter noted that the 10-year average annual change in per capita healthcare spending from 2010 to 2020 was 4.7%, and the 20-year average annual change in per capita healthcare spending from 2000 to 2020 was 5.4%. Another stakeholder recommended a target of at least 4.6% to not lose ground. They cited a data point from CMS that projected that the increase in the Medicare Economic Index, which measures the cost to practice medicine, will be 4.6% in 2024. The stakeholder noted that it is critical to consider rather than ignore the costs of providing healthcare when setting California's spending growth target. I'll now move on to the comments that support the 3% spending target. The first one notes that 3% each year is not a reduction or freeze, but a goal that the healthcare industry must live within the same constraints as a median family does. Next, 3% is the upper bounds of what is sustainable and may not even go far enough because it won't do much to reduce high outlier prices. Another commenter noted that OCA's 3% spending target puts California squarely in the same range as other states. Other states with cost commissions have targets for the period 2024 to 2027 in the range of 2.8% to 3.3%. A target of 3.5% or 4% would be far higher than the targets in other states. A stakeholder supported the proposal for a cost growth target to be 3% or lower because it provides real relief for California consumers and communities. And lastly, another commenter noted that a target should be less than 3%, but 3% allows cost to increase at the same rate as median household income. And I'll now turn it to the facilitator.
Discussion from the committee? Andrew C.
Sorry, just maybe it's a question for Michael. I guess I read in the comments that a couple of the states that had cost target adjusted them upwards because of inflation. I thought I read Rhode Island and Connecticut. So just wanted to confirm, Michael, if that's the case. And the other thing on the 3% is just, you know, the way that we got the 3% is a 20-year look back, right, including the Great Recession. The forecast of household income is like 3.6. So I guess in my mind, you know, as we're setting the way this is calculated now, so imagine 10 years from now when that Great Recession is not in your historical period and the situation is reverse, right? The historical is higher than your projected. With the people who are arguing for the historical 20, stick to that argument, or of course you're going to look at the lower projected number, right? So, and I think we just have to look at, we're setting targets for the future. You know, we have to look at where we think that's going to be. And I guess I'm going to repeat myself with, you know, our starting point is just very different from 3%. So, you know, I think it's take a look at healthcare costs, you know, what it is right now post-pandemic, you know, make an adjustment for affordability, right? We can't just do a cost plus. But, you know, we just have to take a look at where everybody's starting from.
Thank you. Ivana Kristinovich, and then Adam Daughtry, and then Stacey Rates.
Andrew, you set me up. I wasn't sure if I was going to be able to sneak in some new data. Today's the data day, but I could not resist. So Unite Here Health is part of a sort of, I guess I would call it a collaborative with a number of other labor trust funds that we turn our Kaiser data over, all of our data, but including Kaiser data, over to a third-party warehouse, and we pay tens of thousands of dollars to do this because we really want to understand Kaiser's encounter data as something like claims data, which we can much more, you know, effectively analyze and compare to our other products that we have. So we started this back in 2016. We currently, this kind of collaborative includes about 140,000 Californians, including $3.6 billion in payments to Kaiser Permanente. So we took a look at 2019 through 2022, which includes COVID, by the way, and we actually saw that Kaiser, kudos to Kaiser, kept its per claim cost growth to 2.4% a year. So we think 3% can be done. You have shown it. So, you know, I just thought it's important, you know, kind of data to recognize, and, you know, we look to Kaiser as a leader, and we were really pleased to see that. Now, that's not been reflected in our renewals, right? I mean, if we were paying 2.4% renewals, I honestly probably would not be sitting here. So that we have that disconnect, but just this question about whether it can be done or not. When we looked at, you know, billions of dollars in payments, 140,000 lives, we saw it could be done.
Adam, and then Stacey.
I also believe that Massachusetts and Oregon are also meeting within the next month or two to probably raise their targets again. So for what that's worth as well. I agree with comments regarding the look back period. It needs to be 10 years because of what's already been stated, and anticipating and hoping that, you know, over the next couple years of data gathering, that there will be flexibility to move those year to year closer to that 4% range where realistically it really should be.
We'll go to Stacey Rates and then Suzanne Usage virtually.
Thank you. And, you know, I think we all agree that we want affordable, high quality healthcare with the greatest patient experience for everybody. And it's complex, as I'd mentioned before. But the 3% tied to a metric that's not connected at all to our costs, and you did have the factors listed that, you know, some of us think that should be automatically adjusted. Others would depend on the what's happening in that year in that specific area. But I think that we're not all starting at the same place. And I think that's what makes this a little bit more complex. Some of us take capitated risks, some of us are fee for service. And so every market is different. So we're applying one number to different areas and concerns that people may have. And we have significant cost increases that we know that are regulated in terms of the minimum wage and some other seismic issues and things of that nature that don't apply to medical groups, thank goodness. Our pharmaceutical trends, so yada, 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 all of that, aging workforce. But I would really support and consider to reduce the length of a period from 20 years to something less. Also, if you need to include quality in the equation. And I think if providers are paid on an alternative payment model and they have high quality scores, I think we should consider something different. Actually, ties to actually what David said. But I wrote my notes on the plane. And then I think we should look at those factors that we all are facing that should contribute to an adjustment to the 3%.
Thank you. We'll go to Suzanne and then Andrew and then Joan.
Hi, everyone. I just wanted to emphasize the idea that 3% is that target goal. I really admire OCA's focus on making progress and allowing us to implement something that will really help take a bite out of the elephant, so to speak. You know, how do you eat an elephant? One bite at a time. And I think we've built a lot of good things, or I've seen a lot of good things built to help protect entities that do need some time to scale this or to figure out where it needs to go. But I think the office sounds like they're really prepared to also shift and accept any other changes that have happened either in the market or otherwise. This is coming from the perspective of understanding that defining affordability is different. I think we had a couple really lively but productive discussions a couple meetings ago talking about affordability likely being defined by many as needing to be less than 3% because healthcare had grown so intensely over the last 15 or so years, and it has drastically outpaced other costs. However, 3% is not being defined as what will make it affordable. It's how do we go in the right direction and create the structures and very likely innovation. I think that was talked about earlier. This is kind of the initiating piece for me to help make sure that at this 3% target, we're looking at it as a place to create that space for innovation, as opposed to kind of continuing on and allowing whatever the players are that come into it, not people or entities, but the pieces of the system that haven't benefited anyone so far, allowing those to kind of come to light and flush themselves out. So just want to reinforce that I appreciate that the 3% target recognizes both the need to be affordable, and if the comment earlier that negative growth would actually be affordable, maybe that's not sustainable for others, and we want to make sure that the entities and structures that actually would be providing that care are not harmed or disincentivized to actually help make sure we get to the goal together.
Thank you. Andrew, Joan, and Anthony.
Yeah, so I guess I don't know if Michael, there was a question earlier on Connecticut and I think Rhode Island. I don't know if you have an answer. The other thing is, the period that even brought up is, inflation hit late 2022 and onwards. And thank you for highlighting our good historical performance. Nobody really tells me this stuff, I always look forward, but yeah, I mean, it's case in point, right? That's the history, and the inflation hit us end of 2022, 2023 and forward. So, our goal is to look forward, right, and set the target forward. And I don't know, Michael, if you can answer the other state's question.
Sure. Yeah, Andrew, I can confirm Rhode Island and Connecticut both made adjustments for the impact of inflation. Rhode Island did so for the years of 23, 24, and 25. The adjustments were greatest for 23 and 24, pretty small for 25. Connecticut did not make a change for 23. They made an adjustment for 24. And and per their statute, actually, they are obligated to at least consider the impact of inflation each year. So next year they will review inflation and whether they think it should or should not result in a modification to their 2025 target.
But Michael, what's the number?
So I don't remember what it is in Rhode Island. It's 3 different numbers. But I know what it is in Connecticut because they just made that decision. So they went from their target, which is 2.9%, their long-term target, to 4.0% for 2024.
Thank you. Joan and Anthony?
So I support the 3% target because what we're doing right now obviously isn't working. The underlying premise of the statute is that what we are doing isn't working. And so when I see the concerns and I see we need it this high in order to not lose ground or in order to keep up with trend, all I see there is baking in what's already not working. And so we need to do something radical. I would agree with some of the comments that have been made that 3% is not radical. 3% is inherently incremental. But we need to actually start bending the cost curve. And so definitely support the 3%. Also, this speaks to me, the discussion here, for the need for better data. And that if we can't start to unpack what's inside the numbers that I'm seeing in the concerns column, if we can't know of those percentages, how much is supplies, how much is shareholder dividends and profit, how much are the various factors, we can't really see which are the places where we need to invest more and where are we safe to really cut pretty deep without impacting care or quality. And so just support full speed ahead with the recognition that the board can come back each year, come back frequently to reassess that target, make sure we're on the right track, but that to inform that further down the road, we're going to need a lot more data about what's going on under the hood at these entities, and that those are going to be some tough conversations. And I hope that we are all ready to confront what that shows.
Thank you. We'll go to Anthony and then virtually to Hector, then Mike, and then back to Stacy.
Yeah, so I think in terms of the conversation of the look back, right, I think the data that we were presented earlier showed that if we do shorter look backs, it's a much higher variability of what that potential could be, from 1 to 4 or 5, cent, whereas you have a longer one, then it sort of helps smooth out. In the conversation that we were just having about inflation, right, there are some states that are talking about, in terms of the period that we just sort of coming out of, where we had a high inflation spike that is hopefully moderating. It is moderating now. We have data, suggest that, yeah, you want to take that into account, but you also want to spread it out over time. And so I think that is a better way to go and provides more consistency to the industry than something that was to sort of ride the wave of a 5 or 10 year look back, where it would be a lot more variable. I would also, and I do, so I would want to recognize this. I also just want to, as I look at some of the proposals for percentage for targets, that are, they're basically status quo or even maybe worse than status quo in terms of like the increase of costs. And then if that's where we're setting it, then what are we doing here? Like, then, what's the point of this exercise? What do we tell the public about what we're doing here if we're in somebody? Like, I appreciate that we're having this conversation. I think it's good that we're having this conversation because we have talked for decades about we should lower costs in the healthcare industry, and the fact that we're now at a table discussing like what should that target be, and it's very clear that we've been having very different conversations without knowing it. When I meant affordability, apparently some of the other people who are talking about affordability meant something completely different in terms of of this, and so it's useful that like define this conversation. So this is a really important conversation, but what are we actually trying to get to? And again, I do think that it's at an incremental, modest thing to say, can we at least make it so it doesn't impact? I do appreciate the comments about different people starting from different providers and entities starting from different places, and I think we should figure out how to move to that as quickly as possible. And then back on just the issue of the broader question of access, and we've already talked about how access is compromised now, but I do want to just get to this notion of, so a provider, an executive, a leader at a provider, I hope that we're not in a situation where a provider is looking at this to target and their first instinct is, okay, I'm going to close a needed service versus, okay, I'm going to try to find efficiencies in my system to provide this the service. Or, I hope that the reaction is maybe I'll modulate what I'm charging for this service, or how do I find efficiencies or whatever. But the notion that I would hope that a hospital executive's instinct is not, well, because of this target, I'm just going to close the service, rather than, well, if it's a needed service, I'll go back open. And especially in this context of progressive, and what will that yield? That will yield a conversation. Like, it's not like this is pure rate regulation, that this is something hard and fast. This is something where it's like, okay, if you do go over, and then you can say, well, I'm trying to keep these services open. There's issues about trying to keep services sustainable, but it seems like the incentives are problematic now, and I don't know how this would increase or decrease the notion of whether that would be the first or even second instinct of a provider to do that. So that would be my question.
Thank you. Moving virtually, Hector, Mike, and then we've got Stacy and Abby.
Thank you. So yeah, I wanted to kind of reiterate Stacy's comment and Anthony's, that not everybody's starting at the same place, and that's a really critical issue. For example, I trained at Kaiser and I stayed for 5 years, so I became a partner in the medical group, and there were 3 other colleagues working together that realized Kaiser back then, this is in the 80s, struggled with Medi-Cal, and as an insurance company, it had no game plan for the uninsured. And what took us into medicine was to serve people who were vulnerable and disadvantaged, like the uninsured and the Medi-Cal population. So we took everything that we learned from Kaiser, and we thanked them for what they taught us about prepaid medicine and investing that in prevention, population health management, and organizing care. Those are great principles that have helped our success in an underserved area. But the reason we left is that Kaiser was a different type of system than what our community where we grew up needed. And I think we need to recognize that very clearly. And it speaks into the earlier conversation we had about enforcement, that if some folks, some entities or part of the industry are starting, 100 yards behind, they're going to constantly look bad because they're not meeting the target. So I'm okay with the target wherever we set it as a target, but we need to also publicly recognize that not everybody's starting from the same point. And, part of the enforcement discussion earlier was that at some point, these organizations that don't meet the target are going to be called to the mat and publicly explain why they failed to make the target. I think that's going to give the public the wrong impression. What I would suggest, if we're going to follow this path, recognize not everybody's at the same starting point. 2, have OCA summits where everybody can bring best practices and have those that need to learn how to do things better, do it better. What I've seen in the recent months, the closure of labor and delivery services in many hospitals, my first reaction is, well, most of, half of all babies born in California are now covered by Medi-Cal. So it must be they're not making enough money because of the payers. But when I started visiting those hospitals, I realized the reason they were closing, not because they were callous about money, is they didn't have the workforce. They didn't have L&D nurses. They couldn't recruit enough OBGYNs. to cover the shifts without burning out their docs. And then there were resources that they couldn't provide the patients who came from long distances to get the care. So part of this is that we need to drill down and understand why everybody's starting at a different place, and to actually allow time to compensate for those deficiencies that we've created for the last 50 years. And that enforcement should be a proactive, non-punitive discussion about best practices, and not have it appear like a public flogging. So thank you.
Thank you, Mike. O'Day?
Thanks. I appreciate the work of the office and support the 3%. I think, we all know that not all spending is the right kind of spending. And I think when it comes to kids, we see that only 54% of kids in the state are getting any preventive healthcare visit. And that's some of the most basic things we expect from health coverage. And right, so we're paying premiums every month and not necessarily getting the services. And so it's hard not to think that they're without, that there's room for doing business differently, and that there's some efficiencies to be gained by having more investment in prevention, upstream interventions, and how patients experience and interact with the healthcare system. So to some comments that were made earlier, just thinking about how quality and value for our healthcare dollars kind of weigh into this as well.
Thank you. Stacey Hernandez?
Thank you. Yeah, I think I just want to bring in awareness of kind of the fragile provider community right now. We're on the heels of a pandemic. It's still here. And it took a beating on us. And I'm not sure people are aware, just my little community in San Diego, you have Tri-City, that's a distressed hospital fund. You have Palomar Medical Centers, that's really in trouble. Scripps announced last week they're closing OB in Chula Vista. And they just exited Medicare Advantage for their two main medical groups, which puts pressure on the community. And we hear others outsourcing their call centers. They're already making those decisions. They're at that point, Anthony, where they're having to survival. And so just a word of caution, and it's a balancing act like everything else, but just, the provider community is not in a great place right now, for what it's worth.
We'll go to Abby Yount and then Carmen Comsty.
Yeah, I just had to look back at my own notes to refresh that the base year is yet to happen. It's 2025, right? And we experienced in our plans an overall increase for the 24 plan year, 9.5%. And that was for 24. And so to think about the luxury of having a 3% would be extraordinary at this point in time. We'll be exercising all our muscle in bargaining this year to try to get as close to that 3% or lower for all of our plans, but I don't know that that's going to be realistic. The other concern that I hear coming up over and over again, and it just baffles me, is quality should be a gate. We shouldn't be negotiating incentives for quality when the quality standards have been there for a long time. And there are many best practices, and I know many of you and your organizations work hard on performance improvement and changes, but it's not enough. The outcomes are still far from what any of us want them to be. So I think we do need to have quality as part of the discussion, but I wouldn't put it in as you get a reward for doing what should be done anyway. So thank you.
Thank you, Carmen Comsty, and then it looks like we'll be able to move to the next slide.
Yeah, hearing everyone's discussion, I think going back to, our earlier discussion, which is, what are we doing the target for? And I think one of the questions when it comes to the enforcement side is trying to answer what is actually being spent on, because I think Hector's example of let's not publicly flog regulated entities if it's an issue of workforce and not blame them for trying to profit off of money. That's an open question. I know that there are some hospitals, healthcare systems who closed maternity wards and behavioral health wards, and a particular one that is looking to close its trauma center where there are workers who will lose their jobs, and it's not an issue of workforce. And I think this is one of the questions of why we want to get to the question of whether or not regulated entities are actually meeting the 3% goal, and trying to figure out, what is actually pushing up, what is being spent on. Is it really? It's basically calling the question. What are you actually spending your money on? And we need to get to that answer. And I think setting a good goal, we've had this discussion before, setting a really ambitious goal and trying to open up the conversation so that we can have those conversations about best practices, or where there is problematic spending that is happening and where there's good spending. And if we don't have those conversations to begin with, we're never going to be able to build the programs to, whether it's addressing Medi-Cal reimbursement rates, or whether it's, a workforce issue to train more behavioral health or L&D, providers. Like, we need that discussion to happen. And if we aren't putting ourselves with an ambitious goalpost, we're never going to answer those questions. So I think the 3% is a good place to start, and let's start there. And then let's figure out if there's things to adjust. And I think, that is what, looking back at our discussion earlier, is like, we want to have this public discussion. I don't think people are going to publicly flog, places if they have legitimate reasons for why their costs are higher than the 3% growth rate. Like, I think we want to find the where the bad actors and actions are, and to do this publicly. And I think that's really, I keep on going back to, I know that we're not, with the progressive enforcement, we're not getting to the fees just yet, but like, there are really important things there that we can get to, and asking regulated entities to basically show us your books, prove it is really important. So I think, we should stick to where we had the discussion a few weeks ago, which is, let's stick to the 3%.
Ken, we were going to take final comments on this slide.
Yeah, I just want to add to this, and piggybacking Joan and Anthony's request to use data. Ideally, from a purchaser standpoint, for years we've been looking at using our data to identify the providers that deliver the best outcomes, and to use that data to then integrate that into plan design to shepherd our participants where they'll get the better outcomes, and to reward the providers that render the highest quality of care. So I think that has to be ultimately a target of using the HPD type data and factoring that into the equation. If we get, we always believed if we got our participants to the right doctors in the first place, everything would work its way out, because there'd be more responsible use of hospitals and better outcomes.
Thank you. Returning to our presenters.
All right, so we're going to turn our attention a bit from the target value itself and into some comments that we received related to the target setting methodology. So some of the concerns were that without incorporating inflation projections in the spending target, the state's healthcare system will be unable to afford medical supplies and upgrades to its physical and technological infrastructure. That a 3% target is well below inflation projections for California and would remove $4 billion annually from the healthcare system, ultimately impacting quality and access to care, as well as investments in care quality improvements. Historically, other spending states have struggled to meet the target and had to readjust the target. COVID-19 significantly impacted hospitals and could face similar pandemic events in the future. The proposal does not take into consideration market growth for healthcare worker wages, and that proposing an adjusted target based on median family income growth is setting a target lower than the recent year's GDP growth, making California an outlier when compared to 8 other states with similar cost growth targets. Supporting the methodology was that 3% exceeds recent inflation projections by the Department of Finance and the Congressional Budget Office for 2025 and beyond. OCA's 3% spending target puts California squarely in the same range as other states. Other states with cost commissions have targets for 2024 through 2027 in the range of 2.8 to 3.3%. A target of 3.5 or 4% would be far higher than targets in other states. The recent spate of inflation will already be built into the baseline and not need to further influence the growth target. The 2025 target will be reported in 2027, and by then the inflation of 2022 and 2023 will be years in the rearview mirror. If there is a reversal of trend, the board has the flexibility to review the target. After years of conversations and now implementation of the new Office of Healthcare Affordability, Californians should not have to settle for a target that is less ambitious than what Washington, Oregon, Massachusetts, and other states around the country are using for a goal in the next several years.
Okay, any additional advisory committee member comments on these concerns and messages of support? Okay, I see that as a sign to move on to our next slide.
Comments pertaining to the target setting methodology and concerning the theme of adjustments included the following. Aging is projected to increase healthcare spending by 0.7% annually. The increasing aging population of California results in higher costs of care for healthcare entities. Government reimbursements for Medi-Cal and Medicare has not kept pace with rising cost of labor, supplies, and drugs, leading to fiscal losses for safety net providers. There was a comment about the MCO tax and failing to account for this critical new spending that will improve access to care for Californians when setting the spending growth target undermines all the work we are collectively doing to improve patient care in the Medi-Cal system. Another comment noted that the methodology does not account for the cost of new healthcare technology. Another commenter noted that the methodology doesn't take into account the rising costs due to key industries, rising costs such as insurance companies, pharmaceutical manufacturers, and pharmacy benefit managers. There was a comment about the 2030 seismic operational mandates for hospitals and how they're unfunded and require hospitals to take loans with interest rates greater than 3%. I'll now shift over to the comments in support of the target setting methodology and its approach for adjustments. The first is that OCA should not apply any prospective adjustments to the target that may increase provider/plan costs. These adjustments are speculative and hard to quantify in advance. There will be a mechanism to account for major unexpected cost drivers in retrospectively assessing entities' performance against the targets in future years. The next comment noted how OCA should quickly set sector targets, whether they be geographic, industry, or entity specific. A statewide only target allows high cost providers to increase costs at the same rate as low cost providers. The focus should be on high cost outliers and set their target below the statewide average. Writing in support of OCA suggests a statewide spending target of at most 3% without any further delays and without population or new technology adjustments. This target makes sure that healthcare costs don't outpace what everyday Californians can afford. Now return to the facilitators.
Members of the committee, any comments or reflections on this input about adjustments? Yes, Andrew C.
Yeah, so probably repeating David's comment from earlier. I mean, there are items that we know, right? So we should start with healthcare costs as we know it. I'm make an adjustment for affordability, right? I'm not just saying build up your costs, but just start with a number that's realistic. It's realistically aggressive and glide path to a number, that that we're targeting based on income, right? It's just there are things we know versus doing it after the fact, where lots and lots of entities will be filing lots and lots of I don't know. It's again back to platoon of actuaries. I don't know if you can picture that. After the fact, trying to justify why there's overage. I'm not sure that's what we want to do here.
Other comments, questions, reflections? Yes, Karen.
Just a question. Sorry, I stepped out for a moment, so maybe this was covered, but the MCO tax piece, I just want to confirm, because my understanding is based on when that's happening, that'll be sort of built into the baseline as opposed to be a new or additional expense. Is that correct? Because I know that came up a lot in the concerns, but I'm not sure that it's accurate.
The first set of targeted rate increases became effect for, as of January 1st of this year. And there is some time for the MCOs to kind of cascade that down to providers. And then the second set of targeted rate increases, which I believe still need to, get a formal SPA or state plan amendment approval. But those are targeted for January 1st of 2025. So those would be in the baseline. But then there's other investments that are also being made that are kind of multi-year all the way through. The spending plan goes through 27, 28. And if it's not part of the baseline, then we would, contextualize that spending growth.
Okay, so based on what you proposed, that seems like maybe less of a concern than some of these other things. So I appreciate that clarification, because I just want to make sure we're all talking about facts here. And then the other piece is just, we've had all these conversations before, but just to put it out there, I do think some of these adjustments that are listed are real opportunities actually to reduce costs. I think we have an opportunity to do care better in a lot of these areas that will also reduce costs. And I consistently think about aging as a real opportunity to lower costs by giving better care to people who are aging and making sure that people are aging in the community as opposed to very expensive institutional settings.
All right, David Joyner and then Sumana Reddy.
I don't know why, but when Andrew talks about armies of actuaries, I have zombie movies in my mind. But I just want to make a comment about this, which is, if you think about it from the point of view of a healthcare provider, you provide services to patients, and you have different payers: Medi-Cal, Medicare, commercial insurance. And at the end of the day, you have to make sure that you have enough revenue coming in to cover your costs. And the thing I'm concerned about the direction we've been taking today is that, first of all, we're setting a target that has nothing to do with medical cost inflation. It'd be like a little bit like saying, we're going to set a target for how much gas should cost in this state. We're going to ignore refining capacity and production and supply and demand. We're just going to say household income, and it can't go up by more than that. And yet the economic forces underneath the production of that product are nothing to do with that. So I've already made this point, I realize. But the other thing I'm thinking about from the point of view of provider is, we all know that Medi-Cal, even though I know people say it's actuarially sound, it's not economically sound. It's very low reimbursement. You have Medicare, which is set by the federal government, and we've said basically those two we're going to basically ignore because it's outside of the control of this process. Then you have self-funded ERISA plans, which is also outside of this. So I think you end up really focusing on commercially insured, fully insured business in California, which is a very big subset, but it's a subset of the total picture. And I'm worried that we haven't really thought through the unintended consequences of what happens when, for example, Medi-Cal and Medicare don't keep up with the cost inflation, and the providers have to somehow make the revenue add up to cover their costs. And you're seeing this with rural hospitals, I think, is the canary in the coal mine for this situation. And we're meanwhile going to say, well, the commercial insurance can't go up by more than 3% because we've set this goal. And I don't think we've thought through the implications of that completely. And especially the fact is, employers can decide to switch from fully insured to self-funded if they want to avoid being a part of this process. And I think to our earlier conversation where we started this morning, rich HMO benefits have much lower patient out of cost and therefore much lower bad debt and bankruptcy and concerns about that than your PPO plans that can have very high deductibles. And so I'm just, again, I think the history of economics would show whenever you place some kind of a price kind of goal or target, the thing you got to watch out for is unintended consequences. And I think as I think about these factors, both the unintended consequence of the cost shifting and the unintended consequence of moving to from fully insured to self-funded, which by the way also means that the state benefit mandates no longer apply also, which is a consumer protection. So, and I know that we have a goal here that we want to increase the number of members that are in APMs, advanced payment methodologies. But self-funded ERISA plans that are fee-for-service don't apply there. They're going to be fee-for-service by definition. So I just have a concern about this set network of unintended consequences.
Thank you. Sumana Reddy, and then Ivana Kristinovic, and then Barry Arbuckle.
Small question / comment on a monograph that's been included from Berkeley, a new vision for California's healthcare system, integrated care with aligned financial incentives. And the reason this just raises a lot of questions for me is, one, it is a decade old, and I looked through it, and all of the information is from that time. And what I didn't know 10 years ago is that small, lean primary care has power in aggregate, and I don't think we had that data. And because this group is largely large payers, I'm just curious if anyone else has thoughts or comments on that, because I couldn't have known then that there is real potential on cost savings by supporting on the ground groups. Because why? By not being integrated, we're not beholden to or needing to refer to or requiring to support the larger aspects. And I know that's selfish, but on a public health level, it works and probably works more effectively. So I wonder if anyone else had looked at that or had thoughts on it.
Thank you. And while folks think about that, we'll turn to Barry Arbuckle.
There was someone before me, I think, but I was going to respond to Dr. Reddy's question. I know the authors of that. I was actually participating in that little exercise some years ago. They have a newer version of that now, and to respond to your question about the integrated systems being able to provide better value, as opposed to what I think in the fee-for-service model, what you're concerned about is the primary care doctor being pressured to refer to the specialist within the group, and they have to go to the hospital at the higher prices within the group. If that system, if that integrated system is paid under an alternative payment model where there's a real downside risk, they think that is the better model, and they actually call it the Better Care Plan. It's the newest publication from that a similar group. So if you don't have it, I can send it to you.
And my apologies, Ivana Kristinovic, please go ahead.
I was going to actually respond to David, so that's fine that you guys got to have that interchange. You know, when you talk about unintended consequences, I have more data. In 1996, San Francisco employers contributed $267 per month per eligible employee, and they're self-funded, right? 23 years later, in 2019, San Francisco employers were contributing $1,932, or 7 times more than in 1996. If the contribution for healthcare had stayed the same as inflation in those 23 years, workers would have taken home an extra $200,000. So that, like, we talk about unintended consequences. Nobody has talked about who's picking up the tab. And for years, it has been working people, commercial insurers, you know, payers like Abby and like, you know, our group, Ken's group, you know, so, you know, tables are turned now, and the industry is going to have to figure it out, how to bring these rates down, because we can't just, you know, keep doing it. Those same San Francisco workers in 1996, 13% of their compensation was going to healthcare. By 2019, it's 32%. A third of their compensation is just going to pay for healthcare. It's not sustainable.
And Barry Arbuckle.
This is a follow-on from David's comment a moment ago, and it's It's a question that I think I should know the answer to, but I'm rather chagrined I don't. And that is, I was making an assumption when we set a total cost target, let's just use 3% since it's what's on paper today, that for a hospital, if 70% of, I'll say 60% of their payer mix is a combination of Medicare and Medi-Cal, Medicare increases year over year, maybe 2.1%, and it's dictated, we can't do anything about it. Medi-Cal, 0, that's what history has been. That therefore then that other 30 or 40% of their payer class, which is commercial, could be at 5 or 5.2%, which would average out that entity to 3%. If I can't do the math like Andrew can, so I'm making these numbers up, but you get my point. Is that the way we're going to look at it? Are we looking at every single sector where Medicare guaranteed to be below 3, Medi-Cal guarantees below 3, and then commercial is, if it's below 3, then those hospitals are using that 3% to make up for all the underpayment from the government? If my question there.
We'll be looking at performance by market. So, through the payer data, and for provider entities, especially the physician organizations for hospitals, we're still working on that. But we would be able to assess performance against the target for your Medicaid line of business, for Medicare, and then by commercial.
So no, I mean, I don't think it is as you state, Barry. I mean, we'll be looking at commercial specifically and applying the 3% for commercial specifically.
To an entity.
Well, we are still, as Vishal noted at the beginning, we're still figuring out how to measure hospital costs because it's not as simple as, for a health plan can say we're capitating these HMO patients for this amount, and we're still figuring out how to measure hospital costs. So that is still under development.
So Sumina Reddy and then David Joyner.
Super delayed reaction to Barry, but if that's the case, then we don't have any work here, right? Like if it's true that these integrated health systems can in fact deliver much more efficient care, and we don't have to worry about the specialists and the OB and the perinatal group and the cardiac surgery because they're all going to figure it out, then there is no other objection, right?
My only answer to that, I believe, and I think the research from the Berkeley group would support that in an integrated delivery system that's under an alternative payment model. So they must be at risk for the health of the population, period, end of statement. That model solves a lot of the stuff we're trying to do by playing whack-a-mole, by controlling the side of care through regulation, by tamping down cost over here, by referring specialists too much, by overdiagnosing, overtreating. It takes care of itself because it's your money you're playing with, and you're not going to do that. That would be my argument.
Yeah, so we're just all in favor of that, and we got to get there fast, is what we're agreeing. Okay.
David Joyner.
Vishal, I just want to make sure I understood when you said we're going to do it by market. Did I hear you say essentially you're going to measure, say, Hill physicians against our Medi-Cal? How did that go against the 3% target separately, the Medicare Advantage, separately the commercial? And in other words, if you're below the 3% in one line of business, it doesn't give you any credit on any other line of business. You're going to measure each one separately. Is that what you said?
We are going to measure them separately. So if you're let's say you're over for the public programs for Medicare and Medicaid, but you're compliant in commercial, and there's some other program changes that were kind of coming down the pike from CMS or from DHCS, we would take that into account. But we are going to look at it by market.
Hector Flores, we see your hand. Please go ahead.
Yeah, sorry about the disjointed communication, but back to Dr. Reddy's question. Kaiser is the ultimate integrated delivery system, and certainly on the physician side. But it's the culture that they have is that their hospital system and their medical group are cost centers. So they're not looking at, hey, how can these entities that are under the health plan need to make more money? It's how can they make the budget that we get from the purchasers useful to the patients that we serve, right? And we could argue about whether they cut corners or not, but the bottom line is their ethos is, hey, we're a cost center. Let's figure out how we can do this more efficiently. The other thing about Kaiser, it's physician led, and it's no accident that that's part of their success formula. And in that part, the culture of the medical group is that they realized years ago they needed to increase their primary care cohort because primary care does save dollars downstream. And secondly, that they needed to recruit specialists that had a different orientation about their profession rather than just, being paid what everybody else in their specialty was being paid. So when you look at Kaiser's model, it's their medical group and hospitals are cost centers. Their attitude is, hey, we spend so much money on hospital in the past, how can we do it for less and still get the good results that we get? And on the medical group side is, say, how can we entice primary care where the ounce of prevention saves us the pound of cure, and create a culture for the specialists where they accept less money than they might otherwise being in the non-Kaiser world. So that getting to that point is going to take a while because the culture of how physicians today are being trained is not the Kaiser way of doing things. It's how can I get out of this training program and go into a practice where nobody's teaching me how to practice, so I'll just figure out the payer mix that I need to have the livelihood that I need. I think those are important elements that took Kaiser 50 years to get there, and we don't have 50 years, but we're going to need to be realistic, and it's going to take some time. Thanks.
Okay, Anthony Wright. And then I think we may be in a position to move on to the next slide.
A couple of things. One is I think the sort of the sentiment I've heard about that, whether it's talking about HMOs or integrated healthcare, whatever, I think there is actually some consensus that that's where we want to move to. And, the IHA did a presentation to the FSSB like last month that suggested that there's actually a lot of those integrated systems are at sort of like that 3% range already. So by definition, this target would actually largely say like that's fine and focus on where the areas are, which is the places where there is the uncoordinated, more expensive, more disjointed care. And I think that's the appropriate place where attention should be paid. I want to be, and so there might be, I want to take into consideration the fact of where providers are, and I appreciate we've all been through the ringer with the pandemic and everything else going on. So I think we're mindful of this. I see that there are some, the healthcare system is full of haves and have-nots, and so there are real issues. I see, but I don't know if but those issues are happening now, right? Some of those closures, some of those issues are happening now because of whether it's payment or management or other issues. I don't know if the cap would have an impact. It's almost, if somebody used a metaphor of gas prices, I would use the metaphor of a speed limit, right? There's this is a speed limit for the folks that are testing that, but there still needs to be help for those cars that are struggling to get the right gas or the other issues that are on the road. I'm not to extend the metaphor to drunk driving or bad drivers, but the point with the speed limit also is that we're set a speed limit. There might even be some variability in enforcement because let's face it, you don't necessarily get pulled over for 66 or 67, but and people will pay more attention to those drivers that are driving 90, but you also don't want to put it in a situation where we're just going to enforce whatever the speed of traffic is, because then you're the freaking Autobahn, and that's not safe. That's not safe for patients. So I think that we can be I think that this is an appropriate target, and I think that part of it is the context of how it's viewed. If it's viewed as this punitive thing that's trying to punish providers, I don't think anybody, that's not certainly my intent coming to this table or anything like that. It is actually to try to identify what's going on in our healthcare system, and hopefully we can better identify, some of the issues that are underlying, and also shift resources to more integrated systems and right care, right time, rather than to the things that are driving our healthcare costs and creating an affordability crisis for patients.
well. Okay, we may be ready to move on to the next slide. I'll turn it back.
All right, so moving on to the theme of the economic indicator. Some of the concerns were that the office is yet to collect data to inform the establishment of a credible, attainable target. Using a 20-year period for the historical median income is flawed, skewed, because it includes the Great Recession. Using a 10-year period instead is more representative of the current climate. It is more realistic to base the proposed target on projections for median household income growth over the next 5 years. It is more appropriate to look at the median income over the last 10 years, which is 4.1%, and the current projection for median household income growth for 2026, which is 3.6. In support, a longer look-back period creates more stable spending growth over time and provides a steadier foundation to which the healthcare industry can sustainably and structurally adjust. The only metric that is tied to affordability relates to income. Other suggested metrics may be useful for management and analysis, but do not seem to relate to affordability. We should anchor the methodology on affordability metrics, not the spending trend. Using growth in median household income aims to keep household spending from growing no faster than income and help prevent further erosion of affordability. The first step in changing healthcare costs is setting a target that, for the first time, reflects the experience of consumers and other purchasers rather than letting the healthcare industry charge whatever it can. The board has discussed at length the critical importance of basing the spending growth target on median household income, which reflects the ability of consumers to afford both healthcare and coverage rather than the wealth of the California economy as reflected in measures such as GDP.
Any comments or discussion from the committee?
Okay. I could move on. These set of comments on the next slide concern the duration of the target. Comments that raised concerns suggested that OCA set a single-year target to allow time to resolve challenges, for example, staffing and labor costs, rising pharmaceutical, medical device, and supply costs, as well as potential for reduced federal program reimbursements, as well as provider attribution, Medi-Cal data collection, treatment of supplemental payments, and provider self-financing clarity. Another commenter noted that the statute allows for OCA to adopt a single-year target rather than a 5-year target immediately. Another commenter suggested that we set a 1-year baseline target for 2025 and use 2025 to collect data to inform the first enforceable target for 2026. This allows hospitals to develop ways to reduce costs / slow spending without major detrimental impacts on care, medical education, and research. Comments that were supportive of the recommended target duration noted a glide path or phase-in as of yet unspecified parameters that allows industry to grow that much further only prolongs the pain of consumers and other purchasers beyond the intent of the long debated law by allowing industry more time to undercut the need for change. Another comment noted that setting a 5-year target allows the board the flexibility to adjust the target if necessary, such as for an extraordinarily expensive new drug or cost savings due to widespread adoption of technology or other efficiency improvements. And back to the facilitator.
All right, any comment or discussion from the committee? We'll go to Andrew, see?
Yeah, so I'm a broken record. For me, it's really about multi-year, but with a phase-in or a glide path. I am team phase-in. And really part of it, I'm very sensitive that consumers and employers are kind of long suffering. But, just considering where providers are right now, where costs are right now, trying to get from right now to, something pretty drastically different, it's going to take time, right? I'm not a healthcare operator, but I'm told care transformation takes time. And, we need a multi-year period to get to a reasonable point, right? So just that's kind of just my advocacy.
All right, other comments, discussion? Yes, Joan Allen.
Given all the discussion we've had about it here, I'm a little surprised that there wasn't more representation in the comments about the idea of potentially getting to sector and entity-specific targets faster than 5 years. I'd just love to know if there has been any further development in that consideration in the recommendations.
Yeah, Joan, it was in a comment on an earlier slide. Yeah, some folks did suggest that.
Any final comments or yes, Abiyat?
Yeah, and I'd kind of like to challenge you that we are on a glide path now. And I think what I expect to see in my 25 rates should be getting us in that direction for sure, because we didn't get there last year. So I think that the industry has been on notice. We've been at this table. We see this coming. It's not like going to be a surprise in 27 when we have to settle up. But I think we have to recognize that the target 3% I totally endorse, but any target, I would imagine industry is on the glide path already, thinking about how to get there.
Any final comments or discussion on this item?
Oh, sorry, last uncategorized comments that we wanted to make sure were noted were on the concerns column was that OCA has not communicated rules around how the data would be analyzed. OCA has not yet laid out rules for how entities would be held accountable to the target. And according to a 2019 California Healthcare Foundation report, prices for both inpatient and outpatient services increase when there's more market concentration or consolidation. If the board sets the healthcare growth spending target too low, high cost outliers will continue to be just that, high cost outliers, and smaller entities will give up and be swallowed up by larger, often more expensive systems. Setting the targets too low will drive the very consolidation that leads to the increased healthcare costs that you hope to prevent. And in support, the target should not simply codify the existing cost trends that led to today's crisis of affordability, where low and middle income families choose between getting care and paying for housing and other necessities. The target and other important elements of the law are designed to foster structural and systematic change that improves outcomes, quality, and equity while slowing the growth in healthcare costs. Spending that does not go to healthcare cost growth is available to other parts of the economy, starting with wages of workers who do not work in healthcare, but also other purposes of employers. The OCA staff proposal is not a reduction or a freeze, but a goal for healthcare industry to compete within the same constraints as a median California family. The health industry should not simply be able to charge whatever its inflated costs are and expect Californians to sign the check no matter the cost. Set a goal that is aligned with the actual experience of California families and give the industry the tools, flexibility, and incentives to innovate to meet the targets of lower costs and improved quality and equity.
Looking for final comments, discussion from the committee, and then we will move to public comment on this item. Right. Seeing none in the room and seeing none virtually, we'll move to public comment. At this time, public comment on this agenda item. Those in the room that would like to make a comment, please step to the podium. Those attending virtually, please raise your hand. Please limit your comments to 2 minutes if possible. Looking virtually, please go ahead. Looking into the room, please go ahead.
Hi, my name is Miranda Dietz, and I'm a researcher at the UC Berkeley Labor Center. This is a technical point, but given how much discussion there's been about the 20-year average, we wanted to just explain the rationale behind using that 20 years in our reports on spending, target methodology, and consumer affordability. So the 20-year average is both appropriate and informed by our analysis. So first of all, that 20-year average is what was used by the two other states, Oregon and Washington, who use historical data to set their target. The second thing is that that 20-year average will promote a more stable target value, so with less fluctuation than if you used a shorter amount of time. And then that 20-year historical average is also at least as good at predicting the next 5 years as if you used a 5 or a 10-year average look back. So in our comment letter, we looked at data going back to 1984 and compared sort of if you used a 5-year average, a 10-year average, a 20-year average to predict the next 5 years, like how well would you do? And the 20-year historical time period fared slightly better than the other options in predicting those future trends. So just a little bit of background on why that 20-year average we think makes sense. Thank you.
All right, looking virtually, if you'd like to make a comment, please raise your hand. Noting at this time we have roughly 50 virtual attendees. Seeing no hands raised, going back to the individual at the podium.
Hi, thank you. Ben Johnson from the California Hospital Association. Thanks for the conversation today. In our letter, we have proposed an alternative framework for setting a target that we believe would really credibly demarcate reasonable versus unreasonable spending growth by accounting for things like inflation, which would prevent OCA from actually seeking a cut in real healthcare spending given projected inflation going forward, and which has actually been ticking up lately, according to the most recent estimates from the Legislative Analyst's Office. For technology and labor as well, because we want Californians to be able to access Ozempic and other new drugs, as well as access healthcare providers. For policy changes like Medi-Cal Managed Care Organization tax, where really most of the increases do take effect in 2025, so they're not in the baseline, which we would consider 2024, the first prior year of the spending target. And then finally, for the growing needs of Californians due to demographic change. The framework we propose yields, at least in the first year, value of around 6%, which is very closely aligned with what Rhode Island recently adjusted their target to be, and then in subsequent years goes down to around 5%. Again, consistent with what Rhode Island does, at least in the earliest year. So it is not out of line with the most recently adjusted or set spending targets being considered or put in place around the country. The framework that we lay out, it can be used in various ways, one as a methodology, but also for assessing the reasonableness and achievability of the spending target, or to provide adjustments to one based using a different methodology. And then finally, we do ask OCA to consider a one-year target to allow the OCA to actually collect data before setting a spending target to make progress in terms of defining how enforcement is going to take place and to meaningfully assess the impacts of the target over the longer term before setting that multi-year and enforceable spending target. Thank you.
Thank you. Looking back virtually, if you'd like to make a comment, please raise your hand. Seeing none. Looking back to individuals in the room, seeing none at the podium, that concludes public comment on this item.
For this next agenda item, Assistant Deputy Director Margaretta Brandt will be providing an update on our progress on workforce stability standards.
Good afternoon, everyone. So as Vishal mentioned, I'll share OCA's draft workforce stability standards and monitoring metrics and solicit your feedback on these draft proposals. So as kind of a starting point and a refresher, For OCA's enabling statute related to workforce stability mandates that by July of 2024, we will develop standards in consultation with the board to advance the stability of the healthcare workforce. These are non-enforceable standards that will be used to monitor workforce trends and promote workforce stability alongside the spending growth targets. So OCA is charged with monitoring workforce stability in 3 ways. So monitoring the effect of the spending targets on workforce stability, ensuring that workforce shortages do not undermine healthcare affordability, access, quality, or equity, and promoting healthcare affordability while also recognizing the need to increase the supply of trained healthcare workers. And so in addition to general workforce stability standards and complementary monitoring metrics, the statute also specifies that OCA may require a healthcare entity to implement a performance improvement plan if spending targets are not met. And that performance improvement plan can include workforce stability standards. So currently our focus is on developing the general standards mentioned on the previous slide, and these general standards would be used to inform the standards used in a performance improvement plan. So this slide provides an overview of our work to date and the progress we've made so far. So we are working with the Institute for Health Policy Studies and the Health Force Center at UCSF to support the development of these standards. And this slide just outlines, as I mentioned, our approach. So we previously completed an initial round of the 23 interviews to solicit feedback from a variety of stakeholders on the standards and metrics. And throughout March, we are conducting a second round of interviews to solicit additional feedback on our draft standards and metrics. And then from March through June, we'll revise these standards based on input also from the advisory committee and the board, looking to adopt final standards in June. So a few key takeaways from those interviews that I mentioned. So we interviewed content experts, stakeholders, including some of you all on this advisory committee, to solicit their input on the standards and how kind of they interpret it and what they're looking for in the standards. And a full list of interviewees is in the appendix. So some of the key takeaways are highlighted on this slide. And from interviews, we heard that, you know, interviewees are looking for the standards to lead to transparency around healthcare entities' staffing models and costs, that the standards could help identify and plan for workforce shortages and could contribute to improved quality and lower costs. Interviewees also pointed to challenges in applying statewide standards to the diverse array of healthcare entities in California, and the potential for rigid standards to inhibit innovations in care delivery. Reporting burden, especially for hospitals and publicly funded clinics who are already subject to significant state and federal reporting requirements, was another concern. So, and then lastly here, interviewees were divided in their opinions about whether the workforce standards should apply equally across settings and occupations versus focus on certain settings or professions. So some suggested that OCA could focus on high-cost, large employers like hospitals, while others recommended focusing on settings that employed more unlicensed or non-unionized workers, such as skilled nursing or long-term care facilities. Some stakeholders also suggested that OCA look at settings where there is current little regulatory oversight, such as physician's office. And we have noted that outpatient offices, aside from community clinics, are an important gap in our current publicly available data around workforce. So I want to note that we are still in the process of gathering feedback on our initial draft standards. But you know, based on our advisory committee timeline moving earlier to March, we wanted to solicit your feedback today. So kind of before we get into some of the more details about the standards, wanted to emphasize here that in terms of who the workforce standards apply to, so the statute specifically references the non-supervisory healthcare workforce workforce or frontline healthcare workers. And so based on this language, OCA has interpreted statute to mean that the supervisory workforce, including physicians, dentists, pharmacists, is excluded from the workforce stability standards. And we heard from several interviewees that OCA should include supervisory workers in our standards, pointing to issues such as primary care provider shortages, or the fact that increasingly physicians or other providers are employers or employees of large health systems and do not function as independent practitioners. For now, OCA will collaborate with our fellow office, the Office of Health Workforce Development in HCI, to understand the physician workforce, and we may consider broadening the scope of our standards in the future. So based on the interviews we conducted and the data set and metric reviews that we did with the UCSF team, we developed a set of principles to guide our workforce stability standards and metrics. So these guiding principles we have used to inform the development of the standards and metrics, and they include addressing current challenges in the workforce. They also include looking at monitoring for emerging workforce shortages to plan for future needs, incorporating flexibility, comparing workforce composition across similar healthcare entities, and tracking graduations from health profession education programs alongside licensure requirements. So these efforts, these principles aim to improve the match between workers entering the workforce and existing needs. And then our next set of principles is focused on including promoting diversity in the workforce to address the need for culturally and linguistically competent care for all Californians, tracking the impact of spending targets on the most vulnerable workers and communities, and then considering trade-offs of focusing on monitoring efforts on the highest cost and already highly regulated settings versus least regulated settings. And also, as I mentioned earlier, that our interviewees suggested that OCA should considering monitoring for indicators of insufficient training of the workforce at the facility level, such as sentinel event and workers' compensation claims. And that's something we're still looking into, and that OCA should minimize reporting burden on healthcare entities. So in looking at these principles alongside the domains of workforce stability that are included in training, included in the statute, which are training, job quality, labor cost, and workforce adequacy and equity, we developed the workforce stability standards and metrics that you'll see in a few slides. And before I share the standards, I wanted to share our approach to the standards and the metrics. So we have approached the workforce stability standards as a set of best practices for healthcare entities to adopt and to implement. So we are strongly encouraging entities to gather and monitor key performance indicators to assess their effectiveness of achieving a stable workforce. And we propose a monitoring approach that relies on publicly reported metrics to provide insight into workforce stability at the organization and market levels. And OCA may introduce benchmarks in future years after establishing baseline on the proposed metrics. And we may also consider requiring reporting in future years to fill any gaps in the currently publicly reported metrics. So these next two slides outline our draft workforce stability standards. So we are proposing 6 standards to ensure workforce stability in the context of the spending targets. So given the absence of evidence to support setting specific benchmarks for performance and workforce stability at this time, as I mentioned, we're defining standards as best practices for organizational behavior rather than minimum performance expectations. So the first draft standard directs healthcare entities to monitor a set of key performance indicators for workforce stability. And some of these indicators, many of these indicators were emphasized in our key informant interviews and our other interviews. So they include turnover and retention rates, job satisfaction, and investment in workforce training, among others. And we may consider requiring additional reporting on these metrics, but at this time we are requesting that healthcare entities track these metrics if they are not already. And our second draft standard on the next is to focus more, The second draft standard and those on the next slide are more best practices that entities should strive towards. So they include in the second standard developing formal processes to adapt to changing workforce conditions. And our third is focused on investing in training opportunities for workers, such as career ladders to support the advancement of entry-level and non-clinical workers, increasing the use of team-based care models that improve quality, equity, and efficiency of care, centering culturally and linguistically competent care, and finally, treating workers as key organizational assets that can drive performance improvement instead of a cost center to cut under financial pressure. So now that I've reviewed the standards, I will move to how we're looking to monitor workforce stability and at which levels. So we plan to monitor workforce stability at both the employer or the organizational level and the labor market level. So employee wages or contract nursing hours would be examples of organizational level metrics. And then at the labor market level, we can look at monitoring metrics of the overall functioning of the healthcare labor market within various occupations or regions. So the number of new graduates entering the job market and the demographic distribution within occupation would be examples of labor market metrics. And we're mindful of the interactions between these two and how they can influence each other. So here on this slide, this provides just a few examples of some of the organizational level metrics. So here we're sharing a few examples on this slide, and then in your appendix is our full set of monitoring metrics. So we are proposing to monitor workforce stability at the organizational level using several HCI data sources. So for example, for hospitals, HCI collects data via the annual hospital financial disclosure reports, and many of these data are helpful in terms of monitoring workforce stability. So for example, one thing we plan to monitor is average hourly pay for various occupations within a hospital, including nurses and food service staff. In this next slide, and sorry, before I move on, wanted to note that in addition to hospitals, we will also look to track similar metrics for nursing homes and community clinics using data also collected by HCI. And so for workforce stability metrics in terms of the market level monitoring, these are again a few examples with the full set in your appendix. So at the labor market level, we're proposing to track metrics from a variety of state and national sources. For example, the California licensure boards and the HCI license renewal surveys can tell us the demographic factors of various licensed professionals. The U.S. Integrated Post-Secondary Education Data System reports the number of degrees conferred, including the racial ethnic makeup of graduates across the state and by region for many health professions. And we propose to track several data sources for registered nurses specifically. And so all of these market level metrics will allow OCA to report on workforce diversity, look at interpretations of appropriate workforce supply, and to identify trends to reveal potential workforce shortages. So to wrap up, wanted to share our next steps. So we are currently, as I mentioned earlier, in a process of soliciting thorough stakeholder feedback through interviews and surveys, as well as collecting all of your feedback today. In addition, we're collaborating with our colleagues across HCI to review the proposed metrics and explore opportunities for future data collection. And we'll present our draft standards to the OCA board on April 24th. and also release the draft standards and metrics for public comment at the end of April. So I'd welcome the suggestions and feedback from the advisory committee on these standards and metrics.
Comments from the committee? Yes, go ahead. Sorry, yes, Sarah, go ahead.
Just making sure. I just renewed my license, so was able to complete some of the HCI information. I thought it was great that we were collecting it. I have a question about the turnover rate, and something that we're looking at in our health care organizations across a few counties is looking at turnover by position type, not just site facility. And I'm just wondering if that's something, because we're seeing higher turnover in certain positions. So when you think about interventions to support reduced turnover, it aligns usually with those positions.
Thank you. So I think in some of the HCI data, specifically hospital and community clinic data, you can infer turnover by position type, but we would also in the standards, are encouraging healthcare entities to track turnover, and we can add more details to the standards if that would be helpful.
I have a question.
I've got a couple lined up for you. Oh, is
sorry.
this for this?
Oh, sorry.
Okay. I've got Janice O'Malley, Ken Stewart, Carmen Comsteed, Joan Allen, and then we'll go to Abby Young. Sorry, Abby.
So because the workforce stability standards, as you're collecting data, it's not mandatory that these providers provide this information to OCA. How is OCA going to track the lack of data that's not being provided by entities, and then also following up with those entities to ensure that that information is actually collected?
Do you mean in the publicly available reports or in the proposed metrics within standard 1?
So when we track this workforce stability standards, I think there are key performance indicators that you are tracking for, I guess, the relevant metrics to monitor. So if that information that you're trying to collect from these providers on turnover rates, retention rates, vacancy rates, job satisfaction, how is OCA going to ensure that information is actually collected?
So at this time, we are not proposing to collect those key performance indicators from healthcare entities. We would use the metrics that we shared in terms of the market level and the organizational level metrics to track those workforce metrics, and then publicly report on those metrics and look for trends. So look for outliers, set kind of baseline data over the next few years, and look for trends over time and outliers, and dig into kind of the reasons why there might be those trends and outliers.
I think there are some metrics when it comes to, especially for hospitals, that have really comprehensive, that are pretty comprehensive, but they're not as comprehensive in the other providers like community clinics and skilled nursing facilities. And so I would suggest that that information is really important, because as we're trying to develop these standards, we have to get an understanding comprehensively of the workforce and what's happening in the workforce to make these informed decisions.
So we'll go to Ken Stewart, Carmen Comsteed, Joan Allen, Abby Yont, Sarah Sorokin, and Carolyn Nava.
All right, just picking up on Janice's question. My understanding is that if there are cost savings from a health system or a medical system, that it can't be funneled directly through labor. In other words, how are you going to monitor if there were substantial reductions in labor if that type of data is not being pursued?
So some of the metrics in the workforce stability metrics that we proposed include wages and benefits and salaries for a variety of occupations. So that, that would be the starting point for us to look there.
But what about, just for an example, hospital system A? How would you know that they've maybe had a 15% layoff?
So some folks have suggested that there are additional data sources that we could look at that include like layoff notices. So that is something that we're looking into and are not on our list yet, but have been suggested that we add.
All right, thank you.
Carmen Comsty.
Yeah, thanks, Margaret, for the presentation. I think, fundamentally, there's a really big concern that CNA has with the draft workforce stability standards, with the sheer fact that we're not actually collecting data and we're relying on data sets that are currently in existence. And I think, to Janice and Ken's point is that, if we're relying on voluntary information from employers, from healthcare employers, or existing data, how are we actually going to drill down to make sure that we're doing the thing that we've been talking about for months now, which is making sure that when entities are trying to meet the spending targets, that it's not being done on the backs of workers. And I think that's really, really important here, that, I mean, to be frank, I was surprised that there weren't any requirements for actual reporting, because I fear that we will not be able to protect healthcare workers if there aren't real guardrails here that can be utilized in a meaningful way. And then separately, because I don't want to, I know that we gave feedback to you all already, but I do think that there's fundamentally questions about some of the workforce stability standards here, which lean towards efficiency and reduction of labor costs without actually looking at the health and safety and the longevity and the quality of the jobs for the workers themselves. Like, when we talk about investing for, like, number 3, investing for training for worker opportunities, that's all well and good, except that you talk about using technology and team-based care, which for nurses, team-based care is oftentimes an end run around to nurse to patient ratios, I think, and staffing issues. And the use of technology is often used to take the actual direct patient care or all these jobs and outsourcing them, or those types of questions. So I think there's a fundamental question here about the best practices that are apparently being that you all are trying to develop under the standards about, efficiency is not always the best thing for healthcare workers or patients. I think we need to fundamentally question what we're trying to do here. I think we need to focus back again on how do we protect workers and how do we make sure that the direct care providers can actually do the jobs that they need to and are fully staffed. And I think that's one of the things that we've been talking about, which is ensuring that there are, oftentimes it's not just reducing labor costs, it's also ensuring that we're putting labor costs in the right place, which could be higher wages to retain workers, or additional training programs for workers so that they can do all the jobs that they are meant to do, or so that we can get more behavioral health folks, or so that we can staff up so that patients aren't, that there isn't understaffing and patients are getting the care that they need. And those things aren't really reflected in what we have here in the proposal. And I just want to make sure that everybody understands this is voluntary. This is voluntary, and it's concerning that the elements of the standard are voluntary, even when we get potentially to the performance improvement plans. And I'm really not sure how we we actually try to protect healthcare workers here with what we have. And, you know, maybe that's a problem with the statute, but I think it's fundamentally a big issue.
Thank you. I have 8 committee members lined up to comment. Next, Joan Allen.
So I appreciate all of the work that your team has put into this and the really rich conversations that we've been able to have. And I agree with you that there is not enough data right now to set true benchmarks and standards. That even for the key performance indicators that are included at this point, we wouldn't know what an acceptable versus unacceptable rate of retention, turnover, time to fill vacant positions should look like. Whether that is a statewide standard or stratified by subsector. But if we don't start collecting the data, we'll never know. And we have to be able to get to that because our healthcare workforce, we do know unequivocally, is in crisis. I think to earlier today when Hector raised the concern of a labor and delivery unit closing, not because it wasn't financially viable, but because there wasn't the workforce to staff it. And we see that throughout the state, that we know we do not have enough healthcare workers to meet the needs of the workforce of the future. This both from the state and from the private sector, there have been many studies time and again showing that. And what they don't do is get then to the entity level. We can see a lot of data at the broader workforce level, but if we're not getting to how different entities are actually implementing the targets, then we're not going to be able to see what led to that 15% reduction in force that Ken asked about. We'll be able to see the warn notice filing that says this many workers were laid off, but we won't understand, is that because those are the workers that weren't enough to staff the labor and delivery unit? Or is that because an entity is responding to something else? Or because they're outsourcing those workers to a joint venture? Unless we're actually collecting that data and putting it out in a way that is transparent and can be analyzed, we are not going to understand whether and how the spending growth targets are impacting workforce stability. The healthcare workforce is an incredibly complicated one. It is not just doctors, nurses, and other. There are so many types of workers in different care settings. We know virtually nothing about the physician office workforce. We know more about skilled nursing facilities. We know more about community clinics, hospitals, but we do not have that complete picture until we start looking at these key performance indicators and others and gathering those from the entities. A standard that is voluntary and never made public is not a standard. And so I would also posit that there may be some among the provider and plan community that might also benefit from more transparency around their peers. Those providers who know that they are doing the right thing when it comes to their workforce, if they miss their spending target, and then there's a performance improvement plan that's under discussion, gosh, it would be nice to say, yeah, I missed that my target because I was doing the right thing by my workforce. I was staffing appropriately for my patients. I was investing in my workers' training and development and retirement and making sure that those are high quality jobs. But if we don't have the baseline to compare them to, we don't know whether they're actually doing better than the rest of the industry. And so it just feels like we cannot get to the idea of workforce stability and the way that that the target's impacted without this information, and feel like we are missing an opportunity and also running the risk of failing both workers and patients.
Thank you. I've got Abby Yellen and Sarah Sorokin, and then 6 more committee members.
Yeah, I think, Jen, you alluded to some of this. As I was just curious as to what the plans were for looking across the whole spectrum of healthcare services, since there's such a shift to outpatient and home care. A lot of the workforce has gone with that, and I don't know how we're paying attention to that or tracking that. Thank you.
Sarah Sorokin. Oh, sorry, Sarah.
What was that?
Go.
Oh, okay.
Go ahead.
So in terms of the behavioral health workforce, in particular, mental health clinicians, like licensed psychotherapists, there's such a huge proportion of this workforce that operates outside of health insurance, Medi-Cal, Medicare, commercial insurance. And if the same was true for other parts of the healthcare workforce, like nursing or primary care doctors, I think it would be something that would raise a lot of alarm bells, and people would want to look into and see, why is this the case? And I'm wondering if there's any plan or thought to take a look at that. What is different about the working conditions or the compensation conditions between the large group of mental health clinicians that choose to function outside of the system, and that could help inform changes that need to be made within the system to attract and retain healthcare workers that already exist but choose not to participate because of very challenging working conditions that aren't sustainable. And the other thing too, and this may be impossible to really take a look at, but looking at internal churn, one thing that I anecdotally have experienced at workplaces is people like maybe the workforce number remains the same, but it's people are moving around within the same workplace to get relief from the challenging job that they're currently in that's burning them out, and kind of start over, slow ramp up with a new role, which on one hand may not sound like a bad idea, but it is bad for patients, because then all of these patients then have to be put back on a wait list, transferred to someone new. Somehow their care is interrupted. But those were my 2 comments.
Thank you. Carolyn Nava and then Hector Flores.
Thank you. Perhaps my thoughts are more questions than they are comments. And the first kind of ties in with what Sarah Sorokin was just mentioning about that barrage of individuals or practices that operate outside of this window that aren't a part of this measurement that could possibly be providing really good insight as to some adjustments that could be made along the way as we progress towards that bigger goal. Can you help us understand what efforts might be being made to include those practices, those primary care physicians or specialists within this voluntary effort? Because since it's voluntary, it seems logical that really anybody would be able to join in. And second to that thought is, can you help us understand, and I'm kind of new to this table, so I want to preface this question because maybe it's been addressed already in past meetings, but I'm still on the 525 pages of public comment. But the thought of not including, for example, the primary care physicians in this voluntary information effort, what was the reasoning behind that?
Sure. So that's based on OCA's interpretation of the statute. So the statute in several areas mentions frontline healthcare workers and non-supervisory healthcare workers. And so based on our understanding of kind of the differences between supervisory and non-supervisory healthcare workforce, we are including physicians, dentists, and pharmacists in the supervisory healthcare workforce. So that's, our interpretation, and we've heard feedback kind of both ways that we should include physicians and dentists and pharmacists in the standards and metrics that we're tracking.
I guess I was just curious about that because there are many physicians and dentists and professionals working in larger group settings where they are also employees. They're not necessarily those key decision makers, and that could be a huge block of information that just is not being brought to this discussion that is quite impactful.
Thank you. Yes, and we look to kind of complement our standards and metrics with the data that our fellow Office of Health Workforce Development collects on physicians. So we would look at those both, but appreciate that feedback.
Hector Flores, go ahead.
Thank you. Yeah, and just following the discussion, obviously what we're always struggling with is transparency, and in this instance, counterbalance with unintended consequences of creating anti-competitive environments. But I do think we should move towards required reporting of these positions. Think about the database that would be collected that would inform our public education system to see where the viable tracks for students to follow to meaningful careers with meaningful pay. It would also inform organizations who are paying top dollar for talent searches that often are not networked with the type of talent that we need, and so a lot of money gets wasted there. I think it would be really powerful in that regard, and it would also recognize what's been commented earlier, those that are actually doing the right thing by their employees. When we often malign organized labor because of the way they fight for their workers. And as Barry Arbuckle mentioned before in one of our meetings, that the labor action in a community invariably raises the bar for every other entity to equal that. Otherwise, they're going to lose employees to that organized labor environment. I think there's some important lessons to learn through a database that would give us the mobility of employees, would inform employers to who's doing important work in the same community with the same circumstances, but somehow is able to retain their workers and the kind of training they provide, et cetera. I think it would really go a long way to do that. And then for practices that are in underserved areas, in particular, but elsewhere, is we should look at that community benefit that tax exempt organizations have to produce. And it would be great to have an argument for an economic development tool to give for-profit practices in underserved areas tax breaks if they can demonstrate they're doing the right thing by their employees and recruiting for local communities. The empowerment zones that the Clinton era had, and then some of the subsequent models that Governor Brown had and others, I think could inform this kind of thinking so that we have a database that informs K through 16 education, for example, that informs trade organizations to where they can find the talent. And it actually then ups the ante for every worker to have meaningful wages, no matter where they are. One of the things we look at as a medical group that's in an underserved area is we need to be competitive. Otherwise, we will lose our employees to hospitals or large medical groups that can afford to pay them better. So for me, the MCO tax is a way to sustain our practices and justifies the increased investment that is being made through the MCO tax because it's going to benefit our employees and ultimately our patients. Thank you.
Thank you. Samantha Reddy and then Stephanie Klein.
Thank you, Margarita, and thank you so much, Hector. I was just beaming because, physician office workforce, that's like the scariest thing of what I have to do these days, the turnover. And I just want you to think about what it's like to be placing all my bets on, the most advanced level of advanced payment, support eventually. And that for over a decade, I've been trying to set up my practice to do that. So others say that we are by far like the first practice to have offered, the most progressive benefits and everything else that we can possibly do. We're already practically at the $25 an hour for our staff, which is kind of scary because as we keep staffing up in this way, finding culturally sensitive, linguistically appropriate staff without compromise coming out of high school, the impossibility is not all of that. It's that to do this kind of work on the ground and the way we're doing it, we don't even have space to put all these people. The receptionist work is just one of the most complicated things ever when we don't have the clinician workforce to, like, how do we schedule? It takes an Einstein to do it, So it's getting harder and harder to do that job that we're expecting line staff, however well we pay and train, to do it. So we absolutely need that kind of support. Thanks.
Thank you. Stephanie Klein and then David Joyner. Use the microphone. Thank you.
I'm very happy to see that these metrics are included, but I do wish they were mandatory, and I do wish they included physicians. I watched half of my department quit as a respiratory therapist. During the pandemic, the nurses were staffed up, but we were not, even though I had 3 times the workload. I see the retention rate very low. I know that nobody, including my employer, could have ever predicted what we were going to go through. So I'm not like irrational, and I don't want to trauma vomit on people. But I can tell you, if there's another pandemic, even half as bad as this, I'm out. I don't care if I have to empty ashtrays at a casino. And I'm being, I know that's a little funny, but I'm being dead serious. My husband and I just looked at selling everything we own so I can move to Costa Rica, because I told my husband, I had to prone a patient yesterday after not proning a patient in over a year, and it triggered me. And it was horrible, and I don't want to go through it again. And when we took no lunch, no breaks, we were penalized. It was horrible to see the things that we went through in the medical community, including my hero, my doctor, who quit and said, Stephanie, I can't practice medicine this way anymore. I had a list of problems. As a frontline healthcare worker, I couldn't even get in to be seen for months. And when I finally did get seen, my doctor said, Stephanie, I only get 10 minutes with you. I have to make you go home, remake another appointment, and come back to me. And he goes, this isn't the way I want to practice medicine. I watched my physician friends who I've worked with for over a decade cry at their desk. I remember hugging physicians because we couldn't see our patients. And I remember a lot of people going on comfort care that I don't believe should have ever went on comfort care. But we were just a death panel. And I don't see how we can sustain another event like this. And I don't know what the situation is, but I know that and I don't think it's just my employer, but I think employers across the board, because I have friends who work at multiple hospitals and I worked at multiple hospitals, we violated a lot of safety issues to get through that. And I would really like to know where the COVID funds went, because I didn't see an adequate appropriation of that money. But I could go on again. I should write a book, but we need to include this because you don't want your mother or brother coming into that hospital with somebody like me who isn't getting, is in these conditions, and then I don't even get a bonus in my retirement plan. So I'm working with all this PTSD, and I'm watching other workers who just quit. And I have more seniority than almost my entire department, and I shouldn't be the most senior person. And I'm really frankly getting tired of having students every day. And I'm really frankly tired of having new hires because I don't get a break. Even though the pandemic's over, I can't recover my mental faculties because I am constantly working worse than the military. I'd rather be back in Desert Storm or Desert Shield. And that, we don't have Joint Commission and JACO and all these people and lunches and breaks. But I can tell you, I feel like the way things have been going are not conducive of something we can maintain long term, and that's it. Thank you.
Thank you. David Joyner, Anthony Wright, and Ken Stewart.
I just, on the comments that were just made, I can tell you that the amount of burnout in the healthcare system across the board is unbelievable. And it's like this hidden giant issue that we need to grapple with. And it applies not just to healthcare workers that Margareta was talking about with the workforce standards, but also applies to physicians as well. And I endorse the comment about including them in these metrics. But the other thing I wanted to say is some of the comments make me worry me that we are sort of engaging in some wishful thinking here, which is we're somehow going to say, let's improve workforce turnover rates, retention rates, vacancy rates, time to fill, et cetera, et cetera. At the same time, we're going to set a target for healthcare entities that's below the rate of inflation and meet that. And, you know, if you look at any healthcare entity, be it a hospital, a physician office, a clinic, the number one cost is labor cost. And I think there's no way that you're going to manage to a below the general rate of inflation target and not impact labor costs in some way. And it could be in different ways, but I think somebody used the words of, let's not make the 3% target on the backs of workers. Well, unfortunately, if you're going to make a 3% target below the rate of inflation, it's almost unavoidable that you will impact workers in some way. So I just wanted to put that on the table.
Thank you. Anthony Wright, Ken Stewart, and then Carmen Comsty.
My initial comment was just that this is a really important subject that that we don't want unintended consequences, and we put some metrics in place like primary care, like behavioral health, and workforce should be aligned with that in terms of the seriousness, and even if it's mandatory or if we need to collect specific data on it. I do think that data would be useful, whether it's what we want to be mindful of the needs in rural communities, the demographic and equity issues with regard to diversity, things like that. And we do want to see, again, what is the potential impact on workforce. I do hope that that at the end of the day, the point of this is I don't know if integrated. We've talked earlier about the moving to integrated to care. I don't know that does provide savings and better quality, and I don't know if that has a negative impact on workforce. I think that it should actually potentially have a good impact on workforce, and so that's the thing that we're trying to incentivize. I think it's really important to have these metrics to focus on it, but I don't necessarily think that the moving from the fragmented, uncoordinated care to a more integrated system could. I do believe that there is a possibility of the win-win, that it doesn't have to be a trade-off, and that's what we're trying to do here, and that's why it's really important to do this to these metrics so that we can get to the place where whether we're doing upstream care or whether we're doing more integrated care, that it's actually that would actually provide. It's not just asking the workforce to do more with less. It's actually where we're coming up with solutions that are more than the sum of their parts.
All right, we've got 3 committee members that want to comment, and then we'd like to wrap this section up. So Ken Stewart, Carmen Comsty, and Sarah Sorokin, please go ahead.
Okay, just want to make the comment that this is not a level playing field, that there are some health systems and service provider systems that don't play by the same rules as everybody else. And their benefit is to the detriment of the ones who do, like Sumana's firm. In the multi-employer world, our trustees were legally required to collect fringe benefits from all contributing employers. those that paid used to get really ticked off at the ones who didn't because they were using that money to better themselves at the expense of the others. So I just think that requiring this data to be submitted and properly monitoring it to ensure the bad players don't get the benefit is important.
Thank you, Carmen, and then Sarah.
Yeah, in the past couple of comments in the discussion, it reminded me of one thing that's missing in the metrics here in number one is and I think we've talked about this a little, which is getting the information about health and safety in the workforce. Are there labor violations that can be looked at? There are a lot of things that aren't being collected here that go in terms of ensuring that healthcare workers have good jobs. So, I know that I think we mentioned this in our comments to you all, Margaret, which is like looking at the question of moral distress and moral injury and actually trying to quantify that. That might be a really important thing to understand here is like, are the working conditions that healthcare employers are placing onto workers making them leave, so that they're gone to to casinos instead of being healthcare workers, and I think that it's a fundamental issue of like, we're trying to focus on training new healthcare workers, but then if we're just burning them out and they're leaving, what's the point? I think ultimately, to David's point, there is always some room in the labor cost equation that can be taken out, which is at the top. And I think that's one of the things what Ken was referring to, some of the larger systems where the labor cost fat could be the people who don't, the administrators who don't provide care or services, or aren't the janitors on the floor helping make sure that the hospital actually runs. I think this question of what is the administrative weight and bloat that's happening? Is it marketing? Is it all these things that don't actually contribute to the quality of healthcare that's being provided? I think those are questions that hopefully eventually, if we get to a place where we're getting required reporting, we can figure out where in that labor cost equation that we can trim that doesn't actually impact care.
Thank you. We'll go to Sarah Sorokin and then move to public comment on this item.
I just wanted to thank Stephanie for sharing, and my whole heart ached as she was telling her story. And that is the reality of the healthcare workforce, what they experience, the ones doing the direct patient care. And one thought that I had when she was talking is about that turnover when we're thinking about healthcare labor costs. What are the cost differentials of sustaining a workforce versus having a high turnover, having to onboard new staff, train up new staff on a constant basis? I mean, I don't know if there's even data that exists on that, but it could be investing more in labor, which reduces turnover, could actually maybe save more money than status quo and high turnover, but just a thought.
Thank you. That concludes this item. We'll now take public comment on this agenda item. If you'd like to make comment in the room, please step to the podium. Online, please raise your hand. Seeing no one at the room at the podium, looking online, seeing roughly 50 virtual attendees at this time and no hands raised. That concludes public comment on this item. We will take a break. It is 3:12. 3:22. Thank you.
Okay, if everyone could please come back to their seats, we'd like to resume the meeting. Thank you for coming back to your seats. We're going to resume the meeting. Okay, we'll be moving on to the next agenda item now. Turn things back to Margaretta Brandt for this next agenda item. Thanks for your attention.
Yes, thank you all. And yeah, feel free to stand and move around. I know it's been a long day. So in this portion of the agenda, I'll review our primary care definition and some options for an investment benchmark for your feedback. So these recommendations have been developed with input from the OCA Investment Payment Work Group, which is our monthly work group to focus on primary care, alternative payment models, and behavioral health. Feedback from our sibling state departments, and also informed by subject matter experts and stakeholder interviews. So this next slide shares a timeline of our primary care work. So today we're seeking your input on the draft recommended definition of primary care and some options for the investment benchmark. We'll then coordinate with our work group to incorporate your input and bring drafts to the board for discussion and public comment in April. And then again, incorporate that feedback and from the public comment and the board and bring a benchmark to the board for approval in July. So this next slide shows the statutory requirements related to primary care and behavioral health investment. So it requires that OCA measures the percentage of total healthcare spending allocated to primary care and set spending benchmarks for primary care that recognize the historic underfunding. It also notes that benchmarks and public reporting should consider differences among payers, claims and non-claims payments, and other variations across populations. So, and today our discussion will kind of focus on those areas. So the statute also provides some additional guidance. It indicates that we should focus on improving outcomes for primary care, and it identifies several strategies for achieving those improved outcomes. So increasing the use of advanced primary care models, the integration of primary care with behavioral health, and adoption of alternative payment models to support advanced primary care. So these are some of the policy goals we want to keep in mind as we move forward in our work. So moving to our draft primary care definition and approach to measuring claims-based spending. So the definition and approach to measuring claims-based spending are very connected. So we took a vision for primary care delivery from the California Quality Collaborative to inform our work. This was a vision brought up in our investment and payment work group, and we've used it to guide our work. So this vision was developed by the California Quality Collaborative in partnership with lots of California stakeholders. And for example, the vision references team-based care, which should suggest a definition of primary care that includes nurse practitioners, physician assistants, and other team members. And in addition to all of these elements for the vision, our work group noted the need for a sustainable and well-resourced primary care to achieve this vision. So we are recommending, sorry, the clicker is slow. We're recommending a modular definition of primary care with 3 modules. So primary care paid via claims, primary care paid via non-claims, and then behavioral health delivered in a primary care setting or by a primary care provider. So these modules allow us to track components of primary care spend, and all 3 modules would be included in the primary care investment benchmark. And the behavioral health in primary care could be added to the behavioral health or to the primary care investment calculations. So this is our structure. And so based on that, we wanted to move into how we define primary care using claims-based payments. So for the purposes of measurement, primary care is typically defined in other studies that look at primary care spend of when a primary care provider performs a primary care service. And then some definitions also look to restrict by place of service or care setting. So this slide shows the interaction of primary care service, primary care place of service provided by a primary care provider, getting you to primary care. And this slide also shows some of the common types of providers, services, or places of service that are included in definitions. So we looked at how other states are approaching primary care definitions, how both in California and other national organizations are approaching this, and then use that to guide our work along with work group feedback. So these next two slides provide an overview of OCA's recommendation for measuring primary care investment paid via claims. So the first three recommendations are to include a broad set of providers to reflect the statutory goal for promoting team-based care, restrict some places of service to reflect the work group's vision of promoting continuous and coordinated primary care, and include an expanded set of services to encourage as much care as possible and appropriate to be delivered in a primary care setting. And this next slide shows our last two recommendations for claims-based measurement. And that is to include some OBGYN services as primary care services consistent with other body systems, but to exclude OBGYN providers as primary care providers to be consistent with the focus on providers who provide whole person continuous care. So this recommendation is preliminary. We've solicited lots of feedback and heard lots of feedback from our work group and others about this recommendation. So we want to get your feedback in particular here. And then we also propose to include a limited set of behavioral health services provided as part of primary care, as I mentioned earlier. So in developing this claims-based definition in our work group, it was proposed that we should try to narrow and be more precise about who is actually practicing primary care in a health plan's network. So we've worked with the Department of Managed Healthcare and our other stakeholders in our work group to develop this more nuanced approach using this workflow to identify primary care providers. So we are recommending a two-step approach to identify primary care providers that uses the provider's taxonomy code on a claim and, where available, their designation as a primary care provider in the Department of Managed Healthcare annual network reports. So in this approach, first payers would identify their claims with a primary care provider taxonomy. And if that taxonomy is for a physician, nurse practitioner, or physician assistants, then the payer confirms if the provider is identified as a PCP in their DMHC annual network report submission. So for example, at this stage, an internal medicine physician who is not identified as a PCP would be removed at this step. And so if the provider is identified as a PCP, or on the other track, if the primary care taxonomy is not tracked as part of the annual network report, the payer moves on to confirm both the place of service and the service are included in the primary care definition. So this next slide identifies the provider taxonomies that we are recommending including in the primary care definition. And it really focuses on providers who are providing whole person continuous care and are part of a team. So you'll note that the definition includes members of the primary care team, even those who are less likely to bill via claims, to both acknowledge their importance and because the definition also guides the allocations of non-claims payments. And for primary care team members who do not bill via claims, like community health workers, we expect that their associated primary care payments will be captured in the non-claims payments. So using all of those three kind of continuous circles, primary care provider providing a primary care service in a primary care place of service would be counted as primary care. And digging into one of the provider taxonomies, want to spend a few minutes on the preliminary recommendation to exclude OBGYNs as primary care providers. So as I mentioned earlier, this preliminary recommendation is based on the work group's emphasis on providers providing that whole person continuous care. And as an example, a patient who selected an OBGYN as their primary care provider would likely seek treatment for minor acute conditions like a sinus infection or for a chronic condition outside of pregnancy with another provider who is not their OBGYN. And stakeholder feedback to date has been mixed on this. Many have shared strong support looking back to our vision of primary care, and others have shared concern that this conflicts with the Knox-Keene Act and other policies allowing OBGYNs to be selected as primary care providers. And then some stakeholders also emphasize the potential impact on women's health equity. So we'll come back to this at the end and really want your feedback on this area. And I wanted to share a little bit of data about the inclusion or exclusion of OBGYN and how it could impact primary care spending. So this slide shows data from IJ, or the Integrated Healthcare Association, with whether or not OBGYNs is included or not. So when included, there's a less than 0.5% change in the estimated primary care spend based on their definitions and their data. And notably, the Maine Quality Forum and the New England State Consortium Systems organization both reported similar results when they undertook similar analysis on commercial Medicaid and Medicare Advantage data. And then this next slide outlines kind of two different approaches that other states and other organizations measuring primary care spend take related to OBGYNs. So the first approach is to include a limited set of OBGYN services, such as screenings or insertion or removal of contraceptive devices when performed by a primary care provider. And the second approach is to include OBGYNs as primary care providers or include a broader set of OBGYN services. So some considerations for this approach would be that OBGYNs might be the most consistent source of primary care for some people, especially pregnant people, and that some definitions of OBGYNs try to avoid overcounting OBGYN services in primary care. For example, they exclude office visits by OBGYNs in their definition. And we'll note that this option of being broader but specific on the services provided by OBGYNs adds significant data submitter burden to our definition. So would encourage you to kind of think about these considerations, and we'll come back to them when we open up for discussion. So then moving to recommended services. So this slide shows the services that the work group identified as aligning with the future vision of primary care. So focus on preventive screenings, immunizations, care management, and minor procedures. And again, like all elements would be combined with the other pieces of the definition. And this next slide for claims-based definition shows the recommended places of service. So these places of service are intended to focus on kind of traditional settings, so offices, but also to include home settings, so any site that might be a person's home, and community sites of care to promote improvement in access to primary care. And the work group recommended excluding retail clinics and urgent care sites of care due to concerns about care coordination, integration, and comprehensiveness, referring back to our vision for primary care. So now that we've walked through the claims-based approach, kind of get into the more nuanced approach, which is measuring non-claims primary care spend. So I'm sure, as all of you are familiar, non-claims payments are not tied to a specific service or provider, so isolating non-claim spending dedicated to primary care can be really challenging and requires clear definitions and specifications. So this slide kind of outlines the framing of how we're kind of thinking about it and what the limitations are. So OCA's non-claims measurement will focus on payments to providers made by payers in support of primary care services. So what the payer intends the dollars to fund. And the challenge is that payers often don't know and therefore can't report how the dollars are spent within a provider organization. So OCA will not be measuring based on our current data collection efforts what providers are directly spending on primary care in a non-claims provider. It will be from the payer perspective. So today we're going to share in these next set of slides a proposed approach to measuring non-claims primary care spend. And we're building on the strategies that other states and organizations have used, but these methods are really blunt instruments, and there is kind of no perfect solution. So we're looking to kind of create reasonable approximations of primary care spending through non-claims. So this next slide outlines the essentially kind of the formula that we'll be looking at to measure primary care spending as a percent of total cost of care or total medical expense, and just outlines what we're looking at in terms of claims for primary care, total claims for all payments, and then non-claims payments for primary care and total non-claims payments. So we're going to kind of focus on that top box in the circle of non-claims payments. So as a reminder, kind of our data source for primary care spending measurement is based on the total healthcare expenditure data collection efforts. So non-claims payments will be categorized using the expanded framework that we reviewed in the November advisory committee. And that presentation is linked on your slide if you want to look back to it. And OCA will provide definitions and technical specifications and technical assistance for data submitters in terms of allocating payments to primary care from non-claims data. And this next slide just again kind of outlines some of the challenges we're working with is that non-claims payments is a large portion of primary care spending in California. So it's really critical to try to get kind of an accurate picture or at least an accurate approximation of non-claims payments supporting primary care. And we'll note that a few states are allocating non-claims payments to primary care, but there is currently no standard for doing so. And kind of the overarching challenge that we've mentioned is that non-claims payments cannot be tied back to specific providers or services. Some of these payments are made for a patient population and cannot be tied to groups within those populations, such as children and adults. So these next two slides provide, again, a high-level overview of our approach to measuring non-claims payments for primary care. So looking back to our expanded framework categories, so starting with category 1 of population health and practice infrastructure payments, and then category 2 of performance payments, the proposed approach is the same. So all non-claims payments in these categories are allocated to primary care when paid in support of primary care programs. So some programs might include care management, care coordination, population health programs, and then similarly, performance incentives in recognition of quality of care for patients attributed to primary care providers would also be included. And we would provide, guidance, technical assistance, details on how to do so. And then additionally, we are proposing that payers would be required to limit the portion of practice transformation and IT infrastructure payments that count as primary care to 1% of total medical expense. For category 3, shared savings payments, the portion of risk settlement payment allocated to primary care would essentially kind of follow an equation. So it would be limited to the same proportion that claims-based professional spend represents as a percent of claims-based professional and hospital spending. So it's essentially setting a proportion for the amount of primary care that can be allocated from shared savings or shared risk payments. And then for category 4, here's kind of our capitation and global budgets category. The approach would depend on the type of capitation payment. So for primary care capitation, of course, 100% would be allocated to primary care. For other capitation payments, data submitters would calculate a fee-for-service equivalent based on a fee schedule for primary care services multiplied by the number of primary care encounters. So this next slide provides an equation for how this would work. So here, kind of in this hypothetical equation, capitation payments are allocated to primary care based on a few factors. So that top box is your primary care capitation. And then the equation in the center of the slide calculates the total number of primary care services that meet OCA's definition times the fee-for-service equivalent for that service taken for a fee schedule. And the fee schedules would specify fees for each primary care service by payer type, so commercial, Medicaid, and so on, geographic region, and year. And each combination of those 4 elements in the oval on the slide, year, region, OCA, fee-for-service, primary care definition, and payer type is a different segment. So the process of estimating primary care spend by counting encounters and multiplying by fee schedule amounts is repeated for each type of capitation, so ranging from professional to payments to integrated delivery systems. So counting all of this up, then you would get to your total primary care spend paid via capitation. So now that we've walked you through some equations and proposed definitions, I want to transition to how we're thinking about setting the primary care benchmark and propose some options. So in the work to kind of determine an approach to the primary care investment benchmark, we looked at these 4 questions. So, do we set a single benchmark across all payer types or different benchmarks? Do we look at a single benchmark across all age groups or differentiate by age group? The next question we looked at is whether to base the benchmark based on total medical expense or defined per member per month amount. And then what's the structure of the benchmark? Is it an absolute target, a relative improvement target, or some combination? So a few lessons learned from other states in this work. So the first is that, sustainable delivery transformation requires multi-payer investment across all populations to deliver high-value primary care. And we noted in our work that 4 of the 6 states with investment requirements only focus on commercial or Medicaid, not both, or Medicare Advantage. So another is that it's difficult to reallocate spending to fund primary care investment in the short term. And so if the timeline is too condensed, this could be inflationary and considered unachievable. And then finally, other states have taught us that increases in total cost of care hinder meeting the primary care benchmark. So looking kind of at across states, we wanted to kind of outline this slide to show how all states that have primary care investment benchmarks have looked at these key questions. So you'll note here, kind of for the first question, California is proposing or recommending a benchmark that applies to all payer types. The second key question is to whether to set a single benchmark or separate benchmarks. And here, this is still under discussion, and we look forward to your feedback, and we'll go more into details later. And the next key question is to, is the benchmark based on total medical expense or per member per month amount? So per member per month amount can be considered, having less risk of being inflationary. However, the percent of spend approach is consistent with other states and national approaches and communicates that increased spending on primary care should reallocate rather than increase total spending. And we note also that the statute seems to have a preference for total using a percent, and so our recommendation is to use a percent. And the fourth key decision is to whether to set an absolute or relative benchmark or some combination. And there are different approaches. So a relative benchmark meets payers where they are today, while an absolute benchmark offers a shared vision for the future. So our proposed approach, and it is somewhat similar to other states, is to set an absolute statewide benchmark with relative improvement goals year over year. And so next, want to review some data to help inform how we set that benchmark number. So this slide shows data from the Integrated Healthcare Association looking at primary care spend across payer types and also across age groups. So if you look at the primary care spend for so this is primary care spend from 2019 through 2021, and the dark blue bar shows how the percentage looks when commercial populations are combined. So this is adults and pediatrics, and that average is 7.3 to 9.9% spend on primary care services from 2019 to 2021. And as you can see, the differences between adults and pediatrics is quite stark. However, the commercial spend compared to Medicare Advantage is quite similar. So the Medicare Advantage data is shown in green. And I also want to note here that the two-step process that we are proposing for primary care provider identification, so using that DMHC PCP identification, would likely result in OCA coming up with lower primary care spend numbers than this IHA methodology. And this next slide shows the, spending in Medi-Cal health plans on primary care services in 2018. So again, this there's quite a bit of variation across pediatrics and adults. So the average is 11.3% across all populations, with the average of 28.2% on primary care spend for children and 11.6% for adults. And again, I want to highlight here that this report uses a different methodology than we're proposing, so we would likely see different and lower numbers in the OCA data. So getting to our proposed benchmark. So taking all of kind of this information and lesson learned from other states and our discussions in the work group and the data, we are proposing a relative benchmark and coupled with a statewide absolute benchmark. So for the relative improvement benchmark, we are proposing that all payers will need to increase their primary care spending by 0.5 to 1% per year, depending on their current level of investment. And that for payers that are at the statewide absolute benchmark or above could opt to maintain their current primary care spend if increases are not aligned with care delivery or affordability goals. And the relative improvement benchmark, again, is consistent with other state approaches that as we saw, reflects the statutory guidance to recognize differences across payers and allows for that gradual reallocation of spending to primary care. So getting into two options for an absolute benchmark, where we want to solicit your feedback on these two options. So this is the first option. So this first option is a single absolute benchmark across all payers and populations. So this option proposes to allocate 15% of total medical expense to primary care by 2034. And this statewide absolute benchmark is slightly higher than those in other states. And it aligns with the high percentage of primary care spend we see in other national healthcare systems outside the US. Our California delivery system, our younger population, and the 10-year time horizon. So this 10-year time horizon gives payers the opportunity to reallocate spending to primary care and promotes that long-term redistribution. Option 2 here separates the benchmark into a benchmark for adults and for pediatrics, recognizing the stark differences in current spending across those populations. So this option includes a 12% absolute benchmark for adults and a 24% absolute benchmark for pediatrics, again by 2034. And I do want to note here that we continue to evaluate the feasibility of this option and data submitter burden. So especially tied to non-claims payments. So it can be challenging to allocate certain non-claims payments to adults versus pediatric primary care spending. And also for both of these options, we want to note that because of the two-part approach of identifying primary care providers in addition to the taxonomy codes, the amount of primary care spending calculated by OCA to kind of set our baseline would likely be lower than the current data that we have now. So now kind of turning to 4 key questions we have for the advisory committee. So one, going back to the question of whether we should include or exclude OBGYNs as primary care providers, how we should allocate capitation payments to primary care. You know, should we look to set a single absolute benchmark for all ages or separate absolute benchmarks? And then do you have feedback on the time frame? So does the 10-year absolute benchmark time frame coupled with that relative benchmark provide necessary investment while allowing for sustainable transformation? So we look forward to your feedback on these key items and then any other feedback you have as well.
So Margareta, should we take these one at a time in terms of directing the conversation? Would that be helpful in terms of gathering input?
Sure,
okay,
thank
maybe
you.
Colleagues of mine can keep us on track with time or as best we can do that. But so first, just inviting feedback on this first question about including or excluding OBGYN provider taxonomies. David, I see your hand.
My input would be that I agree with excluding. One of the issues we have in the Hill Physicians Network is some OBs want to be assigned as primary care providers. When we look at the actual experience, they don't treat all conditions that a primary care provider needs to treat throughout a life cycle of a human being. And so we would agree with your exclusion recommendation.
Simona Reddy.
David's comments are appreciated. I think it's tricky. I'd love to even expect a self-election, but I recall many years ago reading a simple kind of survey study of OBGYNs. You know, if you couldn't have been an OBGYN, what would you choose? And overwhelmingly, it's a surgical specialty. And that's kind of informed my perspective when I see patients who, you know, as we provide care back and forth, that primary care orientation around counseling and education around options for birth control, for example, or truly the integration of in that one physical. I mean, it's clear that's where my heart's been my whole career, but I think it would be fair to the OBGYN if they were not doing surgical care and they chose that taxonomy to include them. And I recognize that would be such a minuscule portion of the spend. It's not even relevant. But culturally, there does seem to be that difference.
Thank you. We have Hector Flores with a hand up. We'll take next, and then Adam Doherty.
Yeah, I would exclude OBGYN unless they have a primary care clinician affiliated with their practice. And the reason for that is I share what David mentioned about his IPA's experience. We've had the same experience. Since women were able to choose OBGYNs as their primary care provider, they have a very limited scope of practice because their training programs are not geared towards primary care. And they end up referring them back to us for ongoing chronic care of the patients. So clearly they're not equipped to take care. However, for women, many prefer the OBGYN as their access point. And so what we've encouraged the independent OBGYNs is to hire a family nurse practitioner or internal medicine nurse practitioner who could then provide the comprehensive primary care under their tutelage. And then we, as the IPA, will continue to monitor performance and utilization. So that would be the exception. But as a general rule, I would exclude them.
Thank you. Adam Doherty and Stacey Horrentis.
So I think it is a little tough because there is precedent in statute for decades that OBGYNs can be designated as PCPs, and DMHC allows that ability as well. So, while I sympathize with some of the, inconsistencies, I'm not sure we should be, confounding different definitions than what is in precedent. I believe there are OBGYNs that are providing whole person care, so I think there should have that ability, and I think there is a middle ground here. Again, it gets down to how many of those individuals there actually are, but I would resist the notion that they do not provide primary care.
Thank you. Stacey Orantes.
Yes, I was going to actually support David's comments in terms of not including them in the primary care. I know there are certain geographic areas where they probably are absolutely, operating as primary care physicians. But I have another comment. In the list, diabetic educators are not listed, and I think they should be included, as well as I do think that urgent care centers associated with primary care physicians should be included, as well as virtual on demand that are embedded into the clinic sites with primary care physicians.
Any other input around the OBGYN question? Okay, let's move on to the next question, allocating capitation payments to primary care. Any input on that? David Joyner, Stacey Orantes.
So this is fiendishly difficult, and I'm sorry for what I'm about to say, but the reality is, for many groups, we're paid a professional or a global capitation that doesn't distinguish between primary care and specialty care. And at least at Hill Physicians, we spend a pretty significant portion of dollars in a pay for performance that goes directly quarterly to primary care physicians. It's allocatable to the primary care physicians. So I think you're going to have to figure out some very comprehensive data collection exercise here, because we're going to have to include elements like that, as well as divide up our capitation according to how we pay it. The health plan will not have designated how much goes to primary care. It'll be the group that will have designated how much goes. So I think it's important you allocate the dollars fully, and you're going to need a very flexible questionnaire because of all the different ways that these monies get paid.
Thanks, Stacey Orantes, and then we'll move to Suzanne Usage.
I have to concur that this is a very difficult one, and I've been debating with IHA about this for quite a while, because you can't look at a capitation amount and divide it up by a fee-for-service equivalency. There's a lot of resources we've invested in primary care to support the practices that are not included in a claim, our population health, our remote monitoring. And so those costs need to be factored in a specific way. Lance Lang is working with IHA on that.
Yeah, I think we are looking to, like, for the pay for performance and for other population health programs, we would aim to capture that in other categories outside of the capitation. So those would be in, like, the practice infrastructure payments and the other payments, the pay for performance programs.
For us, those are embedded in our capitation rate, and
Okay.
we have invested and allocate those to support primary care.
Okay.
So it's not an additional payment from a health plan.
Suzanne Usage, you're next, and then Hector Flores, and then Joan Allen.
Mine was actually about the OBGYN comment, so apologies, this is out of order. I wanted to just support the idea that OBGYN, kind of like the precedent that's been set, and understanding that, I think it was the very first meeting that we had together, the second, we did kind of address women's health as a concern as falling behind. And so I think that might have been some of the historical reasons why OBGYNs were recognized as providing some primary care, maybe the gynecology side of their practices. So given, maybe that could be something that's looked a little further into, if there could be an exclusion or some type of factor created just for the labor and delivery portion that could be cut out, or the maternal part that would be cut out. But just kind of emphasizing the comments about considering how OBGYNs can be considered for primary care.
Thank you. Hector, please go ahead.
Thank you. So I don't have an answer either, but I think as we continue to study this, there's a couple models emerging that we should also consult. One is the advanced primary care model that PBGH, with its subsidiary, the California Quality Collaborative, is looking at for PPO products. And they're looking at, how to take a 2-year look back, see what expenditures were made for primary care visits, and then identify if there's an additional PMPM payment that could be made to support the practice, providing coordinated care, transitions of care from the hospital, et cetera. And the second model is the existing Medicare MACRA model, which is paying for chronic care management and transitions of care and other services that, in this case, Medicare patients need, that is above and beyond what the primary care physician gets paid for direct service. All this to say that we should also be looking at not paying the physician for widgets, but actually paying the physician practice and their team for the care that they're providing to the patients. And so at least it'd be worthwhile to see how the folks in the APC and Medicare experience has been to kind of help inform us on this matter. Thanks.
Thank you. Joan Allen?
So I appreciate that the data source that we have is that we'll be measuring that money paid to providers in support of primary care services, and that we don't have the data source of the money providers spent delivering primary care services. I think it would be helpful as we are going down this path to start investigating what is the delta between those two, and what is that delta being spent on. Is the bulk of it that the PMPM is going for both primary and specialty, and so there's not a great way to really untangle that? Is that delta, in the case of a private equity owned physician practice, going largely to out-of-state shareholders? Are there other places where really we are overinflating the amount actually being spent on primary care because of that data gap? And I know we won't have that day one, but would hope that as we walk down the path, we would start to better understand that delta.
Okay, why don't we move on to the next question, number 3, in regard to setting a single absolute benchmark for all ages or setting separate benchmarks for the adult and pediatric populations. David, I see your hand.
Totally agree that a separate benchmarks should be done here. You've shown how different the spending is. And I think it's worth actually evaluating whether there should be a different benchmark for Medicare age versus adult commercial. There might be a difference there as well. I haven't seen the data, but I definitely think you will have some providers whose mix of population will be more heavily weighted towards pediatrics or towards adults, and I don't think you want to set a target that's inappropriate given the big difference in the underlying needs of the two populations.
Thank you. And we do have at least commercial, IHA data on Medicare Advantage spending that actually looks like it's higher than commercial adult spending on primary care. And I think that's slide 100 or somewhere around there. Yeah, thank you.
We have Sumana Reddy next, then Mike O'Day, and then Hector Flores. Sumana?
I do agree with option 2, just because until recently it's felt like the care of children and adolescents, young people in general under 25, has been really underattended to in our big healthcare systems because of MA plans and the rise of more sort of Medicare managed care and attention to the frail elderly. And it seems like all systems kind of by default, focused on that care, understandably so. But it has felt like, and it's an equity issue. It has felt like youth have been really, really under, their needs have been underemphasized, and there's a lot that can still be done in primary care that I think is really important. And it's an issue that, despite the lack of additional support, we've tried to kind of maintain the resources that they need. So this just makes so much sense to me, knowing what it takes to take care of those kids and teens.
Thank you. Mike O'Day.
Thanks. Just wanted to say thanks for the presentation. I obviously agree with option two, based on the data that was provided. But I think, also to point out that we would hate a unintended consequence for there to be a shift away from spending in primary care for kids to other things as a result of a single benchmark. So really appreciate the thoughtfulness in having the two benchmarks. Thanks.
Thank you. Hector Flores.
Yeah, I support the two benchmarks as well. And what I would add is that we also need to look at an absolute denominator. For example, the capitation payments for seniors and persons with disability in Medi-Cal doesn't compare to the capitation with Medicare Advantage, for example. And even though I would argue that SPDs need as much care, if not more care, than the average Medicare patient. And so I think we need to also look at an absolute denominator to level the playing field. We also look at pediatric practice in California, and Michael, you can correct me on that, but I see that pediatricians who are in the community tend to have an overwhelming number of Medi-Cal patients because 50% of the 14 million Medi-Cal recipients are children. And family physicians, we do our job too, of taking care of Medi-Cal children, but it's the pediatric community and the community that really picks up a lot of them. So we should also take that into account, that a percentage of a low denominator may not compensate them for the work that they need to do. Thank you.
Okay, let's move on to the fourth question. How about the time frame for achieving the benchmark? Any input about that? Yes, Abiyant, please.
Yeah, we are partnered with Blue Shield and Alteus Brown and Tolan on the PPGH Advanced Primary Care pilot. And I'll just say the ramp up, the startup is much longer than anyone anticipated for a variety of good set of reasons. So I do think that the change management that comes with this needs to have significant lead time. We are through the pilot learning a lot, about the cost and the population and all of the questions that go into what the cost of advanced primary care is, and then trying to match it, line it up with outcomes. One of the bigger challenges we have in this pilot construct is, we're working with one payer. And physicians treat everybody the same no matter who the payer is. And so getting from here to there is going to be another murky path, but I think one that people appreciate, and really it's an all-in endeavor. And we'd love to find ways to expand the pilot with other IPAs.
So Abby, has the change management been mostly on the data collection side and sort of setting it up, or actually having the shift occur, or both?
It's both and more.
Yeah. Sumana, ready?
Just want to comment on that because we're part of that pilot as well. And the hardest thing for us is just to get feedback from the payer, communicate at all has been really challenging, and correcting data errors remains really challenging. So I just want to point that out because that's hard.
Okay, I'm looking around the room and our virtual committee members. I don't see any more hands, so Margaretta, I'll turn it back to you.
Thank you very much. Appreciate all the feedback. And it sounds like, at least for folks who spoke, that a separate benchmark is preferred. I will just note we are continuing to evaluate what that would look like. So would welcome maybe offline any additional feedback on how we could do that, especially for non-claims payments. But thank you for the feedback.
Okay, so that concludes that agenda item. So we'll turn to public comment for that agenda item, and we'll invite folks here in the room to step up to the podium if they'd like to speak. We're going to look for members of the public online to raise their virtual hands for any comments on this agenda item. There's no one coming to the podium in the room here. And looking online to members of the public, we see no raised hands. And so that concludes the public comment for this agenda item. Thank you.
Go ahead, Margareta.
Yeah. Thank you all. So yeah, back again to introduce one of our advisory committee members, Barry Arbuckle, to share an example of a cost reducing strategy. So just as a quick refresher, this is OCA's cost reducing strategy effort, which is really an effort to highlight examples of successful cost reducing strategies that also maintain or improve quality. So we're working with health plans, hospitals, physician organizations to highlight examples that have demonstrated results. And so we're highlighting these examples as resources for healthcare entities. And just as a brief reminder, OCA did not independently verify information about these strategies or results by the healthcare entities, and we're not endorsing any specific strategy. These are helpful examples that can be a resource. And then just one more quick reminder that we are soliciting additional examples from healthcare entities of cost reducing strategies. So we welcome those and welcome those in our OCA inbox. And now I'd like to introduce our advisory committee member, Barry Arbuckle, President and CEO of Memorial Care, who will share their cost reducing strategy on using community-based ambulatory care centers.
Thank you. I think we're wearing the group down today sufficiently. So this is one of Memorial Care's cost reducing strategies. It's one of our longer standing ones that we've been working on for about the last decade. Just a quick let's skip over that. Orientation to the Memorial Care health system, because the provider systems throughout California are all different in a number of ways. Memorial Care is what we consider to be an integrated health system. We do have 4 hospitals. One's a teaching hospital, one's a women's and children's hospitals, and we have 2 community hospitals. But our emphasis has really been on our community-based centers, and that's been the lion's share of our expansion over the last number of years. You can see there the number of imaging centers and physical therapy clinics, dialysis sites, urgent care centers, breast centers, ambulatory surgery centers, and I'll get to the dental site in a moment. Just as a note, though, the imaging centers, the PT clinics, the dialysis sites, and the ASCs are all joint ventures. They're all partnerships that we established with folks, as we like to say, does that work for a living, and that is all they do. And we're a part owner in those, including with the ASCs, where we have physicians as owners as well. And the goal has been to try to find the right site of care where the patient belongs for their clinical needs, as well as for the financial impact it'll have on them or on the payer. You see we have one co-located primary and specialty dental practice site that might seem like a bit of a one-off. These are co-located sites for a medical practice and a dental practice in the same suite with a common lobby, the same electronic medical record. Our desire to go into that space, and we have one with a commitment to build 25 over the next several years throughout Los Angeles and Orange counties. But it was really predicated upon a growing amount of evidence for the last number of years of what's called the mouth-body connection, the connection between oral health and overall health in areas like cardiovascular health, diabetes, preterm birth, and even most recently Alzheimer's. So our interest here is, can we get ahead of some of those conditions and diagnose them and treat them earlier than we might otherwise be able to? I included this slide simply because last time Stacy Harantis included a slide just like this for the Sharp Health system, and I felt I needed to do so. So this really just shows what Memorial Care does, at least in these 10 areas. But you can see the heavy emphasis on the ambulatory side. We have 71,000 ambulatory surgeries, over 600,000 imaging studies, and almost 190,000 dialysis treatments. So it's, again, a kind of an unusually configured health system, but we've done it with an intention to allow us to bend the cost curve in healthcare. This is our geography again. Memorial Care is only in Los Angeles and Orange counties. We do have some provider sites in the Inland Empire, but not many. So our goal is to be where people work and where they live, and have provider sites close to those in that geography. This slide shows a rather lengthy evolution in value-based care after the enactment of the Affordable Care Act. We leaned heavily into the various value-based care plans. We have and continue to participate in what we think is every type of ACO and at least most types of alternative payment models. We have ACOs on a PPO platform, ACOs on an HMO platform. We have attributed model ACOs, and if that's a foreign language to some of you who don't work in this space for a living, those are ACOs where the member is attributed by the health plan to the ACO based upon where they've received most of their care in the last year. The ACO may not know they're in, the ACO may not know that patient's in the ACO. The patient may not know they're in the ACO. The primary care doctor won't know they're in the ACO, and therefore then can't reach out to them for preventive care, educational care, et cetera, until they at some point engage with the health system. Those patients can also go anywhere else they want to seek care, yet the ACO is charged with their financial responsibility. That all said, we are moving away from attributed model ACOs because you simply can't bend the cost curve if you don't have that relationship between the provider sites and the patient from very early on. Attributed models tend to be where the government, namely the federal government, has moved some of their CMMI products. I think that was just to largely be politically correct and not force people to choose a network for an ACO. Those models, as another one, are called designated or network model ACOs. Those are far more effective, particularly when there's significant downside risk for the providers taking care of those patients. We also have a direct-to-employer plan. We had what I was told, I didn't know this going into it, was California's first direct-to-employer plan. We're a large corporation that had a concentration of employees in a certain geography, contracted directly with a provider system. This happens to be Boeing. That was a number of years ago, I want to say 7 years ago when we entered into that contract. It does have a health plan offering administrative services, and in this case, it's Blue Cross and Blue Shield of Illinois that does that for all of the Boeing sites across the country that have a direct employer model. It is an opportunity to bend the cost curve significantly because we can work directly with the employer on the benefit offerings that can drive the right care to the right place. We've now developed a model for smaller employers because the Boeings and the Qualcomms and the Googles and the Ciscos are but a very few of all the companies in California. Most companies don't have that number of employees in a concentrated geography. And so we've developed a model that's direct to employer for smaller companies, regional banks. We have Activision Blizzard, Microsoft, at least the employees they have in Los Angeles and Orange County. And then finally, we did have participated in a number of the CMS, CMOI programs, for better or for worse. They've been kind of learning as they've been going, but we wanted to participate in them. Before I jump into the community-based ambulatory sites, just this note, we've touched upon this in some of our dialogue on this advisory committee since its inception, and that is moving into alternative payment models or accountable care organization models requires a different infrastructure or an amended infrastructure that requires some significant investment. Data is very powerful for these, and so you need a lot of it. You need a lot of integration, and integration is not necessarily inexpensive. You have different care management and utilization management assets that are required, pharmacy management. I mean, just by example, in one of our direct employer contracts, the largest one, in the first year, we're responsible in that contract, by the way, for total cost of care, everything, including pharma, which is not something we control in any way. And it was frankly our greatest hesitation stepping into that contract was we would have financial risk with no endless downside for pharma. In the first year, we reduced the cost of care for those employees signed up into that ACO by 20%. Pharma went down by 20%, while the other employees in the same company went up by 8%. And that was simply by having a robust pharmacy management team that scoured the data to find what prescriptions were being given to patients that were either unnecessary or overly priced. So that's another opportunity to help kind of bend the cost curve. Need to have the broad ambulatory points of care. That's what I'll talk mostly about. And then I should also note, and we touched upon it in some of our discussions as well, the importance of virtual care. Really came to the forefront during the pandemic. I think it was one of the, maybe the only silver lining in the pandemic because it really forced the public to reconcile with virtual care and see that it actually can work, and frankly, providers to see that they can actually comfortably provide virtual care and that people will accept that. It increases access incredibly, and it also helps direct people to the right site of care. If they're at home and you think a lot of health plans have a $0 deductible for the ER and $20 for urgent care. The patient knows they probably don't need to go to the ER, but $20 is $20. And so they go to the wrong side of care, drive up a much more expensive bill, wholly unnecessarily. Whereas they could, through a e-visit, contact a nurse that's 24/7 online and describe their symptoms, or do it through artificial intelligence and have that directed to the right site of care without them unnecessarily worrying about paying a deductible. Okay, so, oopsie daisy. Just a quick definition. This is, again, focusing on ambulatory care. I'm referring to imaging services, dialysis, ambulatory surgery, as well as some others. Those procedures can be provided in really two locations, and they're both considered outpatient. One is what's called an HOPD, a hospital outpatient department. These are outpatient entities that are either attached to or in proximity to a hospital, but they are licensed under the hospital. They're under the hospital's managed care contracts. Community-based ambulatory centers are typically in the community, as the name would suggest. They're not under the hospital license. They have their own managed care negotiations, and they also are under all the regulatory environment that a hospital is required to operate under. Clinical criteria is the best way to determine which of those two the patient should go to. And when you ask, well, who cares which one they go to, you'll see in a moment why we should care which one they go to, and it's really all about price and, to some degree, access. So we do have clinical criteria. When I say we, I mean some of the health plans in the state of California, to determine is that patient's comorbidities or their physical condition or the type of surgery or their allergies, does that necessitate them being in proximity to a hospital, therefore an HOPD is appropriate, or can they be cared for safely in a community-based ambulatory center? Now, I will say that CMS uses what I characterize as a blunt instrument called site neutrality. And that was several years ago. CMS went down this path where they got frustrated that they were paying differential rates for the same procedure on the same patient, whether it was done in a hospital licensed entity or a community-based entity. And so they went through a process and they fixated on site neutrality. We're going to pay the same amount, the lower rate, regardless of where they get their care. It's really not the most sensible way to go about it. It was simple. And frankly, they weren't given a more informed alternative, which would be use clinical criteria to dictate which of those two locations the patient should receive their care. And I'll give some examples of what I mean by that in just a moment. Actually, I'll do it right now. So this is, I'm going to give 3 examples of conditions or diagnoses or rather procedures or diagnostic tests that people are getting rather routinely. Maybe some people in this room are familiar with this first one, a colonoscopy. And you can see the 2 sites of care. This is the same patient, the same procedure. The blue bar, the purple bar is an HOPD, so it's a hospital licensed GI center or an ASC in some cases. And the right-hand side is a community-based center that's not necessarily under the hospital license. You can see it's a rather significant price difference. Now, on the left-hand side of all these charts, you can see some of the clinical criteria that would necessitate a patient going in for a hospital procedure, hospital outpatient department, and I would argue it argues for a higher price. The patient is moderately or morbidly obese, has multiple comorbidities, has certain drug allergies. The community-based center will likely not touch them. They don't want the exposure, they don't want the liability, they don't have the additional resources to care for that patient should something happen. Another example here is in knee replacement. We do a growing number of knee and hip replacements in ambulatory surgery centers out in the community at a much lower price point, as you can see, than a knee replacement procedure done either in an HOPD. In some cases, they're still being done as an acute care patient in a hospital. What's the reasons why you choose one or the other? A patient has multiple comorbidities, maybe of advanced age. Patient has difficulty with anesthesia. There's probably a host of other ones. And again, that dictates where they should receive that particular procedure. And again, I would argue If they're on the hospital side, the hospital outpatient department side, it understandably should be at a higher price because of the resources that are required to care for them in that setting. And then finally, chest CT, a pretty standard procedure. You can see a rather significant price difference. And these are real numbers. These are not hospital charges. These are negotiated commercial rates with health plans right in Southern California. So you can see the difference there. But again, there's reasons, clinical reasons why a patient might need to have that procedure done in a hospital-based setting under an HOPD. So why are HOPDs more expensive? I've touched upon some of the reasons so far. I mean, the HOPDs, the community-based ambulatory sites, do many of the same procedures. Tests, procedures, et cetera, but they are structurally very, very different. One is the availability. I mean, hospitals have no choice but to be available 24 hours a day, 7 days a week, 365 days a year. That's an expense. They have a different regulatory burden than do the community-based ambulatory sites. The acuity of patients is usually significantly different between an HOPD and a community-based ambulatory site. Payer mix is as well. Community-based ambulatory sites don't necessarily have to receive all payers, and particularly if they have outside investors, they may choose not to receive all payers. And so where do those patients go? They go to the hospital because the hospital usually accepts all payers. So there are those differences. Another concern, and we're seeing this emerge even more and more, as patient care continues to migrate into ambulatory settings or outpatient settings by improvements in technology, improvements in clinical science. It allows tests and procedures that used to be routinely done only in an inpatient setting to be done now in an outpatient setting. 20 years ago, when I was CEO of one of our hospitals in Southern California, a knee replacement procedure was fairly routine to be done in the hospital, and it was a 4-day length of stay with a very prescribed series of things that happen to the patient each day. Now we're doing them in our ASCs. They arrive at 6, they're done by 8, they stand up at 1, they walk at 4, they go home at 6 p.m. Now, not all patients can do that, but that technology is allowing a lot more that we never imagined would be done in the ambulatory setting. How does that impact the hospital? A lot of physicians now, surgeons, anesthesiologists, radiologists, are saying, a lot of business out in the ambulatory setting. I'm needed out there. It's a different work environment. It's not 24/7, 365. It's many times 7 a.m. to 4 p.m., Monday through maybe Saturday. I'll choose that, and I'll relinquish my hospital privileges. So the population of physicians that are there to take mandated hospital physician on call for the emergency department, which is mandated by Title 22, is narrowing and narrowing and narrowing. They simply don't want to do it. And it's becoming quite costly for the hospitals, again, hence some of the costs that you see in the HOPDs. I did a quick poll in Orange County of hospitals, what they're paying mandated specialties for physicians to cover the ER, hospital by hospital, and the average was $1,000 per specialty per day. And that's regardless of whether or not they are called once a week or called a couple of times. If the physician bills, that's their money. So it's $1,000 a day out the door. Neurology is $2,000 a day. Anesthesia is $7,000 a day. $2.5 million for one specialty. And it's simply because they're very hard to get. And if you want them, because you have no choice but to have them, you have to pay for it. Also, the second bullet up there notes something that most people don't really think about. Because of the regulatory and compliance requirements of a hospital, the same piece of equipment being installed. Let's say it's a CT scanner. You can have it in an outpatient imaging center or a HOPD part of the hospital. That costs the same amount. But the installation cost and maintenance cost are sometimes twice as much as they are in the ambulatory setting because of all the regulatory environment that wraps around hospitals. So even those things you don't think much about cost more in that environment. Some of the barriers and challenges, question I get a lot is why have all health hospitals and health systems not developed such a robust ambulatory network and are moving patients to the right side of care as we have done now for the last number of years. A lot of health systems haven't invested in a robust network of community-based ambulatory sites. They've either chosen to invest in other areas or prioritize other investments within their health system. In fee-for-service contracts, One of the challenges, that's why you hear me harp on APMs so much, in fee-for-service contracts, the value that's created by investing in this network accrues to someone else. And so when I invested in ambulatory surgery centers and imaging centers, I spent money to joint venture those community-based centers and to integrate them with my health system in order to have my health system paid 75% less. So I spent money to cause myself to be reimbursed less, and that savings accrued to the health plan. I'll give you an example. I'm from Missouri. I apologize. It's a show me state, so we feel we need to give an example for everything. We were in a contract negotiation with one of California's largest health plans a few years ago, and it's a $250 million health plan for our health system, so it's not small. A year, $250 million a year, and we found ourselves at a stalemate, 1% off. I wanted a 4% increase in that year. They wanted to give me a 3%. We went to full-blown termination. I gathered the data, and this goes back a number of years before that health plan had any clinical criteria to determine where patients should go since they're in control of utilization. We had voluntarily moved patients to the right side of care. I could demonstrate to the penny that we'd saved them over $20 million in the prior year. We were fighting over $2.5 million. I shared that data with them. They had no idea. If they had no idea, they probably didn't pass that savings down to the employers and the consumers because it just got lost in the morass of an enormous health plan. That's an unfortunate thing in a fee-for-service climate. Those who invest in creating value sometimes aren't the recipients, if you will, of that value. The challenges of integrating medical records, patient records across the sites of care is a challenge. And then, as I mentioned earlier, some of the community-based ambulatory centers don't accept certain insurance coverages. I'll also mention that I've mentioned a number of times that health plans are developing clinical criteria to determine does the patient need to go to an HOPD for that outpatient procedure or to a community-based ambulatory site. It's been a rather slow uptake in health plans. I had an outside firm look at the 6 largest health plans in California across 5 clinical areas: outpatient surgery, imaging, physical therapy, occupational therapy, outpatient infusion, and radiation oncology. One health plan has published clinical criteria for roughly 65% of the outpatient activities. 3 have less than 50%, 2 have none at all. And so that the gatekeeper is not directing patients to where they need to be, and so that's something we could probably encourage so that patients get to the right side of care for the right care at the right price. And then finally, just really a final note to commend the Office of Healthcare Affordability's goal of increasing adoption of APMs because when we shift away from fee-for-service, and it will accelerate the right side of care once a substantial portion of a provider's reimbursement is in one of those HCP land categories, the higher level categories where providers are at real downside risk. So with that, I moved rather quickly because I know we're dozing off or getting bored or something. Questions that I can answer?
Yeah, for the committee, any questions?
Great job. Thank you. Well done.
It's my cheering committee.
I have a question. Go ahead.
Hector, please go ahead, Hector.
Okay. So thanks, very great presentation. Now, the model you're describing, it allowed you to use resources you had as a system. And one of the challenges that we have in the smaller practice is the cost of entry, right? The barriers of transformation of practice and outfitting with technology, et cetera. How many of the docs are employees of your medical foundation on the primary care and specialty side? And did that help to kind of move them quickly to this transformation?
So how you ask how many are employed?
Correct.
Yeah, so we have probably 375 primary care physicians that are employed by the health system, probably another 400 that are in a financially aligned IPA that are linked within the health system. And we share risk with those organizations. And so it was relatively easy that when we showed them the difference in the price point for them to move it to the right site of care. The challenge comes with the PPO patients and the other patients that come into the health system with independent physicians that we don't in any way control. They bring the business where they want to bring it, and that's why we tend to rely upon the health plans if they have clinical criteria to say that CT chest scan should go here versus here.
Great, thank you.
Sure.
Sorry, Joan Allen next, and then Carolyn Nava.
Actually, very similar question, but on the non-physician workforce. As we've seen sort of this model emerging with a lot of systems around the state, when I've talked with systems, as that joint venture ambulatory side is increasing, we've sometimes seen that be an overall expansion of the workforce, and we've sometimes seen it be a transition of the workforce out of the employed, whether it's the medical foundation side or the hospital side, into those joint ventures. Can you speak a little bit to sort of how big is that employed side of your workforce versus the JV side, and what has been that trend over the years?
So on the JV side, because the joint venture partner, like for example, SCA for ambulatory surgery, Fresenius for dialysis, RadNet for imaging, they're the managing partner. So they're the ones that hire the employees, and it's their benefits, it's their salary structure. They often complain that they need to keep up with the acute care hospital salary structures. They generally don't and probably can't. So when employees leave, interestingly, many times they're leaving the acute for the ambulatory, and it's not for money or benefits. It's for a different work style. And that's one of our biggest challenges.
So yeah, that's exactly the experience we've seen with other systems. And I do want to flag, as we're looking at the workforce stability standards, that's something we're going to continue to see playing out, and is yet one more of those things that we need to be tracking, is that movement where from the outside it kind of looks like an employee staying within the same system, but they're moving within different parts of the system. And is that still leaving enough workforce in the inpatient side, whether it's on the physicians or that you were talking about with really expensive call numbers, or the non-physician workforce. And so that's just one of those needing to get under the lid on the workforce stability issues.
Fair point.
Carolyn Nava.
I'm going to throw the monkey wrench.
Oh, that's all right. It's almost 5. It's time for a monkey wrench.
There you go.
Because cocktails will follow, so please.
First of all, I really think it's amazing what's been accomplished, and I see this network of care, which is phenomenal. My question is if you were to take that north of Sacramento, what recommendations could you bring to a rural community that might be applicable? Because I cannot immediately see a point of reference for these far north areas on accomplishing something like the cost savings you've accomplished here, because the network doesn't exist. So what could we walk away with that might encourage them to do something similar?
Well, I mean, to the degree that that rural hospital, for example, has expanded into the ambulatory, the alternative payment models, that's an incentive to actually build these lower cost sites, because then you can control the care and you can lower the cost of care. You raise a good point. It is admittedly considerably more difficult. These companies that I partnered with, not by design and frankly, not necessarily my preference, they're all publicly traded companies. And I'm guessing that there's probably not enough opportunities to build ASCs in those markets you're talking about, where a hospital could easily JV with them. Those assets aren't there.
And I think it's great. We're just finding, especially the farther north you go, the population is diminishing, number one, and population is often a driver of, like you said, these publicly traded entities moving in. It's just a concern that I felt like it was important to bring into the conversation, because we might wind up with this cookie cutter application over time, where we're going to find, like we have the food pockets of insecurity. We already have the care pockets of insecurity. And I'm just looking for solutions that I could bring back up north to say, hey, call Barry, get some pointers from Barry, get some pointers from all of these amazing professionals here on this committee. So I was curious if there were some thoughts that we could carry out that way.
It's certainly something that the health plans that serve that geography should take into consideration, because having these clinical criteria are lovely, but if you don't have enough of a network of a community-based ambulatory site, doesn't do much good.
Like right now, it's all partnership. They have taken over the entire north, and that's a huge concern when you're just relying on one managed care plan, then you've only got a certain cross-section of the care, the primary care physicians, the specialty clinics that are going to work with that particular plan. I feel like we're even more limited now than we were before.
Thank you.
Anthony Wright, and then Hector Flores, and then Adam Doherty.
Just a couple of questions, but let me limit them. The site neutral issue, I mean, there wasn't there. I mean, this is a live issue in DC. There's and you're talking about what I feel is an alternative to the proposals that are currently in debate, right? That it's not that. I don't know if is it that you don't think that there's an issue with site neutral, or that it's a different way to do it with regard to maybe a different mechanism to solve the issue of directing patients to certain venues to begin with, as opposed to just having to have a charge for patients that are going to, again, what I think you're acknowledging is not the right place, not right time, right place versus the not the right place.
Right setting, right, yeah.
Yeah.
So as to cost neutral, I referred to it as a blunt instrument. It's really not based in any clinical science. It's not based in any actuarial science. It was just a simple, quick solution that CMS chose. Mm-hmm. And unfortunately, they weren't given an alternative. Mm-hmm. And I must say, I spoke about that at a number of places across the country, saying, you're fighting a losing battle with just say no to site neutrality. Right. You need to recommend clinical criteria and let patients go where they really belong to be. I looked at our data set early on to see what percentage of patients in the early days were in an HOPD, in ASCs, and for surgery and for imaging. The patients that went there that didn't have a clinical reason to be there, they were referred there by the doctor or otherwise because it was convenient. I mean, understand, I'm not a doctor. You're doing 5 surgeries a day, 3 are inpatient, 2 are outpatient. It's pretty convenient to have them all done in the same location, and they're oblivious of the price difference. So in that data, in our data set, 78% of the patients that were at that time going to an HOPD didn't have clinical criteria reasons to be there. So it can be a significant shift. But I wish Medicare's not going back. They're going to stick with it. And the current discussion is, do they ungrandfather the grandfathered sites that they got pressured into grandfathering several years ago? That's really the only difference.
But you're acknowledging that there was a problem a problem before, and it just was that there might be a different solution that's appropriate. I appreciate that. And then just more broadly, you talked about the perverse incentive that you have to do incentives to get paid less. And I don't know if you have any just further thoughts about like how we can think about writing those wrong incentives.
Beating a dead horse, but a faster acceleration to alternative payment models mm-hmm. begins to eliminate those issues, because you are then incented to invest in these places because you're the one who's spending the money. And it's your money to control, and you've got a fixed pocket or fixed pot. Now it's going to take some time, and it's been taking a number of years already. I think we'll need, particularly for organizations like the ones that Carolyn had spoken of, if they're trying to move into alternative payment models, they probably don't have the monies to invest in the data systems and the care management systems and maybe non-mandatory network. They may need support. That may be somewhere where the state or some other entity needs to step in to give them assistance, because they won't be able to do that.
Thank you.
You bet.
All right, we see Hector Flores' hand, and then Adam Doherty.
Yeah, thanks again, Barry. Yeah, to your point, I think there will need to be an investment. The state is making an important first step with the Equity and Practice Transformation Fund. There was a study that the California Healthcare Foundation published in May of 2022 found that 56% of primary care visits for Medi-Cal patients were in private doctor offices, and the other 44% were in FQHCs and rural health centers and county facilities. And LA County is actually even bigger. The private doctor networks that serve LA Care, for example, provide almost 70% of the primary care visits, even though the FQHCs are pretty strong in LA County. And so the state recognizes there needs to be an investment, and I see it as a down payment on much more investment down the line. For the folks in rural communities, Adventist Health is doing a lot of work in rural health center model. They developed a string of about 20 rural health centers, which are operated as hospital outpatient facilities. So they get a facility fee at the same time that the docs are getting the PPS rate. The docs are actually employed by the Medical Foundation. So I think these are models that will continue to evolve, but by having the docs employed, it guarantees that they're going to stay there rather than just come in, do a loan repayment and leave. The facility fee allows Adventist Health to be able to support the structure of the practices that are needed and all the upgrades that come in. These are not necessarily in frontier counties, but I know that that's part of the Adventist Health plan. So it might be worthwhile to have a conversation with them about their long-term plans. Thanks.
Yeah.
Adam Doherty.
Barry, who staffs your EDs?
I'm sorry?
Who staffs your emergency departments?
Your group.
Pituity does?
Was that an advertisement? No.
I wasn't totally sure.
That's okay. Two of our hospitals, Pituity does, and the group has been there for 50 years.
I'm not aware of any specific examples, but are there any shared savings efforts from our side, any collaborative efforts to, things I think about are, reducing hospital, admissions, whether they're preventable or whether they're, innovative systems like, hospital at home or urgent MRIs for TIAs or mild CHF exacerbations that don't necessarily need a full hospital bed to be able to capture some of that, talking about incentives for, both of our groups essentially. And then also, on the back door, but, front door and the back door of the hospital, post-acute care, some of these things to be able to get people out of the hospital who don't need to be hospitalized.
I think all the above could be on the table. That's an area where I think the emergency physicians in the hospitals and the admitting medical groups could work more closely together. Observation days in hospitals are, in my opinion, grossly abused. That these patients that you don't know if they're an inpatient, they're not really sure if they're an outpatient. They can stay in a hospital bed under hospital nurse-to-patient ratios for 2 days, and they'd be paid as if they were an outpatient. It's being abused by the risk-bearing organizations. Hospital at home, big fan of, but that is, and I hate to say this, but it's an innovation in California that will not take root in any foreseeable future, except perhaps at Kaiser, because it's a closed system. And the challenge there, and again, this is not a criticism, it's just a fact, the nurse-to-patient ratios apply at home. And all the analyses that have supported hospital at home throughout the country don't use that same structure. I mean, neither good nor bad, it just is. And we were heading full-blown down the path of hospital at home, because to build a hospital bed in California is expensive. And I'd rather have them at home. And I know the seniors that we care for in South Orange County would rather be at home. And until I'm fully at risk, as Kaiser is, it can't make economic sense.
Barry Arbuckle, thank you so much
thank you.
for that segment. I think I'm going to turn to CJ Howard now.
Thanks, Barry. And this is just a quick comment on the out-of-pocket, out-of-plan spend. I know that you all want to stay here well past 5 o'clock. We're going to postpone that to our next meeting. We'll also couple it with a broader discussion around affordability and affordability metrics. And so I think it'll actually pair and couple nicely. So with that, I'll hand it back to our facilitator.
All right, at this time, we will move to public comment on both the last agenda item and general public comment for the day. So if you'd like to make a comment, please step to the podium. If you're attending online, please raise your hand. At this time, seeing no one in the room and no hands raised virtually, we'll give it a moment. That concludes public comment, and that adjourns our meeting. All right, thank you.